ఆయన తీసుకెళ్తారు. ఆయనే వెళ్ళాలి.
హుహుహు. మీ ఇంట్లోలు ఎంత ఇంకా అక్కడి నుంచి చేయాలి.
అక్కడే కంట్రోల్ చేస్తారు సార్. మనకి ఏ డిస్‌ప్లే వస్తుందో ఆ డిస్‌ప్లే మీరైతే
దీంతో అవుతుందా?
దీంతో
ఇది
మార్చుకోవచ్చు.
గ్రీన్.
గ్రీన్‌ది.
ఫార్వర్డ్ అండ్ బ్యాక్వర్డ్.
బ్యాక్‌వర్డ్ సార్.
ఇది
ఇది
ఇదా?
పాయింటర్ సార్.
ఓకే. ఓకే. థాంక్స్.
ఫస్ట్ మీరే సార్. మీ స్లైడ్ చూసుకుందాం ఒకసారి.
హ్మ్.
delegates to take their seats. To ensure an uninterrupted flow of academic discourse, please switch your mobile devices to silent mode. Thank you for your cooperation. To begin with the event, I request you all to kindly raise for the Mande Mataram. Thank you, everyone. A very good morning to our visionary chief patrons, members of the advisory board, core organizing committee, legendary guest faculty, and colleagues joining us from across Andhra Pradesh, Odisha, Chhattisgarh, and Tamil Nadu. Medicine is a profound journey that begins with a single fragile heartbeat and extends through the most complex physiological crisis a patient can face. For many, that path begins with a precise routine clinical intervention. For some, it leads to the life restoring possibility of an organ transplant. Today, under the banner of M7 Hills Hospital, we gather at this prestigious Dr. Baba Sahib Ambedkar Auditorium to explore that entire continuum of care. Welcome to Precision and Pulse 2026. Today's conclave stands as a testament to quaternary care excellence, offering two APMC CME credit hours of elite medical discourse. At this point, I would like to formally acknowledge the forces behind this scientific feast. Our chief patrons, Dr. Prashant Rajagopalan and Dr. Urjita Rajagopalan, managing directors of MGM Healthcare. A massive thank you to our organizing chairman, the veteran senior interventional cardiologist, Dr. K. Damodar Rao, along with a brilliant scientific committee for seamlessly engineering this massive multidisciplinary platform. To kick off our scientific proceedings, we shall open the first session, the Precision Cardiology Suite. This session will dissect the meticulous mechanisms of coronary intervention and advanced intravascular imaging. To steer this discussion, it is my absolute privilege to invite our esteemed session moderators to the dais. Please put your hands together for Dr. Damodar Rao sir, Dr. M.N. Raju sir, Dr. Ankita Kulkarni ma'am. Thank you, doctors. May I now invite Dr. Bhaskar Rao sir, who will speak on high-risk PCI in ACS, navigating the complexities in contemporary practice. Over to the bench.
Respected chairpersons, man behind this wonderful CME, Padmanabhan sir, our cluster head, senior colleagues and friends. Today we are very happy that we are going to discourse on one of the most wanted territories of medicine, that is organ transplant, cardiac transplantation, followed by many other transplants, which is going to follow the small starters, cardiac interventions. Now, I will be discussing about probably the most important clinical condition in the sense that acute coronary syndromes are the number one killer globally. India also, males, females, urban, rural, everywhere, the number one killer in India and abroad. It's acute coronary syndromes. So I will come to this slide a little later. Now, what are acute coronary syndromes? We know that heart is the most important organ supplying blood to all the organs, but cardiac muscle is supplied by coronary arteries. When there is an obstruction in the coronary arteries, acute, then that clinical picture is dramatic and it has life-threatening consequences. That's the reason why it's so urgent. So acute coronary syndromes, coronary arteries are faced with blockage in the coronary arteries with a clot. If it is complete, Then in ECG, generally we see ST elevation. If it is a little incomplete, then the ST elevations are not seen in ECG. So that's how it is generally classified. ST elevation MI, you can see here, you can see the whole lumen of the coronary artery is completely blocked. Whereas in the non-ST elevation acute coronary syndrome clinical conditions, there is a partial clot partially obstructing the lumen. So there are important clinical connotations between the two. And again, in the acute coronary syndromes, if there is a damage to the cardiac muscle, the cardiac enzymes will be elevated in the blood, like troponin, CPK, LDH, and all. So that's how that condition we call it as myocardial infarction. So if there is an associated ST elevation in the ECG, it's ST elevation MI, and there is no ST elevation in the ECG, then it is non-ST elevation MI. And there is no ECG ST elevation and there is no elevation of cardiac enzymes, then it's not an MI, it is unstable angina. Now coming here, in acute coronary syndrome, the most important objective is to establish the blood flow to the myocardium, coronary blood flow. Generally, there are two ways of doing it. One is by intervention, non-surgical or surgical intervention. The other is pharmacological. So the pharmacological means is by giving thrombolytic therapy. We all know that. But studies have clearly shown long ago that directly taking the patient to the cath lab, doing a coronary angiography and opening the culprit vessel, infarct-related artery, gives the best possible clinical results when it is done as early as possible. We'll come to that a little later. Now, do I'm sorry. In doing that, there can be many complexities. Doing an angiogram and then identifying the obstructing lesion and then opening it with a balloon and putting a stent is called percutaneous coronary intervention. And many other subsets are there in that. But when we do that, when we are doing that, there are certain clinical, anatomical, angiographic findings which increase the risk and increase the complexity of the procedure. So there are many complexities, like for example, you see a patient who has a cardiogenic shock, patient who has renal insufficiency, patient who has severe LV dysfunction. These are all clinical contexts where the procedure has more associated risk and the complexity increases. Similarly, when you do the angiography, if there is more than one vessel which is diseased, then the complexity increases. Similarly, if there is a significant calcium deposition around this lesion, then the dilatation of the lesion could be very difficult, and then it may require many other interventions like calcium modifying techniques, or the patient has cardiogenic shock to support the cardiac muscle and then the improve the hemodynamics. We may have to use several other interventions like mechanical circulatory supports. There are several mechanical supports. So these all things, they increase the complexity of the percutaneous interventions. Now, let us talk about STEMI, ST elevation MI, where the cardiac myocardium is faced with the complete blockage of the blood supply. In that case, there are several clinical scenarios in which percutaneous intervention can be done. One is, the best thing is that open the artery as fast as possible. Now, here there are several clinical subsets. We'll again go to that. So there are three different clinical setups where you can do an angiography. Initial first medical contact, the patient comes, you see ECG, there is an ST elevation MI. Immediately the patient directly goes to the center like tertiary care center where PCI facilities are there. In that case, the best is to take the patient to the cath lab, do angiography, open the artery. That is called primary PCA. But suppose the patient comes to the peripheral hospital, say for example, 100 kilometers, 200 kilometers from a PCA suitable center, then the patient may receive thrombolytic therapy. The thrombolytic therapy, if it is unsuccessful, patient continues to have chest pain or ST segment changes, then the patient should be as fast as possible referred to a center which is capable of doing percutaneous interventions. That is called rescue PCA. Consider rescue PCA. Similarly, nowadays, studies have clearly shown that even after successful thrombolytic therapy, patient's chest pain comes down, ST changes improve. Even those clinical conditions, it is found that shifting the patient to a PCA capable center and doing a coronary angioplasty of the culprit vessel, infarct related vessel, yields better results. But generally, that is done between 3 hours to 24 hours after the successful thrombolytic therapy is done. So, this is the same different clinical scenarios. As I said, the patient chest pain is there. If there is a good ambulance, the ambulance can do an ECG within 10 minutes. See, the time interval that should be taken between the onset of symptom, patient medical contact and then an ECG, it should be less than 10 minutes. And nowadays, it's very easy to contact a cardiologist by, other groups, WhatsApp groups like that. Give a ring, see the ECG. If the ST elevation is there or tall T waves are there, you suspect that the patient is likely to develop ST elevation MI, and then immediately decide what the patient should be doing. If he comes to the hospital of PCI, take him to the cath lab and do primary PCI. If the patient goes to a peripheral center, if the patient can be transferred immediately to a PCA capable center within 90 minutes and the procedure can be done, then ship the patient, say for example, Gajuaka, to some other hospital, either KIMS or MGM or CARE or whatever, Apollo, or whichever center. If it is within 90 minutes, then ship the patient there. Don't do anything after giving, loading doses of antiplatelets and so on. For example, if the patient goes to a far off place, if the thrombolytic therapy is available, it cannot be shifted to a center and the PCA can be done within 120 minutes. The upper limit is 120 minutes. Then subject the patient if there are no contraindications for thrombolytic therapy. So this is the flow chart basically. What about non-ST elevation acute coronary syndrome? That patient, generally primary PCI is not recommended in such conditions, but such patients should be evaluated for the risk profile. Say, for example, patient has ventricular arrhythmias, patient has continuing chest pain, patient has left ventricular dysfunction. Such patients, they are categorized as high risk. So you stratify the risk profile of the non-ST elevation coronary syndromes and then categorize them low risk, intermediate risk, high risk, very high risk. So obviously, high risk patients should be subjected to coronary angiography and PCI if possible. Low risk subjects can get some time. So let us see in the next slide how it should be. Very high risk or unstable patients, they should be treated just like ST elevation MI. Immediately shift the patient to the cath lab and then, see where is the culprit vessel and then open the artery. High risk patients are different from very high risk. Very high risk is that shock is there, recurrent ventricular arrhythmias, continuous chest pain. High risk patients are score is high or there is persistent elevation of cardiac enzymes, ST changes are persisting. Such patients, it is better to do in the same day within 24 hours. Intermediate risk, slightly lesser risk score. Ischemic symptoms are continuing but hemodynamically stable. Such patients should be subjected to intervention before hospital discharge. Whereas low risk individuals, you subject them for, you know, treadmill test or, dopamine echocardiography, stress the test to see the further risk profile. And if the test the risk profile is suggestive of patient having a significant disease, then the patient can undergo coronary angiography and PCA. It's very any procedure is very important when not to do. When I was doing my DM course, my professor always used to say that you should know when not to do things. For example, the patient with PCI, you put a stent, the antiplatelets have to be given minimum of 12 months, at least 6 months. So such patients, If they have a bleeding tendency, say for example, severe thrombocytopenia is there, hemophilia is there, such kind of patients, you have to be very, very careful before subjecting for PCA because they require dual antiplatelets and then it can increase the bleeding. Similarly, severe kidney disease, grade 4, stage 4 kidney disease or stage 3, the patient is not undergoing regular hemodialysis, then they should be very, very cautious. Acute renal failure, and if the patient is having advanced malignancy, very limited life expectancy, such patients also should not be subjected to PCA. Or patient you already have seen, done an angiography, he is waiting for bypass surgery, such patients also should not be undergoing PCA. Now, what about multivessel coronary artery disease? See, we have already discussed that primary PCA is the best. The infarct related artery should be opened, but you are faced with a situation like here. You see, here the right coronary artery is completely occluded. Patient has an inferior MI. It's very, very important that you open this artery to improve the life expectancy. You open the artery, primary PCA is done successfully, and you also have disease in the left coronary artery system. So, do you subject the patient for PCI now on the left side also or not? So, such conditions, if the patient is stable, it is always advisable. If the patient is hemodynamically stable, that procedure can be done after successful opening of the infarct related artery. However, if the patient is in cardiogenic shock, hemodynamically unstable, and such individuals, only the infarct related artery has to be opened, and the other arteries can be opened later once the patient becomes stable. Similarly, with non ST elevation MI also, the culprit vessel is opened, and if the patient is stable, other vessels also can be attempted, but not in the cardiogenic shock. Now, which patients should not undergo PCI but they require bypass surgery? If there is a significant left main coronary artery disease, which is the beginning of the major left sided artery, and complex vessel disease, such patients should undergo CABG surgery in non ST elevation MI, not in ST elevation MI. ST elevation MI always open the culprit vessel. Or diabetic patients with severe multivalvular disease and LAD involvement, complex left main with left ventricular dysfunction, such patients should undergo electively a CABG surgery unless they are not fit for surgery. Now, as I said, one of the important complexities in a PCI is that the coronary artery is having good amount of calcium around the lesion. What happens to the calcium is when you dilate the artery, the calcium restricts the dilatation of the vessel. The balloon stent implantation will be suboptimal. In such cases, the results are generally suboptimal and then reblocks, what we call as stent thrombosis, is very common. In such conditions, now we have the luxury of modifying the calcium in the lesion with a few devices. There are some balloons also which we cannot use generally in acute coronary syndrome, but in acute coronary syndrome, we can have the benefit of having two types of devices. You can see here, so this is a balloon, and this dark, hard structure is calcium across the lesion. It doesn't really allow the balloon to expand. In such cases, we can use what is called as an atherectomy, as a rotational atherectomy or biorbital ectomy. It's basically a device which rotates very fast, 140,000 to 180,000 revolutions per minute, so that it drills through the calcium. The rotational atherectomy drills forwards, whereas orbital atherectomy can drill forward and backward. You can understand when you're drilling the calcium, what happens to all the powder that comes out. So there is a small chance that such kind of debris can collect in the vessel and go forward and occlude the vessel distally. So sometimes the risk in acute coronary syndrome with rotational atherectomy is that you may get a no reflow. Your vessel is opened, stent is placed, but the blood flow may not be there because of the debris occluding. Such conditions, a safer technique is intravascular lithotripsy, in which sonic waves from the balloon, they disrupt the calcium. They break open the calcium so that the stent implantation is possible easily. Now, how to know? How is the lesion? How much calcium is there? What is the extent in the lesion? We have the luxury of having coronary imaging. You can, inside the coronary arteries, you can visualize what kind of lesion it is. Like, for example, intravascular ultrasound, which uses, you know, ultrasonic waves, and optical coherence tomography, which is also used in some of the ophthalmic conditions. So these two are appropriate. You can see some of these images. You see here, there is a thrombus inside the artery, which is clearly visible with intravascular optimal coherence tomography. And after giving medication to dissolve the clot, you can see later it is completely clear. We have not put a stent here. So optical coherence tomography and intravascular ultrasound can help us decide what kind of treatment can be done to the patient with acute coronary syndromes. Sometimes they're not, I mean, you have must have heard about something called uh, myocardial infarction with non-obstructive coronary artery disease. So there is no atherosclerotic disease. There are certain conditions like spontaneous coronary artery dissection, just like aortic dissection, or microvascular disease. The main vessels are normal. In such conditions, stent placement is not necessary, and you require other kinds of treatment. So these kind of intracoronary imaging can help us decide what kind of coronary artery disease. There more of imaging, and then more of calcium modification will be dealt with by our colleagues, Dr. Sirisha and Dr. Harita. Now, what about in cardiogenic shock? I already said in cardiogenic shock, it should be absolutely necessary to open the artery in ST elevation MI, but non-culprit vessels, non-infarct related vessels should not be attempted at that site. And some of the patients with cardiogenic shock or severe LV dysfunction, you have a basic, problem of maintaining the sustainability of the patient. In such cases, we can take help of mechanical circulatory, systems where they help us maintain the circulatory state by protecting the cardiac muscle. Some of them are like, for example, intra-aortic balloon pump, where there is a long balloon which is kept in the aorta, descending aorta below the aortic valve, so that the balloon expands and then, deflates rhythmically. In diastole, it expands so that it pushes more blood into the coronary arteries in the diastole. And in the systole, when the left ventricle has to pump, collapses so that the afterload is reduced. That is intra-aortic balloon pump. There are some other, helping devices like microaxial intravascular pumps. For example, some of the pumps can be put inside the left ventricle, and then the left ventricular blood can be pumped mechanically out of the left ventricle, giving rest to the left ventricle. And of course, ECMO is very well known to you, VA ECMO, and ultimately many other left ventricular assist devices are there, which can be used in cardiogenic shock in patients with acute coronary syndromes with mechanical complications like mitral regurgitation and so on. Similarly, in patient with cardiac arrest, if the patient has a cardiac arrest, revived ST elevation MI, even if the patient is comatose, they should be subjected for PCI, but not in other patients. What about the thrombus in the left, coronary arteries? If the thrombus is significant, there are devices called thrombosuction devices which can aspirate thrombus, but they have not shown to be, improving the mortality in many trials. But many Asian countries, especially Japan and India, where the other kind of devices are not there, the thrombectomy devices, thrombus aspiration devices are still being used to reduce the thrombus load. And of course, all patients with acute coronary syndrome should take dual antiplatelet treatment with aspirin and ticagrelor or prasugrel while patients are going for PCI, and otherwise ticagrelor alone. When patients are not able to tolerate ticagrelor or prasugrel, then only clopidogrel should be added to the aspirin. Cangrelor is an intravenous antiplatelet agent, P2Y12 inhibitor, which is given before PCI when patient is not on antiplatelets to increase the duration of antiplatelet efficacy, transient only. As I said, the thrombus aspiration is not found very useful in acute coronary syndromes in improving the mortality, but there are other intravenous antiplatelet agents like glycoprotein 2B and 3A inhibitors, which can be given during PCI to dissolve the clot. They are very useful in PCI to reducing the thrombus burden and stent implantation and improving the blood flow. I will conclude with an example of one recent patient came to us. We put a stent about 5 years ago in the LAD, and the patient has stopped taking medication for the last 5 days and then came to the emergency with severe cardiogenic shock, left ventricular dysfunction, anterior MI, and a complete heart block with a heart rate of 20 and diabetic ketoacidosis. You can see how the stent is blocked here. I will just conclude with this. See, you can see here there is a stent which is completely blocked at the origin in the left anterior descending artery. Blood is not flowing through. Here, what we have done is we put a temporary pacemaker for the complete heart block. We did an angiography and then we passed the wire through the occluded artery. And here we can see that the balloon inflation is done. And now see the final result. The artery, which is occluded earlier, has been completely opened. The patient is still on temporary pacemaker, and the LV function improved and the blood pressure improved with all these immediate measures that are being taken. So that is how actually the primary ECA is very, very helpful in acute coronary syndromes. Of course, we have to risk stratify the patient. And as I said, time is muscle. You can see that every 10 minutes delay after 60 minutes of acute MI increases the death by 3 to 4 people for every 100 people of MI. And after 6 hours, no, the mortality rate can go up to 85%. That's why any suspicion of acute myocardial infarction, my dear colleagues, the first important thing is get an ECG within 10 minutes after first medical contact. See, send the patient ECG to a cardiologist if it is an ST elevation MI, primary PCI. If it is not ST elevation MI, also send the patient as early as possible to a tertiary care so that the primary PCI or whatever intervention is required can be done. Thank you very much.
Sir, thank you for such a insightful session. Any question and answers, audience? You may raise your hand. The mics are there with our volunteers. Any question and answers on this session?
Thank you, Dr. for your illustrative lecture. Intervention in the ACS gives a immense pleasure to cardiologists and highest benefit to the patient because we save the muscle as much as we can. There are very few centers which can offer the imaging, but image guided PCI is always better, even in setting up acute MI. That is the most important thing. But if rare situations where cardiogenic shock and where you need a MCS, mechanical circulatory support, very few centers can support that mechanical circulatory support. Very happy to say that we have mechanical circulatory support, including ABP and ECMO. So this is very few centers have this one. So we can save a lot of patients with cardiogenic shock, even though the mortality rate is very high. This is open for a questionnaire. Anyone?
Any questions?
Then we pass on to the next session.
Thank you, sir, for this wonderful masterclass. I now request our next speaker, Dr. Sirisha K, interventional cardiologist specializing in non-invasive imaging, diagnostics, and optimization of PCI protocols via IVUS OCT, to present on Beyond the Angiogram, IVUS and OCT guided PCI, why it's the new standard.
Oh, very good morning to one and all. Coronary angioplasties have been taking place since 1970s. Since then, a lot of advances were developed in the field of cardiology. So we've moved from the balloon dilatation era to the bare metal stent era to the drug-eluting stent era. In spite of so many advances, less than 10%, almost 10% of the PCIs which are taking place every year worldwide come due to instant restenosis. What could be the cause? Let's find out. This is the basic coronary angiographic view showing the normal coronary arteries. So this is the left main coronary artery dividing into left anterior descending and left circumflex and its branches. This is the right coronary artery. So a normal coronary angiogram gives a 2D view. Though we see it in different angles, it does not give any info in 3D direction. Look at this image. This patient has been suffering from breast angina. But when we look at the angiographic view, this lesion looks quite innocent, maybe 50, at max 60%. But why is she complaining of significant angina? We don't know. In this case scenario, we're seeing the blood vessel quite clearly, even before we give an injection. It's calcium. Is the calcium superficial or is it deep? What kind of tool am I supposed to use? In this situation, there is some haziness in the left anterior descending artery. What's the reason for the haziness? Is it a thrombus? Is it a dissection? Don't know. And here, after stent implantation, there is a little haziness proximal to the stent. Is it really due to dissection? Or is it just a small blood vessel passing through and causing an artifact? What's the reason? Because coronary angiogram, depending on the view, we can either overestimate it or underestimate the lesion. it doesn't give any info regarding the level of the fibrocalcific plaque, what kind of calcification it is. I'm not saying it doesn't give completely, but the amount of information it gives is not very, it's not sufficient. So, in order to combat all of these, IVI, intravascular imaging, was developed. There are two main modalities, as Sir was saying: IVUS, intravascular ultrasound, which uses ultrasound waves as the main source, and OCT, an optical coherence tomography, which uses near infrared rays as a source. So coming to the timeline, these IVI have been there since the last 1980s. Since then, they've undergone a lot of trials and a lot of research and were ultimately put in the guidelines. So IVI is mainly useful in assessing the lesion before we implant the stent. The length of the lesion, how much calcium is there, how much lipid-rich break is there, how to prepare accordingly, how to make the bed before we implant the stent. We can also assess if there are any complications after implantation. Do we need to intervene or go for conservative management? So this is how a normal artery in IVUS looks like. A normal artery has got a lumen, an intima, media, and an adventitia. So the media is the one which we pick up as soon as we see the IVUS image. This black ring is the media. It's echolucent. So the one inside it is the intima, the one outside it is the adventitia. OCT gives a very well-defined images. It's got superior resolution. So we not only see those three structures, we see the internal elastic lamina and the external elastic lamina on either side of the media. So these are the various plaque morphologies we come across in IVI. As you can see here, in IVUS, since there are sound waves, the calcium blocks the sound waves. So behind the calcium, which is looking quite eco-dense, there's a lot of shadowing. So we can't see the structures behind it. Whereas OCT, on the other hand, we can clearly see the heterogeneous nature of the calcium. We can measure the density. Depending upon the different types of calcification, we use different tools to break it. The calcium close to the lumen is called superficial. The one away from the lumen is called deep. So based on the type of calcium, we use different calcium debulking tools, the details of which are going to be explained in the next session by Dr. Harita. So this here is a 360-degree calcium. Once it's cracked, proper bed is made and we implanted a stent. There's still yet to do balloon dilatation. So it's not complete yet, but look at the level of cracks it's made. So everything's done. We have to assess whether the stent implantation is precise or not. Did we do a good job? This is how a fully expanded struts and all look like in IVI. It looks like a ring with equally spaced struts. As you can see here, there is a significant distance between the stent struts and the intima, so which indicates the stent is malopposed. Here, it looks quite crumpled. It's under expansion. Some amount of the tissue is seen protruding. This is tissue protrusion. And here, though you cannot see the stent, it's at the edge of the stent. It's as if the vessel was sliced. It's dissection. So the advantage of OCT is that there's a beautiful 3D reconstruction view. So you can go into the vessel, see where the wire is going, and act accordingly. So in case of instant restenosis, these are the different morphologies. These are technical characteristics of OCT and ultrasound. To shorten it, Mainly OCT, yes, it offers a very good resolution, but the penetration is less. So we cannot use it in big sized vessels. It doesn't offer much information. When it comes to the media, the light is the main source for it. So the RBC, they tend to scatter it. So you need to clear the blood before you get a clear image. So it requires contrast media, which becomes a drawback if you need to use it in patients with renal dysfunction. In such situations, IVUS is the imaging mode of choice. So enough with the theoretical aspect. Let's go to the interesting part, which is the case scenarios. So if you're wondering how we do an IVUS guided PCI, this is how we do it. This here is the IVUS console. We're looking at the lesion while we're doing live. And based on these, we make the decisions. This man is a 73-year-old male, hypertensive, diabetic, with hypothyroid state. His creatinine is 1.3, so he's having some amount of renal dysfunction. He presented with NET elevation, myocardial infarction. In spite of that, his LV function was well preserved. When we did an angio, there are calcified vessels, triple vessel disease. Mainly the left anterior descending artery is the revascularization vessel for choice. So this is the ECG showing NS and STEMI. These are the echo findings, well contracting segments, good LV function. So what kind of tool do we use in this patient? Obviously, it's IVUS since he's having renal dysfunction. We don't want to compromise his kidneys, right? This is here is a calcified lesion, very tight. It's very difficult to manipulate. We managed to wire it, but when we wanted to dilate it with a balloon, even the smallest amount of balloon couldn't go through. So what do we do? Shall we abort the mission and say bye? No, we have another tool which helps us in drilling it. So we drilled it with a rotablator device. This is a rotational blood doing rotablation. So by using this rotational atherectomy device, you were able to open up the vessel to a certain extent and pass the IVUS catheter. So once we passed the catheter, we were able to see the IVUS images. We wanted to know whether the calcium is sufficiently cracked or not. So these are the white regions which showed significant cracks in the calcium. We measured the tightest portion of the lesion and did balloon dilatation from distal to proximal, placed two stents, did an IVUS run again. We were quite happy with the result. So this is how the stent struts look like. Well opposed vessel, well expanded. So once we took the measures, we came out. This is how the vessel looked like post procedure. So it's quite like it's a very good result as far as I can say. The vessel that looked like this after stenting like that. So this is the various images we obtain. If you're wondering how we do the rotablation, this is the way in which we manipulate it from the outside. So we drill it using the hands this way, and it's performing the rotablation. This is the burr that went in. So left main coronary artery supplies almost two-thirds to three-fourths of blood supply to the heart. When there is a tight lesion in that, what do we do? It's a challenge. What do we do when there is calcification? This person is a 75-year-old male, hypertensive CKD patient presented with acute coronary syndrome and moderate LV dysfunction. He had a very calcified 70% osteal lesion in the left main coronary artery. Surprisingly, his other arteries were okay. This is the lesion. We were not even able to place the catheter in. The moment we placed the catheter, his blood pressure started falling to 60, 70 systolic. So the entire procedure was done with the catheter hanging from outside the vessel. So it couldn't, we used a cutting balloon for this. This is how a cutting balloon makes tiny slices using blades. This is how it looks like from the outside. So these tiny cuts are made using these blades. So once that is done, we were able to pass the IVUS catheter, record the images, and place a stent, redo the IVUS run, and we came out. This is the level of the lesion. This is how tight it is. This is after the procedure. So till now, I've been talking about IVUS, how useful it is in placing the stents in stent implantation. What about decision making? This is a 70-year-old male patient who's hypertensive, presented with anterior wall MI. He had RWMA in the L-Dairy territory with mild LV dysfunction, 45% EF. When we did an angio, he had double vessel disease, left anterior descending artery, which is the culprit vessel, and also in the obtuse marginal artery, which is a branch of the left circumflex. This is his ECG, suggestive of anterior wall MI. So now, when we did the angio and found out and did an IVUS guided PCI to the LAD, we were not very sure about the OM lesion. In some angles, we're not finding it as significance. In some, it's more significant. So we decided to do an IVUS run to it as well. When we did the IVUS run, what we found quite surprised us because majority of the vessel looks absolutely normal, except for that short area. But even in that area, the percentage of plaque is less. So went in for conservative management. This is how his echo looked like after stent implantation. This is the modern way of checking the ejection fraction. 17 segments were assessed individually, and this patient ejection fraction improved to 63%. Now, coming to OCT guided PCI, this is actually an interesting case which took us all by surprise. She's a 56-year-old female, hypertensive, diabetic, hypothyroid, presented with unstable angina, left bundle branch block, good LV function. When we did an angio, there was a lesion in the left anterior descending artery. But surprisingly, the lesion was not found to be very significant in the routine angio. So we did an OCT run to see what's happening inside the vessel. What we found is, as you can see here, there are branches going up and down. This segment is very tight, which we missed in a normal angio because of the branches, it's being overlapped. It's because of that discrete tight lesion. She's been having angina even on maximal anti-anginal drugs. So obviously, we went ahead and did stent implantation. Even after the stenting, that tiny segment had under expansion. So we dilated it with a balloon. We were quite happy in a normal angio. So we did an OCT run. What we found here is that region is still under expanded. So we post dilated it with a higher size balloon going to higher pressure. Once we're happy with the result, we did an OCT run and we could see a well dilated vessel with proper stent expansion. So this is the lesion before, this is the lesion after. This is the various images we've taken. This is a 60-year-old male without any comorbidities, but he presented with anterior wall STEMI, thrombolized with tenecteplase elsewhere. He came to us with mild LV dysfunction. When we did an angio, we saw a significant lesion in the left anterior descending artery. This is his ECG outside showing significant ST elevations before thrombolysis. As you can see here, there's a significant lesion in the left anterior descending artery, which is looking less significant in certain angles, which is quite significant in others. So we decided to do an OCT. So when we did that, this area showed very narrowed vessel with a thrombus and ulceration, but luckily there's not much calcium. So it's a soft plaque. So this is the thrombus with an ulcer, which is a little scary. So we placed the stent, happy with the result. So thought of doing a IVUS run post procedure and come out. But when we did the IVUS run, what surprised us is this area. The proximal part was relatively less expanded. There is under expansion. So we did a balloon dilatation. The repeat OCT showed well expanded stent. So what I'd like to say is that it is because of this OCT, we were able to do direct stenting for this, to do a direct stent placement for this patient without balloon dilatation. And because of this OCT, we were able to make out the proximal under expansion, which would have been missed if it would have been a normal angiographic picture. The patient would have come back with instant restenosis at some point of time. So the lesion before, the lesion after. So IVI have a class 1A indication for complex coronary interventions, both in acute and chronic coronary syndromes. So in spite of so many benefits with the intravascular imaging techniques, less than 15% of the PCIs are using IVI. So they're very much underutilized. So the what I'd like to stress on is IVI is necessary while doing certain coronary interventions, especially in complex coronary interventions, left main, chronic total occlusion, instant stenosis, whenever there's an anatomy doubt in MINOCA and spontaneous coronary artery dissections. Thank you. I'm open for questions.
Audience, any questions? Moderators?
Conventional angio is a two-dimensional picture, and unfortunately, basic pathology lies in the vessel wall. Conventional angio gives you the contour of the endothelial surface, but unless we know the basic pathology, atherosclerotic plaque, and the morphology of the atherosclerotic plaque, we cannot prepare the blood properly, and we cannot decide the tools what we need, especially in situations like calcium related plaque. So image guided PCI is always better, and I think a day will come. Nowadays, we are not doing floral tab without ultrasound guidance. I think a day will come we should do PCI under image guidance only. Any questions from the audience? We'll pass on to the next.
Yes, sir, it's got good resolution, but it does have its own drawbacks. Whenever there is renal dysfunction, we use contrast. We try to use saline in place of it, but the quality of the images may not be so good. The penetration is less, so in bigger size vessels like left main coronary artery, in those structures, it may be difficult. Like the images may not be as clear as in IVUS if we use a bigger size lumen vessel because the penetration is less. Thank you.
Thank you for providing such incredible insights into intravascular imaging, ma'am. Moving forward, I now invite Dr. Harita Ma'am, interventional cardiologist specializing in modern intravascular coronary imaging and calcium modification modalities, to present a section on cracking the stone, advanced coronary calcium modification techniques. Welcome, ma'am.
Good morning, everyone. Today I'm going to talk about coronary calcium modification techniques. With these advanced coronary calcium modification techniques, we cardiologists have come a long way from calcified nightmares to successful PCI outcomes in heavily calcified lesions. So let's see why coronary calcium matters. So more number of means more number of PCIs are done in elderly, so is the increase in calcified lesions. More than 30% of PCIs are done in calcified lesions. So the risk factors which cause heavily calcified lesions like uncontrolled diabetes, dyslipidemia, and chronic kidney disease are increasing day by day. Uh, Patients with complex coronary disease are increasingly opting minimally invasive PCI over surgery. So calcium predicts procedural difficulty and directly influences the device selection. So let's see why calcium is our enemy. 3 to 5% of stent failures are attributed to underlying calcium. So more we see more number of uncrossable lesions or difficult to cross lesions in heavily calcified lesions. So the incidences of calcium prevents stent expansion and it causes stent malapposition and stent under expansion, which causes future instant restenosis and stent thrombosis. There is an increased dissection rate during PCI in heavily calcified lesion. So the key principle is to modify calcium before stenting and not after. So let's see how we grade and score calcium. So first and foremost, basic calcium grading is done by fluoroscopy, that is during angiogram. It is divided into mild, moderate, and severe based on the radio opacity seen during angiogram. it is classified into mild when the radio opacities are seen only on contrast injection. We call it as mild classification. See in the first image. Sorry. See in the first image during the without contrast injection there is no calcium, but after contrast injection you can see mild calcium here. So we classify it as moderate calcification when the calcium is seen without contrast on only one side of artery and during systolic phase. So we classify it as severe calcification when calcium is seen without contrast, both in systole and diastole, and on both sides of arteries like tram track lines. We classify it as severe calcification. This is very basic grading during angiogram. Then comes the advanced grading with use of IOS and OCT. So the calcium is graded into four grades according to the calcium arc, means how much arc it is occupying. So when the arc is less than 90 degrees, it is mild calcification. When it is 90 to 80 degrees, is moderate calcification. When it is from 180 degrees to 270 degrees, is grade 3 calcification. And when the arc is more than 270, it is classified as very severe calcification. So on OCT actually is a more advanced form of imaging because the thickness can be measured only by OCT, not by any other. Even IVS cannot measure the thickness of calcification. So we follow rule of fives in OCT calcium scoring. So first comes the calcium arc. If it is, we give 0 points when it is less than 90 degrees, 1 point if it is 90 to 180, and more than 180, we give 2 points. And calcium thickness, as I said, only OCT can measure the thickness of calcium. When it is less than zero point 0.5 mm, we give 0 points. And if it is more than 0.5 mm, we give 1.5. And then comes the calcium length. If it is less than 5 mm, it is 0, and more than 5 mm, it is 1. So if the score is 0 to 2 after doing OCT, a non-compliant simple balloon dilatation may be sufficient. When the score is 3 to 4, advanced calcium modification is required. So this is how the different calcium morphologies are seen on IVS and OCT. See, we call calcium as deep when it is nearer to the adventitia, and beyond the adventitia we cannot see. This is the acoustic shadow. In IVS we cannot see the structures post calcium. And in when it is nearer to the adventitia, it is deep calcium. When it is nearer to the lumen, it is superficial calcium. When there are reflections or reverberations, it is thin calcium. When we cannot see past the calcium, it is thick calcium. Anyway, OCT measures directly that whether it is thick or thin. So this calcified nodule, here we can see a protruding mass-like structure with a calcified border. The in both OCT and IVS. So I when we uh, based on IVS how we score as it is severe calcification, we give each point for circumferential calcium. If the length of calcium is more than 5 mm, if the vessel diameter is less than 3.5 mm, and there is a calcific nodule, we give each point to each one. If the score is more than or equal to 2, advanced therapy is indicated. So let's see, like, what are all the platforms we use when we modify the calcium. It is broadly classified into two classification: non-atherectomy devices and atherectomy devices. Non-atherectomy devices are like OP and high pressure balloons, scoring balloons, cutting balloons, and intravascular lithotripsy comes under non-atherectomy devices. And atherectomy devices are rotational atherectomy, orbital atherectomy, and excimer laser coronary atherectomy. Uh, I'm not going to concentrate on orbital atherectomy and ELCA because they're rarely used. So they have different, these six platforms have different mechanisms or different indications. So based on OCT calcium morphology, when it is superficial calcium, rotational atherectomy is preferred. When it is deep calcium, intravascular lithotripsy is preferred. In nodular calcium, the IVL is preferred. It flattens the nodule. Actually, in nodular calcium, orbital atherectomy works best. And we should avoid cutting balloon in nodular calcification because there is a trapping risk. So in eccentric calcium, we can use IVL or cutting balloon and scoring balloon, depending whether it is depending on the thickness. And when it is concentric, that is arc is more than 180 degrees, the best tool is rotational atherectomy. So we usually follow this algorithm before selecting which coronary calcium modification is to be selected. So first we see whether it is balloon crossable or not. If it is yes, we predilate the lesion and then we do OCT or IVUS. As I said, OCT is more advanced than IVUS because it measures the thickness. So if it is severe, that means if the arc is more than 180, length is more than 5, and thickness is more than 0.5 mm, it is categorized as severe calcification. If these three are there, yes, it is a deep calcium. Yes, if it is yes, then we see whether it is deep calcium or superficial. That means whether it is near to the adventitia or near to the lumen. If if yes, we use a intravascular lithotripsy. If no, we go for rotational atherectomy or orbital atherectomy. And if the calcium is not severe, we just dilate with a non-compliant balloon or a Kettering balloon or scoring balloon, and we see whether there is an optimal balloon expansion or not. So if the balloon is not crossable, so what we do? We cross with a microcatheter. We see whether microcatheter is can be crossable or not. So if we could pass the microcatheter, we use a rotational atherectomy or orbital atherectomy. No, even the microcatheter is also not passing through the lesion. We rarely do direct wiring with the rotawire or wiper wire. For rotawire is for rotational atherectomy and the wiper wire is for orbital atherectomy. If even the wire is also not passed, then we use excimer laser coronary atherectomy. Then we see the optimal balloon expansion. If it is good, we go for stenting. If not, we use intravascular lithotripsy. So after stenting, we again do a imaging with OCT or IVUS and see for stent malapposition and stent enter expansion. And the post dilatation can be done first with non-compliant balloon or with OP and high pressure balloon or lithotripsy balloon also. So let's discuss with detail in detail uh, but the calcium modification techniques what we use generally. So coming first and foremost is OPN balloon. Actually, this balloon got a burst pressure of 35 to 45 atmospheres. Usually, the balloons which we use with non-calcified lesions, the burst pressure is around 20 to 22. This balloon got a high pressure, high rated burst pressure. It is 35 to 40 atmospheres. We inflate the balloon in heavily calcified lesions with that pressure, and that causes cracks in the calcium. And so the we choose as 1:1 ratio. Like if the either reference vessel diameter and the scoring balloon should be 1:1. Then comes the scoring balloon. We See, this is a scoring balloon. The first image is a scoring balloon. And 9 wires are scored along the balloon and it helps scoring the calcium. And then the second image is the cutting balloon. These are blades, blades which cuts the calcium. This is usually used in osteal lesions and instant restenosis, fibrocalcific disease, or when scoring balloon is failed. So this is trial evidence showing this ISAR CALC trail proved that scoring balloon is equivalent to OPN balloon, and it's a first line approach for moderate calcification. And cutting balloon significantly reduces restenosis rates in ISR. It was proved in STING trial. So I'll show you a case example where the cutting balloon is used and the fractures are seen on OCT. So this is the clinical history of 67-year-old male, non-diabetic and hypertension. Upon routine checkup, found to have CT calcium score of 738. His ECG was normal and 2D echo showed no regional wall motion abnormality with normal LV function. So this is his angiogram. See, the angiogram is showing ostial 90%, ostial OM 90% and LCX 90% and LAD is 30%. So when OCT run was done in both OM to LCX and in LCX, and it showed a fibrocalcific clot and the minimal lumen area to be 2.2 mm square. So a cutting balloon of 3.5 into 10 mm is used, and the post OCT run showed calcium fractures, and the minimal lumen area increased from 2.25 to 4.0. So then DES is placed both in LCX and OM, and final phylum kissing balloon was done, and this is the final result. So coming to the next calcium modification technique, it is intravascular lithotripsy. So the mechanism is the electrical energy vaporizes the saline contrast mixture and produces high pressure shock waves. It causes fracture in deep calcium. Usually IVL is preferred when the calcium is deep. So this is how it works. This is heavily calcified lesion, and then we deliver. First, we predilate the lesion, and then the IVL balloon is placed at the lesion, and these are the sonic pressure shock waves which comes at 200 atmospheres. And this is and after doing IVL, there is an increased compliance of vessel, and the spinal stent will be placed. So these are the trials proved a procedural success rate in after IVL. So I'll tell an example of IVL. A case scenario of a 72-year-old male patient came with complaints of angina since 2 months. He's hypertensive and diabetic since 15 years. ECG is normal and 2D echo. There is no RWM and it's good LV function. Uh, so this is his angio, as you can see here. There is a LM distal 90%, 90 to 95% lesion, and ostium LAD 90% lesion, which was heavily calcified. So we went with an IVL balloon of 120 pulses. It's a long lesion, so we used 120 pulses IVL, and I'll show you the pre. This is the images on IVUS, which we did before IVL. So the minimal luminal area came to be around 2.05 mm square, and at LM it is 7.38 mm square. And this is the IVUS run. See, these white colored patches, which are echo dense, are calcium. It is almost more than 270-degree calcium. And this is a fibrocalcific clot, and there is a calcium nodule protruding into the lumen. Um, this complete area is calcified and fibrocalcific lesion. And after doing IVUS, we went with IVL balloon. So the post IVL result, see, you can see the calcium cracks here. These are the calcium cracks. These are the calcium cracks after IVL, intravascular lithotripsy. So this is the result after doing IVL and after stent placement. And see, this was the tightest portion which came around which was 2.05 square before IVL, and it increased to 5.93 square after IVL and stenting, and the LM increased from 7.8 to 10 square. So coming to the last, sorry, I'm going to take another 5 minutes. And coming to the last calcium modification technique, this is rotational atherectomy. Rotational atherectomy is like it works on a differential cutting. So it preferably ablates the inelastic calcium and leaves behind the elastic tissue. It's like a regular shaving machine, like it just shaves the hair and leaves the skin unarmed. The same principle is like rotational atherectomy also. It works on differential cutting. So it consists of a diamond shaped bud which rotates at 1,40,000 to 1,80,000 RPMs and cuts the calcium and breaks the calcium into 5 micrometers of diameter, and it is cleared from the blood circulation by the reticuloendothelial system. So, what are the tips while using the rota? So, use an extra support for tortured lesions and first predilate the lesion with semi-compliant balloon if wire crosses. Then give an adequate amount of vasodilator cocktail, and uh, temporary pacemaker is to be kept ready for RCR dominant LCX, and upgrade wire if deceleration persists, and consider MCS for low IF or complex disease. I am going to skip these contraindications and complication, and I'm going to the case scenario. This is a 55-year-old female came with complaints of chest pain since 20 days. She's a non-diabetic since 10 years. ECG showed ST depressions in precordial leads, and echo showed no RWM and good LV function. And this is the angio showing this is a heavily calcified lesion at the ostial LAD, osteoproximal LAD. So after OCT, you can see the ostial LAD is just 1.7 The minimal luminal area of ostial LAD is just 1. After we pre-dilated with non-confident. If a dog boning effect is seen, that means it is heavily calcified. So we did a, it should be a SOTA ablation runs of OCT were done, and the ostial LNG minimal luminal area was increased. LM to LAD stenting stent to ostial. Minimal stent area is 7.6. 7.6 after reanimation. So the taking image first modified before stenting, not after. Combine techniques when needed and be ready for complications. Be ready with the mechanical circulatory support and cover stent on standby for heavily calcified lesions. Thank you.
Then an increase of incidence of your proper
Yes, sir.
coronary calcium scoring is being done now.
Yes,
It is
yes, sir.
more than 400, some patients even 2,000.
Yes, 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 yes. Because of increased risk factors, sir, like uncontrolled diabetes is very increased, and dyslipidemia is very increased. Because would differ in that because nowadays patients are go to the endocrinologist and take the treatment for the diabetes. Yes, yes. For diabetes. Okay. That's why. So now it is being dissected better actually. With the imaging and OCT, the heavily calcified lesions are dissected better. It's dissected. So it was like it's previously every it was heavily the complex heavily saturated complex formally used to be referred to CABG. Now the patients are choosing minimally specific over surgery. So now advanced such lesions to see whether we
Those are
can
better.
benefit. I cannot tell which one is this. Always the first step line is CABG. But if we go with the patient's choice and some are unfit for surgery, then those patients will do CPI even if it is a second line. Yeah, I can understand. Even patients feel also here, like even if they say the go for CABG and all, they're afraid like they cut open and go vascular invasive. By the time they go for minimally invasive PCI where they can be discharged in 3 days. Thank you.
That was such a nice question. Thank you, ma'am.
Mhm. Yes.
Typically, calcified lesions are
Okay.
so we'll be going to the next question.
Full session. We now transit the new eyes of cardiology. For this panel, Dr. Sirisha ma'am and Dr. Sarkar. Application.
Basically divided the talk into two. I will speak on that. So From morning, we are seeing the calcium from inside. Now we are going to see the same calcium from out. So before we analyze the vessel lumen, or before we calculate the first simple question, whether the atherosclerosis has started or not. So to answer that simple question, the first line of investigation is the pulmonary calcium score, by which we can see different calcium quality start. Starting with pulmonary timeline, before the international calcium score, grading of the cardiovascular risk. So the calcium score was invented way back in 1998 or cardiovascular. How to calculate the calcium score? How the market use that so that we can reproduce that in the every day. So these are the traditional risk factors which are calculated before the score. That is the farming risk score, the score with the criteria based on the cholesterol, etc. Based on this traditional risk factors, we evaluate the patient into low risk intermediate risk development of coronary in the 5 years. So first low risk, there is no right. I they should definitely give a preventive treatment. But question arises in many cases whether the treatment is started or not. So for these cases, the calcium score comes into play. So the advantages of in calcium score is the significant risk factor. That is, the calcium score itself is the presence of coronary arteries, provided other risk factors are so we can reclassify the intermediate risk high risk so that we can divide the intermediate group down very for upgrade. So that's for the software. So balance for our calculation is really difficult to for diabetes we can go start the 40 years and this time we can start as early as 35 years for the family history. Yeah, we can do a protein calculation in intermediate risk group. So we calculate the score is on the best score. And we give the thought that what then is that if the patient on 40 years years has a post-coronary calcium score of 90. So most are the same calcium score, but the patient has very high risk of calcium. So we compare the calcium score with the percentile. So if the patient is 90%, compared to the top history, 90% of individuals have less calcium score compared to the other. So next, this is how we do the calcium. The first is the study claim study. We can see the calcium. The second is the making calculate automatically the calcium in this time. So all the bone calcium levels we can calculate in LED LCS. We give different color coding. This is calculated. So these are for which we calculate the again percentage like 50% of the transfer percentage or 90%. So next is we categorize based on the score of the thing. So 0 to 1000, greater than 1000 is extended, that's the 400 is small. So starting at with our first phase, and and female with families of CAD, who is asymptomatic, has undergone a CT training, just scan for the non-cardiac chest training. So identified a small plate of calcium within the pulmonary abscess. It is turned out to be positive. So changes the entire conversation. The presence of calcium without any symptomatic patient even indicate the presence of. So this is the calcium score of the patient. Same patient with family history. His age is 40 years. Here is the dense type of calcium in the proximal LAD, which categorized into the score is 39, and he is falls in the category of 93rd percentile. So this low or intermediate risk patient now is categorized into a high risk individual depending on only on the calcium score. So he should be started on the preventive treatment. So this case, I will continue in the CT coronary angiogram method. The same thing. So another case is that we treat your male patient who comes with I mean, he has all the intermediate traditional risk factors, so he is categorized into intermediate risk. So we have done a calcium score to know the risk of the coronary event. So calcium score turned out to be negative. So even although risk factors are positive, he has no atherosclerosis started in his coronary artery. So that is the power of calcium score. And that is the power of zero calcium score is that he has very low risk of developing a coronary event in coming 3 to 5 years, provided the risk factors are same. So he has very less than 1% risk of coronary events in the 5 years if his calcium score is zero. So when to report a coronary calcium score? If the patient has a zero calcium score now, we can repeat the calcium score after 3 to 5 years, provided the risk factors are same. And if even if the calcium score is less than 100, we can repeat after 3 to 5 years. But greater than 100 calcium score is positive, then there is no use of repeating, and we can go directly to the other modalities like CT coronary angiogram for the follow-up. So when not to advise the coronary calcium score is that we have a patient of already known case of CAD, so there is no diagnostic value of coronary calcium score. So, and the presence of stent falsely labeled here. This stent is falsely labeled as calcium in this image. So, presence of stents or post CABG, we don't require a calcium or in a symptomatic treatment. So, this is the online calculator which we use along with the traditional risk factors in calculating the calcium score percentile. Example, this patient has 6 male white, and uh, we enter the calcium score here and we get a percentile comparison. So these are the scores which we follow. The Gaston score is widely accepted score which we give in our reports. Next, the coming is the volume score. The Gaston score uses the area and the density. So this is like a 2D calculation, and the volume score adds the depth as well, the slice thickness. That is it's the 3D. So for comparison or reproducibility, the volume score is better rather than the Gaston score. So if the patient has two calcium scores, we want to compare the two calcium scores 3 years apart. So we better compare the volume score rather than the Gaston score. The next is the density score, which is taken consideration into the Gaston as well as the volume score for the calculation of the density factor. So this is the recent and continued about the density score. That is, if the patient has of the same age groups have same Agatston score of come under the same percentile. So in between those patients, we can compare with the density score. So the density score calculates the how dense the calcium of the patient is. The more the dense the calcium is, the more stable plaque it is. So the higher the density score, the less risk of the situation. So coming to the next topic, coronary angiogram is a non-invasive. We require contrast, we require preparation for this. And it's not a last line diagnostic modality now. It is the first line diagnostic modality for stable chest pain. So it can diagnose the coronary artery disease or it can rule out the coronary artery disease. We can assess the plaque morphology. So these are all the indications of the chest pain. Indications of the central coronary angiogram for the stable chest pain. And unclear test results like unclear nuclear results or positive TMB. An acute chest pain now is being used triple rollout scan in acute cases to rule out coronary pulmonary embolism as well as the aortic resection. And the CCTA is the best for the evaluation of the bypass graft. It's almost 100% sensitive in detecting stenosis or occlusions of the graft. And also first line modality in investigation of the bypass. And next is the stent assessment, which is a technically difficult part of the CCTA. We evaluate the instant stenosis or the instant of universe. Next is the coronary anomalies, which can be detected PCTA as it is best for the anatomy. So next is the pre-surgical planning for complex cases. So preparing the patient for the CCTA. The first is the medical history review. Go into the details. So first is the medical history review. We review the history of the allergies of the herniated contrast or the venous. Next is heart rate operating. Heart rate should be less than 65 beats. This is prerequisite for the coronary angiogram. So for this, we use the super blocker. Heart rate keep the methodology and please can wide on the water. So these are the patient right then. On that side, usually is that it's based on the weight up to 600 plus contact is used. So this contact that we do very high. It follows the this also watch the contact on the right side so that we can so at the entire scan of fragment which within the 30 seconds. So what takes the meter of the three scan this is what we use. We make it able to very good speed the remaining so that is any other one. This is how a post-mortem looks like. This is the planner. There is a left main one giving rise to LED, L6 as well as Ramus we can see this. And the next is this is the right RCA coming from the right cusp. Next, what we interpret is the stenosis assessment. We grade the stenosis into mild, moderate, and so greater than 50% is significant stenosis. And we assess the plaque morphology for high risk as well as if it is a calcified or non-calcified plaque. And the next is the functional assessment which we now doing the FFRCT for hemodynamic significance. So coming to the case one, our first case is we have seen this one asymptomatic individual, young patient with family history of CAD who has a positive calcium score. So he underwent a coronary angiogram to rule out the soft plaques. So we can see this is the LAD of the patient. There are no plaques and the lumen is good. There is only a small density of calcium here causing the minimal stenosis. Rest of all the vessels are normal. So this patient has only few recals with plaques and no soft plaques are there. So he was advised on high statins based on his calcium score. So next case highlights that not all coronary ischemias are due to the coronary atherosclerotic disease. So this is where CCTA plays a role in identifying the anatomy. This patient of a 60-year-old male has a undergone routine health checkup. His TMT was positive and every other test was normal. So what is the cause of the TMT positive? We have done a CT coronary angiogram where we can see there is an anomalous RCA which is arising from the left cusp, which should be arising from the right. This is the normal one, and this is abnormal RCA which is arising from the uh, uh, left cusp. So the course of the entire artery changes. Now the RCA is traveling in between the major vessels, that is the aorta and the pulmonary artery. So during the exercise, the vessel compresses, the aorta bulges and the vessel compresses. So this is one of the causes of the sudden cardiac death. So here he is of 60 years male. So the next slide also indicate the same. So you can see the slit like RCA here. This is a slit like which is being compressed between the right RVOT and the aorta. So in these patients, the CCTA not only diagnosed it, but we prevented the patient from sudden cardiac death. So this patient goes directly to the cardiothoracic surgeon. He requires a unroofing or reimplantation of the artery. So next case uh, takes us to the intersection between cardiology and the orthopedic surgery. So this patient about to undergo a total knee transplant. She was cleared for the knee transplant, but she has already known case of CAD. So she was evaluated at the CT coronary angiogram. So what we on a closer look, this patient has a uh, small narrowing here, some significant narrowing here caused by the soft plaque and that of the small spotty calcification in RC. So these are the characters of the high risk plaque. This continuation of the plaque where we can see this is the plaque of very low density that indicating that it has a lipid rich core which is about or very high risk of rupture. And here is a small spotty calcification which is another feature of this high risk plaque indicating that it is an active inflammation going on in the leg. So, so this patient require a coronary intervention before going into the major surgeries. So this patient's knee can wait, but coronary should be intervened. So these are other features of the high risk plaque, which we spoke about the spotty calcification and the napkin ring sign to the low density of the plaque. The peripheral rim of the plaque enhances, and this gives a napkin ring sign in an is the positive remodeling. Another one, the where the vessel accommodates the plaque by expanding the lumen. So if we see from the inside, the lumen will be normal and there is no stenosis here. But actually there is a high risk plaque here within the wall. This is known as the positive remodeling, which is a feature of the high risk plaque. So next case highlights about the how CCTF involves in the stent lumen analysis. So here, 53-year-old male patient with stent evaluation has a chest pain. So we evaluated for any interest and stenosis or uh, any occlusions are there. This here we can see the stent in the proximal LAD, which shows normal lumen, wide lumen. There is no evidence of occlusions or interest and stenosis. So we should evaluate this patient for any other type of other causes of chest pain rather than cardiac. So this is a technically difficult for us for evaluation of the stents, um, because the stents, mechanical struts of the stent cause blooming artifacts, which really give false stenosis. So the strut thickness as well as the stent diameter um, is very useful, or the stent lumen should be minimum 2.5 to 3 to consider the CCTA to be a diagnostic for evaluation of the stent. And our next case was about the myocardial bridging. This patient was turned out to be TMT positive, which we evaluated with CT coronary angiogram has this myocardial bridging, which during the systole of the scan, we can see that there is a minimal compression here, and there is depth is greater than 3 and the length of the segment is 25 So out of 100 CCTAs, we can see 25% of the patients have myocardial bridging. So whether it's significant or not, we can evaluate whether the lumen is compressed or not. So as this patient is asymptomatic, this patient was kept on the medical treatment. So this is the follow-up case of the same case showing the myocardial bridging, the myocardium, which will the cases present or last cases are on the post-CABG assessment where CCTA play a major role. So coming to the first case, here the patient has lost all his details about CABG. So we don't know which I mean bypass graphs he has or what is the status of these graphs. So we have done a CT coronary angiogram showing this is the patent arterial graft, prima and LAD graft. So this is the venous graft, SVG pediatric. Based on the anatomy. First, arterial graft, there is the prima LAD or prima LAD which are placed along the arterial graft, which is the graft is wide, then that is growing nicely and with distal obfuscation as well. Continuation, this patient has two grafts are patent and one graft is occluded. We can see a small nipple-like projection here, which is occluded SVG graft. So this patient can be reassured that his two grafts are very patent and good. In next case, again, young patient with family history of CAD already underwent a CABG. We want to know the status of the graft. So here we can see the arterial graft, which is lima already, which is patent and with the distal flow. But here there is also another arterial graft, which is occluded in the middle. It is the rima pedia graft, which is occluded in the middle. So the next, the same patient, we have all the venous grafts of these patients are occluded. We can see the nipple-like projections here and the rest of the vegetation on film. So these are all the occluded CG grafts. So based on this, we can guide the roadmap. We can give the roadmap for the patient. So what to be done next, the strategy of PCA or re-CABG. So this is another case, recent case where the patient has post-CA with 15 years and it has came for evaluation of the graphs. So this is a patent lima LAD graft. He has patent SVGOM graft, and also there is a SVG PDA graft. So in closer evaluation, the lima LAD was normal, and there is a occluded two graphs which seen as nipple-like projections here. And the next, on the physiology. Now we go into the CT FFR, where we can see the physiology. Even before going to the FFR, we can plan which lesion is significant, and we can do the PCA for that. So if they have The upper one is a significant lesion where there is indicated in the red color less than 0.6. That is, there is this lesion is causing significant drop in the pressure. That is hemodynamic changes in the distal arteries. So this should be treated first. And there is also another moderate stenosis, but this lesion is not causing significant hemodynamic changes here. So we can wait. So coming to the summary, so when to do a calcium score, when to not do a calcium score. So have it, sir. Acute chest pain, very high calcium score with reduced sensitivity, and during and also arrhythmias and thank you. So we'll be moving like with the same imaging bridge discussion. We'll be going ahead with the cardiac MRI, which will be presented by Dr. Sirisha. Yes, sir.
A patient of 70 years old with a coronary calcium score more than 300. He has no complaints, either chest pain or breathlessness. Do you advise coronary angiogram in this case?
Uh, it depends on the symptoms, sir. If he has symptoms and
No symptoms, no chest pain, no breathlessness.
if calcium score, we'll calculate the percentile, sir. If for the 70-year-old, we'll calculate percentile.
It is 70 percentile, 50 percentile.
Even then, I think for the age, we can do a CT coronary angiogram because the calcium score does not rule out the soft tissue plaques. So presence of calcium indicates some atherosclerosis is there. So we have to rule out a soft tissue component. So we should do a CCTA.
Oh, thank you.
So please use mic.
Let us not be under the impression that calcium determines the outcomes in young Indians, especially many people die prematurely at the age of 40 or 50. So if a patient has a risk factor or a patient has a positive family history of CAD, even if the calcium score is zero, would you like to look for vulnerable plaques or not?
Uh, I already said, sir, that calcium score does not rule out soft tissue plaques. So we have to undergo do if he is a high risk patient or intermediate risk with family history, we should definitely undergo a CCTA.
That is what I'm telling. The take home message is don't underestimate the coronary artery disease in a young patient, especially when they're vulnerable, like family history or multiple comorbidities. Calcium does not alone determine the presence or the severity of underlying atherosclerosis. Unfortunately, we have seen patients with calcium zero also having subsequent coronary events and dying also. We have reported some cases also.
That is especially true in patients younger than 40, because our country, coronary heart is more prevalent compared to other, Western.
So where Indians may not show much calcium, unlike Western counterparts.
Even in Western population also, the calcium score under zero, zero does not rule out a coronary heart, because calcium score zero in an elderly patient is different from a calcium score zero in an younger individual. The coronary heart disease prevalence in calcium score zero is more in younger ages compared to the people who are older.
All other studies 10 years back, the journals have reported, don't underestimate coronary artery disease in Asians, especially South Asians, only by calcium score.
Coming to the other question, that the higher calcium score, basically it also helps us to risk stratify. Nowadays, the risk stratification includes calcium score also. Whether lipid lowering therapy should be given, how much, what is the intensity, moderate intensity or high intensity. In people who are not atherosclerotic cardiovascular disease, calcium score also helps.
But are you reporting routine high plaque characteristics? Because I have not seen CT angiogram reports reporting high plaque characteristics, vulnerable plaques, especially the so-called NAP ring appearance, spotty calcification, fat attenuation index. All these are not reported, especially in our part of the country.
No, sir, they are being reported. We use the cataracts modifier HRP. We'll add HRP for high risk plaque.
Next, you can start next.
So I'm going to present a case scenario where we did a cardiac MRI. Patient was admitted with heart failure. A 62-year-old male patient came with complaints of class 4 breathlessness and chest pain since 15 days. His vitals were stable. There were bilateral creps and respiratory examination. ECG showed Q waves in precordial leads, and 2D echo showed LV, regional wall motion abnormality in anterior segments with severe LV dysfunction of 25%, and there is an RV dysfunction also. So he was admitted for heart failure with reduced ejection fraction management. After medical stabilization, coronary angiogram was done. Coronary angiogram showed triple vessel disease where LAD was Austin CTO, which was retrogradely being filled by heterocollaterals from RCA. LCX mildly diseased, and RAMS proximal was 90% stenosed, and RCA from proximal to mid long segment diffuse 90 to 94% stenosis was there. So what's the plan? Whether to keep in medical management, whether to send patient for CAPG, or whether to stent it. So these are the angiographic slides. See, there is LED is from Ostium, there is TTO. We cannot see the LED from the starting, but it is being filled retrogradely from the collaterals, heterocollaterals from the RCA. So there is some 90 to 80% block in ramus, and RCA is diffusely diseased from proximal to mid and in the distal part. So what's the plan? For the plan, whether to send for CAPG to check for viability, we have sent the case for cardiac MRI. Cardiac MRI will be explained by Pam.
So, so now, hello. Yes. Yes, sir. Yeah. So we'll be pausing this session, and now we'll be going ahead with inauguration of the event. Over to the anchors.
So let's moving on to the inauguration. So ladies and gentlemen, we have arrived at this historical pinnacle of today's conclave, the grand inauguration and vision 2026. So today we witness the official launch of this multidisciplinary transplant program at MGM Seven Hills Hospital, cementing its place as this emerging epicenter for transplants in Andhra Pradesh. So, to greet this occasion, it is an absolute honor to me to invite a highly revered advisory board group and a leadership tier to the stage. So, I would like to invite first Dr. our very own Chief Cluster Operating Officer, Shri S.P. Padmanabhan sir, onto the dais. We welcome you, sir.
AV.
I now invite our APMC observer, Dr. Maladi Subramaniam Sharma, professor in pathology and pioneer in regenerative medicine. Welcome, sir.
Next, I would like to invite Dr. K. Rambabu, Head of Jeevandan Andhra Pradesh and Professor of Medicine, Unit Head, WIMS, and State Coordinator for Organ Sharing. We welcome you, sir.
I invite Dr. MVV Murli Mohan, sir, highly active clinical leader and Secretary of Indian Medical Association, Visakhapatnam. Welcome, sir.
Next, I would like to invite our highly respected pulmonology academician, HOD, and Superintendent at Government Hospital for Chest and Communicable Diseases, Dr. Sunil Kumar, sir, onto the dais. Thank you. We welcome you, sir.
We would like to invite our organizing chairman, Dr. Damodar sir, highly revered veteran senior interventional cardiologist based in Visakhapatnam. We welcome you, sir.
Now I request all the dignitaries to light the lamp.
We invite our beloved Padmanabhan sir to deliver a key.
Good day to the distinguished faculty, esteemed clinicians, and dear colleagues. It gives me very immense and great pleasure to welcome all of you on behalf of MGM family to this continuous medical education program, Precision Pulse 2026, focused on transplantation medicine and surgery. Transplantation represents one of the most remarkable achievements in modern healthcare. It's a field where science, surgical excellence, multidisciplinary teamwork, and human compassion come together to offer patients a second chance at life. Every successful transplant is not merely a medical milestone, it's a story of hope restored, families reunited, and lives transformed. In today's healthcare scenario, the world is witnessing rapid advancement in transplant science, immunology, organ preservation, donor management, and bone transplant care. In such dynamic environment, continuous learning and knowledge sharing becomes very, very essential. CME programs like this, what is happening today, provide an invaluable platform for experts and practitioners to exchange experiences, discuss emerging evidence, and collectively raise the standard of patient care. I would like to acknowledge and thank our distinguished faculty members who have generously agreed to share their expertise and insights. Their contributions for sure will undoubtedly enrich our outstanding as an understanding and inspire meaningful discussion throughout the day. It is an unprecedented consolidation of medical talent MGM 7 Hills has brought together the country's leading transplant pioneers under one roof to handle complex organ restorations. As an institution, MGM Healthcare remain committed to supporting excellence in clinical care, education, research, and innovation. We believe that strengthening transplant programs requires not only advanced medical capabilities, but also collaborations across specialties, robust infrastructure, and unwavering focus on patient care. We sincerely encourage all the participants to actively engage in the sessions, ask questions, share perspectives, and more important, make the most of this opportunity for professional growth and networking. MGM Seven Hills is completely gearing up to uniquely position ourselves the definitive quaternary care hub for patients across Andhra Pradesh, Odisha, and Chhattisgarh. By deploying cutting edge infrastructure and aligning world class clinical expertise, the hospital removes the geographic and financial burden on families who previously had to travel to distant Tier 1 metros for life. I wish the CME Precision and Pulse 2026 a very great success and hope the deliberations today contribute meaningfully to advancing transplant care and improving outcomes for the patients and communities we serve. Once again, I personally, on behalf of MGM family, thank all of you and wish a very productive, enriching academic session and a great learning experience. Thank you very much.
We'll continue our previous session on cardiac imaging. I welcome Dr. Sirisha ma'am to present on cardiac MRI. We welcome you, ma'am.
So I'm going to continue the first case, which is sent for the cardiac viability assessment. So this is the first case. The first set of images are plain images where we can see the uh, this is the sagittal view of two chambers, left ventricle and right ventricle. This is the myocardium, left ventricular myocardium. The second set of images are early contrast, and the third set is late gadolinium or late phase of the contrast. It is post 10 or 20 minutes after the contrast. So in the first set of images, we can see the uh, left ventricular thickness, and we compare that with of the early enhancement. So this is the early enhancement which is homogeneous, which is taken up by the LV myocardium here. You can see this become the bright, and later on the myocardium contrast washes out and becomes black color. So this black myocardium is the normal myocardium, and which enhances in the late stage. This is the abnormal myocardium, that is the scar tissue. So what the concept of late gadolinium enhancement is that uh, the ischemia, necrosis, or fibrotic tissue, there is increase in extracellular volume rather than the myocytes. So the contrast goes into this extracellular volume, and which gets delayed in clearance. So in comparison with the normal myocardium, the washout in these abnormal areas gets delayed. So it becomes bright. So what is bright in late gadolinium enhancement is abnormal. So here we can, so we grade the enhancement as this LG late gadolinium enhancement. So we term it as if it is enhancing subendocardial or transmural or epicardial or patchy, depending on the types of enhancement. So we differentiate this LG enhancement like ischemic and non-ischemic. So there is a ischemic pattern of enhancement where there is first is a subendocardial, and it is involving more than 50% of the myocardium. Here it is almost transmural, involving entire myocardium. So this is ischemic pattern of the late gadolinium enhancement where it starts subendocardial and involves the entire myocardium. So this is the LV myocardium. This is the normal black myocardium. This is abnormal myocardium towards septum inferior and also the anterior walls, and involving entire apex. So entire LAD and RCA territories are ischemic and non-viable. So the first set of are the bright blood images, the X-ray images. Here we see the wall motion abnormalities as seen in that of the 2D echo. So here we can see the normal contracting lateral wall, and there is hypokinesis of the septal as well as the apical wall. The same, this is the axial one. and this is the sagittal. The same here, there's hypokinesis of the inferior wall as well. So the LAD and the RCA territories, there is subendocardial and transmural enhancement. Here we can see the enhancement. So we compare with both these images. So these hypokinetic segments, which are has the transmural or subendocardial enhancement, we consider them as ischemic territories. So we more than 50% transmurality, we consider them as non-viable. Less than 50%, there is a chance for recovering the myocardium. So this case, so based on the cine images, we calculate the ejection fraction as well. There is LV systolic dysfunction. The ejection fraction was 34%. We also calculate RV ejection fraction is dilated LV, increased EDP. And so all these diameters we can calculate on the cine images. So based on the wall thickness and wall motion abnormality and LGU, so we give for all the 17 segments. This is the example of LV myocardium basal region segments. We give as anterior segment 6.6 mm thickness of LV myocardium. There is mild hypokinesis. There is no late gadolinium enhancement. So this is a hibernating myocardium. And the next one is severe hypokinesis, subendocardial 75%. This is a non-viable myocardium. And again, severe hypokinesis, subendocardial 75% non-viable. Severe hypokinesis, transmural, non-viable. So we give this for all the 17 segments. So these are the volumes we calculated. LV and diastolic systolic ejection fraction is 34%, and diastolic myocardial mass is about 101 grams per each patient. Case one conclusion. So these segments, this pink color is the LAD territory, this is the RCA territory, this is the lateral wall is the L6 territory. So for this patient, these all segments are non-viable segments. This anterior and septal wall. So the both are LAD and RCA territories rendered non-viable in this MRI. So we calculate the amount of non-viable myocardium based on the contrast late gadolinium enhancement. So for this patient, there is 54% of the LV myocardium is rendered ischemic. Coming to the case 2, which is to be presented by Dr. Sirish, I will explain the cardiac MRI finding. So this so these are cine images of a sagittal. This patient has 60-year-old, and she has a very thick myocardium, which we calculated. There is no wall motion abnormality in this cine images, and we calculated the LV myocardium thickness. These are the plots of the LV myocardium thickness. We can see almost the symmetrical myocardial thickening more than 15 mm, going up to the areas 18 mm. So in case of hypertrophic cardiomyopathy. So we have done a contrast scan. So these are, as seen in the previous case, this is the T1 plane and early contrast and late gadolinium enhancement. Here the late gadolinium enhancement is used to differentiate the pattern of enhancement in ischemic and non-ischemic A. So this pattern of enhancement here, this patient has a non-ischemic pattern that is not a subendocardial or not involving coronary artery territories. So this is the enhancement in this patient. This is mid-myocardial enhancement involving the lateral wall, as well as patchy enhancement where we can see at the contact of the right and left ventricles. This is classical for hypertrophic cardiomyopathy in late gadolinium enhancement. In early enhancement, there are no focal areas of abnormalities. So next we calculated the percentage of enhancement which is used for the treatment strategy. So this is the total myocardial volume and the enhanced mass, enhanced volume rate coming to about 4%. So less than 10% for this patient. So the ejection fraction is about 70%. So in conclusion, this classical example of the hypertrophic cardiomyopathy, which is non-obstructive phenotype, and there is diffuse left ventricular hypertrophy. The late gadolinium enhancement also indicate the non-ischemic pattern, which is the characteristic of the hypertrophic cardiomyopathy. So the enhancement myocardial mass is about 4%, that is, which is abnormal or fibrotic tissue, is about 4% that of the healthy myocardial mass. So there is preserved systolic function and there is no evidence of alveolar obstruction. Thank you. Thank you very much. Now we'll be moving to the next session.
So in case one, which was sent for viability, so it came on cardiac MRI, the LAD territory was non-viable, so the patient was not sent for CABG. Instead of CABG, he was Ramus was stented. This is Ramus lesion, 80% stenosis, and the post stenting angiogram photo. And this is RCA, which is a 90 to 95%, and it was stented. The patient is doing good now, and he came for follow-up too. So cardiac MRI, in this case, cardiac MRI decided whether patient is to be referred to a surgeon for if or not. If the LAD territory was viable, I would have referred the case to CABG because patient will have a complete revascularization. In this case, it came non-viable, so I have done a percutaneous intervention. Thank you.
Um, a 53-year-old male presented with dyspnea class 2 for 1 month. He's a hypertensive with history of coronary artery disease, triple vessel disease, for which he underwent CABG in 2010. On examination, his vitals were normal. Cardiovascular system and lungs were also okay. The blood reports were within the normal limits. ECG is within the normal limits. Echo showed good LV function. The TMT was strongly positive. So we need to do an angio, but he didn't have the surgical details. We cannot do an angio without proper surgical history. We have to keep, it's not like we can't do it. We'll be using a lot of contrast, searching for the grafts. So we asked the radiology department to do a coronary graft CT. So as for the finding, he had 5 grafts, Lima to LAD, which was patent, SVG to PDA showed significant stenotic segments, SVG to OMs were blocked, and an SVG to the diagonals were also occluded. So with those details, we were able to do an angio. This is the angio of the patient. Left anterior descending artery and the rest of the arteries were severely stenosed. very much narrowed up, not compatible for stent implantation. Even the left circumflex system, the RCA, had chronic total occlusion. So we looked at the grafts. Inconsistent with the CT findings, this is the lemma, which is patent. It's giving off blood supply to the diagonals, which were blocked. The SVG diagonal grafts were blocked. So the lemma is giving supply even to the diagonals. SVG to the OMs were blocked. This is SVG to the PDA graft, which shows significant stenotic segments with thrombi. So according to this, the patient had a native triple vessel disease with patent lemma graft with SVG to diagonal occluded and OM also occluded, but the PDA showed proximal and mid-long segments eccentric disease with thrombus. So the plan is to do a PTCA and stent to SVG to PDA graft. This is how the CT has helped us in knowing how patent the grafts are instead of going about wasting contrast and searching for everything. Is a 60-year-old female who came with a complaint HA class 3. She's a hypertensive, insignificant coronary artery disease. Her vitals were normal, blood reports were normal. ECG showed the 2D echo showed a hypertensive picture with good LV function, but the Holter also was not significant. So, in order to explain the prognosis to the patient, a cardiac MRI was done, which was case 2, which was presented by Pavan sir. So, cardiac MRI showed less than 10% gadolinium enhancement, in fact, 4. So, we put her on medical management. The main reason why we did it is because whenever there is a hypertrophic cardiomyopathy case, we have to see and assess whether he or she requires an implantable cardiac defibrillator or not. This is assessed by these criteria. If there is any prior event, yes, you have to keep ICD to the patient. If there are any other risk factors, then we assess the 5-year risk and we consider it as a reasonable choice. If that's not there, we look for an NSVT and Holter. If there is an NSVT, we further assess the risk and place an ICD based on the discussion if it's a high risk case. In patients where all of these are not there, we check for a late gadolinium enhancement. If the gadolinium enhancement is more than 15%, then placing an ICD is reasonable. Thank you.
We conclude the session. This session and move on to the next. Okay.
Thank you, dear cardiology team. A wonderful session on non-invasive radiology, cardiac CT, and cardiac MRI. So any questions, audience? Eh, please speak on the mic.
I have a question for radiologist and clinical cardiologist. In case of a triple vessel disease in a renal failure patient or elevated serum creatinine, when lower coronary reserve volume with a transient myocardial stunning or like a partial thickness, so can cardiac MRI can be done or how far it is sensitive and can you quantify? And what is the clinical challenge for the cardiologist? Shall I repeat?
Sorry, can you
Yeah.
repeat the question?
Yeah,
once?
yeah. This is a case like suppose if a case of triple vessel disease with
Okay.
a low coronary reservoir volume or with like a partial thickness infarction with a transient myocardial stunning with elevated serum creatinine, can cardiac MRI can be done? Or like what is the challenge for the clinical cardiologist?
If the creatinine is elevated, we should depend on the GFR. If the GFR is normal or below 60, uh, we can do a cardiac MR with using contrast, because uh, only after the contrast we'll know the myocardial tissue. So consider the patient is having normal serum creatinine or normal GFR. So we see the late gadolinium enhancement in these patients, and we can actually differentiate between hibernating myocardium as well as uh, ischemic myocardium based on the LGA. So LGA is present in ischemic or necrotic myocardium, but hibernating myocardium, there is no involvement of LGA.
Yeah. Will you restrict with plain or will you go with dobutamine also to differentiate the hibernating myocardium?
Yeah, we can go for a stress test using dobutamine. Thank you. Thank you, Dr. Pawar. Yes, thank you, our esteemed cardiology team. Any more questions? Thank you. So we'll be moving to the next session. Over to the anchors.
Thank you, sir and ma'am, and respected doctors for this engaging and interactive panel discussion. So now we move on to delve deeper into the systemic architecture of organ sharing. So now I invite Dr. Professor K. Rambabu sir for his keynote presentation on organ donation, BSD, procurement. What do we need to know? We welcome you, sir.
Good morning, everyone. Beautiful to see this wonderful auditorium. So I request everyone, please give the big applause to the CAB members who donated. And every time, so whenever I am seeing this one, so I'll get the goosebumps. So this is wonderful AMC gift given by the alumni. Thank you, everyone. So let us go for the social topic. This one, the organizers organizing this meeting. The aim of all this meeting is organ transplantation. But where from so we are going to get the organ? That is one of the most important issue. And the big people, big surgeons, Balkrishnan sir, Tyagarajan, and so many other surgeons from the other hospitals like Sachin Daga, so many big names are there. Everybody is ready, and even we are doing the double organ transplantation in even the single patient also. But get the organ is very, very difficult. So honestly, how many knows here the doctors Jeevan Dan pledge anybody has taken? Honestly, please raise your hand. Anybody? Very, because these people are in the organ transplantation. Other people, anyone? So very few people know that what is Jeevan Dan, what is organ transplantation, what is pledge. So I can see here all the so many elder people are there. So when I was doing my postgraduate, whenever there is a problem in my first year, so I went to my professor and saying that there is a lot of hue and cry there for the patients. He said that just say that some two bloods are needed for that fellow. So nobody will be there. Everybody is vanished. So It took nearly 30 to 40 years to get the blood donation. Only the stigma is patient is will become weak. That's all. No other thing is there. So many NGOs and so many people are sacrificed and given a lot of services. So after that, now we are seeing the blood donation is so easily. So we are doing. Anybody is just by walk through going by the bike and he is giving the blood and going out. So next coming into the cornea donation. If you take the cornea means next gen no eye. So to get rid of that one, almost it took another 20 years. Now the people are coming forward. Then for the medical college, body donation is one of the most important one. So great people, so many sacrificed, and body donation is also going on. Now the problem with the organ donation. So patient is in panic stage, trauma, near and dear is in a difficult condition to explain to him. So what is brain dead and what is natural death is there. So very difficult unless until the people understood that before only they will come forward. And whenever I am giving this lecture, everybody feels that this is only the lecture or the some topic. But whenever in your near and dear and in our family, remember, if the people are moving just like that, anybody, to save him, you are going to the any level of extent. So please listen carefully that suddenly patient will get the fever and the next day doctor will say that you are having the CKD and you landed into that one and going for the dialysis, craving for the organs, moving on, their doctors and everybody. So it's very difficult to get. So please, medical fraternity, please understand so importance of the organ donation. We are doing the wonderful. We are in all over the world. So we are in the number 3, but still, according to the population, it is less than 1% who we are doing. It's a 0.86%. More than 5 lakhs people are dying in India. So in AP, you can see that there is 5,700 people are waiting for the organs, and nearly 2,000 people are for the kidneys, and nearly 3,700 people are waiting for the kidneys and the liver for the 2,000. So when we are discussing so many, one man is dying. So such a difficult condition here. If you just go for that, statistics is saying that 29,000 accidents are happening in Andhra Pradesh, and out of that, 5,000 and in that nearly 3,000 to 4,000 people are in head injury. And we will finish up this list even within 1 year if the people coming forward. So, but there is a lot of superstitions, lot of few only most important things regarding the transplantation, what are the types and what is the brain dead. Please understand this one and spread this what I am going to tell. So spread to everyone. So there is a live donor, you know that, and the disease, it's a brain dead, and it is a related and unrelated. Please understand the definition of the related. Just this month, 4th only, cabinet. So we went for the 2011 Act implemented, and ordinance will come within 1 week. So relation is changed the definition now, both parents and the brothers and sisters, siblings. They added grandparents also. So grandparents included, so that will be implemented within a short period. So why the grandparents included when the 60, 70 years old man, so how the organs is going to be useful? Because we are getting the kidney diseases, even the age of the 10 years, 12 years, 15 years also. There may be chances of grandparent is less than 55, 60 years. So those organs are so useful for the live donation. And in the 2011 Act, so in this act, so swapping donation is also very, very important one. It is the easiest one. So exchange of the incompatible donors for the both families. So everybody got it? Swapping. Swapping is very important. We can encourage the live donation is more by the swapping. in your family, so you are uncompatible, and other family, other person is not compatible. So both can be the so exchange both pairs. Legally, it has to be certified by the medical board. So now 2014 bifurcation. After that, so we came, everything is kept in the Hyderabad. So we thought that Hyderabad is only the for the organ transplantation, whatever it may be. Suddenly we came here and we started 2015, established this Jivandan office, and then slowly encroached into the all other hospitals and training the all the doctors, and the success rate is also very important one, transplantation. And nearly uh, 81 hospitals are registered till now. So till now, from the 2015, we did the nearly 1,500 cadaver organ transplantations and live nearly 3,350 organ transplantations we did. Such a highest number within a short period. You have to understand, 2015 we started. Establishment of the hospitals are very difficult and successful, and the training of the surgeons in between COVID came 2020 and the 3 years gone. All these efforts done by the within 3 years only we did such a biggest thing. Are so recognized by the central government also. Here you can see this is the mark. So you see 2015 to 2026, you can see that very much dip is there, and I took the charge. And in 23, we did the after COVID, suddenly jumped into the 126 organ transplantation. And there is a huge pressure from the health minister, sir, and the secretary also. We want to go for more. Then went for the all the districts every month. So we used to visit to the one district and go for the organ awareness programs and briefing about this one, and medical colleges. We went there, and then 24 we went for the 210 organ transplant. And in 2025 we jumped to the 301 organ transplant. So we did, and you can see that 157 organs within 5 months. And last 2 days we added another 10. So that means that nearly 170 organs already transplantation occurred, and 170 people are alive now. So we are expecting 400 organs will be transplanted this year with all your cooperation. So let us understand brain death. So you're all the doctors, so you know that what is the brain death and what is the cardiac death. Cardiac death means complete death. So you have to explain to the patient at the time when the patient came. So if somebody says that brain dead, so I want to go for the organ transplantation, it's not possible. They have to take the permission and they have to show the proof to us whether it is really brain dead or not. So these are the some brain dead assessment everybody knows. So most important one, this is called as the apnea test. Just do the ABG before removing the ventilator and see that CO2, what is the level. And after the removing of the ventilator, you just see the CO2, it should be raised more than 20%. Some simplest test, so you can do, and you have to send to me. And then we will decide with the other reports. And when the first apnea is over, then only you are supposed to go for the counseling of the patient. Till then, so you are not supposed to do the counseling. And once the counseling is over, then your team will arrive, and then you can take the consent. Consent, please remember, this is one of the uh, difficult moment for the organ transplantation program. Only legally hired person only can give the consent. I'm saying that legally hired person. So that means that wife, husband, and children. So these are only the eligible person to give the consent. So then second apnea, you are supposed to say positive. Then you have to go for the permission with the all the committee members of the hospital. You have to send to me. So you can see these are the total awareness programs done by me. And this is the Tirupati Medical College, Vijayanagaram Medical College. This is the Visakhapatnam and Nellore. And we are doing the flash mobs, rallies, everything. So we are doing all the programs conducted by all these years. So here we want to involve everyone. So please give the big hand to the Care Hospital and also the KIMS Hospital. Both did the dual organ transplantation for the more than 7 patients, both kidney and liver. Such a great thing. So please give applause to them. And all are successful. And thanks to the state government. So whenever we are asking for the heart transplantation or the lung transplantation, they come forward and giving the chopper to us. So thanks to the government, thanks to the police and the revenue department who are ready to go for the green channel. And this is the first heart transplantation, pediatric heart transplantation done in Tirupati with total cost of by the government and chopper, including chopper also. So thanks to the government, thanks to the Honorable Health Minister, so we used to come to the organ awareness programs so many times. So he is very much encouraging for this all the programs, and the felicitation to the donor families is one of the most important program in the organ transplantation. And this government has given the GO number 95. What do you mean by GO number 95? We have to honor with the patient and we have to give the 10,000 for the funeral charges. And also we have to collector, joint collector or RDO, they have to come and felicitate the donor body and then give the honor to the family with the felicitation certificate. These are all just like the how the border when soldiers died. So how the honor will be given. So we'll give the honor to the this all the brain dead donors. And we are planning and already given to the chief minister sir also for the 1 lakh to give the donor. It's almost ending stage is there. It is in the finances. Shortly it will come. So these are all the activities are going on. And WIMS is the first hospital in the government sector did the first organ retrieval. And WIMS is the first hospital did the liver transplantation successfully in the government sector. And just I want to say one thing. You say that it's very difficult to convince the patient and turn out from the that stage when the patient is in deep trouble. And you can see these two people, both the parents and baby, while going into the car, there is an accident, and baby is just 10 years old, and she underwent brain dead. And these two people are with multiple fractures are there. We explained to them about what is brain dead. Both the parents came forward, and with these multiple fractures, after brain dead, after organs removal, they went to the funeral and they came back and they underwent the surgery. Please give the big hand to the such a daring people are also there with us. Wonderful parents, even they lost the baby, so they came forward and saved the more than four people. And thanks to the Honorable Chief Minister, sir. So whenever he saw this message on newspaper only, so he has given the tweet. Thanks to the Honorable Deputy Chief Minister, and thanks to the Honorable Health Minister. So all the government is supporting by indirect way to the organ transplantation. So thanks to the government, your support. So last year, so that means that so we underwent for the 301. It's a great our record break. So it's all over the papers came. And with that, so we got the top sixth position in the country. Top sixth position. So previously we used to be in the 20th position. Now we are in the top sixth position. So thanks to all the hospitals who are cooperating. Now I request all the government hospitals who should come forward and do the organ transplantation program. And I received the national award from the Central Health Minister for the best emerging state in Andhra Pradesh. So this is the one of the biggest achievement, and with a lot of awards and felicitations are there. And thanks to the celebrity endorsements also I have taken from the Nagarjuna sir. So very much cooperative. So whenever he was abroad at that time, and he has given his endorsement, and Murli Mohan and Jagpati Babu sir, he looks like a cruel in his roles, but very much sensitive. So whenever I called at that time, so he came forward and he listened that one. And you can see this one. This is the baby which you are seeing. Mother is suffering with So this is a ventilation problem, and she conceived after 10 years of treatment. But unfortunately, within 3 months, she underwent a cortical vein thrombosis, and there is a brain dead occurs. So, but husband came forward and they donated. And when I am asking for the endorsement to the Jagat Babu, so I told about this story. Immediately he came forward. He went to the house, and when the such a big actor went, collector also came, and you can see this is the baby. Please give the big hand to the family and to the Jagat Babu also, who came forward for the organ donation program, and they are helping. So there is no age demarcation. This is the this we did the analysis, so you can see that from the 5 years of age to the all the 70 years of age, people are suffering with all the diseases. So you can see that so many people with the kidney and liver. There is no age for young people are more suffering. So what are the solutions for this? So we are trying for the holdings, Jivandan help desk, and the two transplant coordinators. And what's about the government hospitals? There is a lack of seriousness is there, lack of awareness, limited departments, lot of other surgeries we are supposed to do. No special incentive will be there, no finance benefit, extra work. So I request everybody to go for the passionate and do that one. Private hospitals, lack of coordinators, lack of presence of stigma. If some patients are going frequently, they did that. So if you go to that hospital, they will declare the brain dead. So that's a problem, and they will ask for the waive off and some finance problems, and management is not that much passionate for this. So these are all the constraint things for the organ transplantation. So what to do now? Superstitions we have to come out, and religious and misconceptions, lack of awareness, and brain dead. What is brain dead? We don't know. What we are doing? So we are doing the brochures, pamphlets, social events, celebrity endorsements, educational event, using the social media, print media, electronic media, whatever the sources are available. So we are using and planning to go for the more organ transplantations. So now I request everyone to please say at least today we will say that I'll say donate organs. We say the save lives. Donate organs. Donate organs. Donate organs. Thank you.
Thank you, sir. Thank you for such a motivating session. Definitely will follow your pledge. Okay, thank you.
Thank you, sir, for this beautiful insight. I think now everyone in the dais knows about Jivendar, a beautiful program launched by government to save lives.
Moving forward with the clinical momentum, we enter session 2, the star-studded transplant suite. This block features pioneers who have redefined the boundaries of survival across India. And I would like to begin this by introducing our first absolute luminary, Dr. K.R. Balakrishnan sir, Chairman of Cardiac Sciences and Director of Institute of Heart and Lung Transplant and Mechanical Circulatory Support at MGM Healthcare. He is globally recognized for performing the highest number of heart transplants in India and pioneering the permanent artificial heart transplant using the HeartMate 2 LV80. Sir is joining us remotely and he will speak on heart transplantation in India, the 2026 landscape and future frontiers. Sir, the floor is yours.
Yeah, can you join? Yeah, good afternoon. Thank you very much for this kind invitation. I said my seniors follow me that I'm not able to join this in I came back from a long ride from the US. So I think about the current status of and so as highlighted by the previous speaker, there's been a steady increase in awareness about organ donation in this country, and approximately 1,200 donations take place every year, and around 230 to 250 transplants of the heart happen annually. The average waiting time for an organ when in our hospital is less than 3 months. This is a very interesting slide. If you draw a line across the middle of India from Gujarat in the west coast, Visakhapatnam in the east coast, 95% of the organ donations happen south of that line. This is a matter for study for social scientists. So when we started the program about 15, 16 years ago, we had to overcome several challenges to make it a viable program. And the first was waitlist mortality. Unlike kidney transplant, where these patients are on dialysis and so stable while waiting for an organ, in the case of heart, it's much more difficult because if they are on inotrope and no organ is available, and despite inotrope, if the blood pressure is low, they die very quickly. So you either have a patient waiting for an organ, or sometimes you have a donor and there's no recipient. So we had to overcome that problem. Around that time, ECMO became available in this country. So we were the first to start a VA ECMO program in India. And as a bridge to transplant, our first experience was this 34-year-old woman. I went to cardiomyopathy, who had a cardiac arrest, severe renal dysfunction. She was resuscitated on ECMO. Screen. On screen. You can't see us. I thought I'm sharing my screen. Screen shared? Okay. Share. Are you able to see my screen? Can you see the? Oh, okay. Let's. I can see. Yeah. Yeah. Can you see? I can see. You want me to start from the beginning? Yeah. Should we start from beginning or better? Yeah, beginning. Beginning. Yeah. Yes. Okay. I'm sorry. I was not aware that my slides. Can you hear? Can you see the slides now? You're asking. Yeah. Sorry. Yes. Yeah. Okay. Can you hear me? Okay. So at the outset, thank you very much for this opportunity to present in front of you. My sincere apologies for not being able to join in person. I came back from the United States only this morning around 5:30, and I couldn't catch the flight to Visakhapatnam. I've been asked to speak on current status of heart transplant in India and future directions. Over the, as highlighted by the previous speaker, there's been a steady increase in the awareness as well as the donation rate across the country, and approximately 1,200 organ donations take place annually. And as a consequence, over 200 plus heart transplants happen. The average waiting time for an organ is less than 3 months in our unit. A very interesting statistic is if you draw a line across the middle of India from Gujarat to Andhra Pradesh, 95% of the organ donations happen south of that line. So it's a study, interesting study or topic for social scientists. So the biggest challenge we had to overcome when we first started the program around 15 years ago was to overcome waitlist mortality. Unlike kidney transplant recipients who are on dialysis, the heart transplant recipients, if they are sick and their blood pressure is low, so they don't have much of a choice. So we started using ECMO, VA ECMO, way back in 2010. And the very first patient who had a bridge to transplant was in the year 2012, was a 34-year-old lady airlifted from Delhi with severe bioventricular dysfunction, with renal dysfunction. And she was resuscitated on ECMO, and as you can see, with peripheral cannulation. She got an organ after 2 weeks, and she did very well. This is her 5 years later, skiing on slopes of Gulmarg, could physically climb Vaishnav Devi on foot with a VO2 max of 30. She died after 5.5 years. She had one episode of acute rejection, from which she recovered completely, but she developed tuberculosis of the parotid gland. She was lost to follow for a while, treated locally by a GP, and eventually developed full-blown tuberculosis and cytomegalovirus virus infection and died. Nevertheless, it gave us the confidence that even in our country, sick patient bridged to transplant with ECMO can have long-term survival. We started using it in children. This patient with biventricular cardiomyopathy was on ECMO for 6 weeks. We then got a donor organ which had significant dysfunction, so was refused by several units. But donor organs from older children or older adults work very well in children, even with ventricular dysfunction. This patient did very well. He's alive and well now after 6 years. We also used VA ECMO when uh, this boy had a cardiac arrest. As you can see, the echo on the left is his native ventricular function. He was decerebrating for 48 hours after resuscitation and ECMO. He woke up. We got a donor heart after 3 weeks, which had significant ventricular dysfunction. But nevertheless, we accepted because he was on ECMO. And he did very well. As you can see, the ventricular function recovered. He was shifted to the room. And he then developed new onset ventricular dysfunction with, especially the right side, with free tricuspid regurg. So we took him back to the cath lab, expecting rejection, but it turned out to be native coronary artery disease. Coronary angiograms are not often possible in our setup in this country because several times the donations happen in hospitals where there's no cath lab. And premature atherosclerosis, unfortunately, is quite common in South Asia. So the 7-year-old boy with a 35-year-old heart underwent angioplasty of the LAD and circumflex and had to needed one more run of ECMO from, after which the ventricle completely recovered. He came back with restenosis and had restenting, and he's alive and well after 7 years. If the patient doesn't get an organ on ECMO after 2 weeks, we can to a short-term ventricular assist device, Centrimac. And with this, you can support for up to a few months. We've used it in children as well. The youngest has been this 8-month-old child who was supported on Centrimac for a month before undergoing a transplant. We also use the impeller pump as a bridge to transplant, including in pediatric patients. This is a 12-year-old girl who had an impeller supported bridge. Long-term valves are not usually used as a bridge to transplant because of the cost. We've used them in some instances. This is the youngest we've done is this 4-year-old girl who was bridged with a hardware and she had a transplant after 2 years on VAD. We also use ECMO to support a donor heart if it's from a suboptimal donor, older age, ventricular hypertrophy, history of cardiac arrest, bloodstream sepsis, and avian incompatible blood groups are all suboptimal donors. Especially during COVID time when the organ donation was not common and transport was impossible. This is done. This is a 14-year-old girl who was supported on BioAd with Centrimac. We got a donor heart from Surat with ventricular hypertrophy. But since no other donor was available, we accepted it. And this heart did not beat at all for 9 days. So she was in central ECMO for 9 days, which we converted to peripheral ECMO. And after 18 days of ECMO support, the ventricle completely recovered. And this was the ECMO at discharge. And this is her. She's now alive and well after 5-6 years. We also used ECMO as a bridge to transplant as well as for poor donor hearts. This is a 18-month-old baby from Bulgaria who was airlifted, had a cardiac arrest in our hospital, was resuscitated, woke up after 48 hours. We got a donor heart from Children's Hospital in Wadia in Bombay after a week. And the chest was kept open for 10 days because that donor heart had ventricular dysfunction. She's alive and well after 3 years. The biggest challenge was overcoming transportation. The previous speaker spoke about government hospitals. In Tamil Nadu now, every government hospital has become a potential donor. The circles that you see in our state are hospitals where organ donation happens. As you can expect, not every hospital or a town where a donation happens has an airline or an airport or a night landing facility. Very often, the organ has to be ferried by road, and the ischemic time or tolerable ischemic time of 4 hours is very difficult, especially if it's driving time to Chennai is say 7 or 8 hours. So we to start the concept of green corridor in India, and as you can see over a period of time, the mean ischemic time has increased over the last decade, and the maximum acceptable ischemic time has been up to 8 hours, especially if the donor hearts are young. We started using commercial airlines for organ transport about 12 years ago. And we are the largest users of commercial airlines for organ transport in the world. So we analyzed 350 patients where we compared organs transported by road, by commercial flight, and by charter flight. And we found no difference in outcome uh, in terms of survival. Very often we get a donor heart from PGI Chandigarh, where from Chandigarh to Delhi we have to take one aircraft, change the terminal, go to another terminal. And these are young hearts, and even up to 8 hours they do well. And this has been published in the Journal of Heart and Lung Transplant. We are now developing an organ perfusion system for the heart, working with the Indian Institute of Science in Bangalore. And this is a big heart where after 9 hours the heart is beating well. So this is being commercialized, and so hopefully we'll have it in the market in the next 6 months to 1 year. Then ischemic time will no longer be such a major concern. So, what are the outcomes? Till January of this year, we have done over 800 thoracic organ transplants, including over 600 heart transplants and 45 heart and lung transplants. The youngest patient has been 4 months of age, and the oldest has been 81 years of age. One third of patients have been in Intermax 1 or 2. And I think we have now, as of last week, we've done close to 150 pediatric transplants. The 90-day survival has been around 85%. And the most important risk factors for 90-day mortality are poor renal function and poor functional class. If they are on ECMO, if they have had a cardiac arrest, or if they are intubated on multiple inotropes with renal failure, their risk of surgery is higher. As you can see, the impact of Intermax category on 90-day survival, those in Intermax 1 and 2 have a 90-day mortality of around 27% as compared to 9% for most stable patients. Similarly, if the renal function is well preserved, the mortality is much lower, and it's almost 3 times higher in the patients with significant renal dysfunction. What about 10-year survival? When we first started this program, we were not sure whether the long-term outcome would be equal to what is published in the Western literature. But surprisingly, this Kaplan-Meier curve shows that at 12-year follow-up, we have got over 65% survival, which compares favorably with what is published in ISHLT. Pediatric patients tend to do better with 75%, 74% 12-year survival. More than 80% are expected to be alive at 10 years. Even within Intermax 1 and 2, if they're not on ECMO or had a cardiac arrest, their 10-year survival is over 76, close to 70% as compared to 50% for Intermax 1. So even if they've had a cardiac arrest and are on ECMO, they survive the surgery, their long-term outcome is no different from the rest. We've had several other publications. From this graph, as you can see, impact of renal dysfunction. These are patients with elevated creatinine with eGFR less than 70 with a median value of 37.92. Their renal ultrasound showed a normal kidney length and well-preserved corticomedullary differentiation, despite which, as you can see, the long-term results with poor renal function are much worse. We don't have a good criteria for combined heart and kidney allocation in this country for cadaveric donors. So it is important to refer patients before significant renal dysfunction sets in. About 15% of patients have some kind of reductions when we do a first biopsy in the first 3 weeks, but they're not usually of clinical significance. We've had rejections late, around 8 or 9 years. This is a young woman, 9 years after the transplant with significant rejection, who presented to to Holy Family Hospital in Bombay with profound cardiogenic shock and cardiac arrest. Was put on ECMO and airlifted to our hospital. And on biopsy, she showed antibody-mediated rejection. So after plasmapheresis, rituximab, and immunoglobulin, and 10 days of ECMO support, the ventricle recovered completely, and this is her 2 years later. The functional outcomes have been excellent. This is a man 2 years after transplant. He's the CEO of a 2,000 crore company. This man, 5 years post-transplant, is able to finish first in a half marathon in an open field. And the girl was looking for mountain goats in Munnar 1 year after transplant. He's in the first round of playing tennis. So functional outcomes are excellent. So in conclusion, good long-term results are possible even in a resource-constrained environment. Preserved renal function is crucial for excellent long-term results. Thank you very much. I'll be happy to take questions. And I think Dr. Suresh Rao will speak about our experience with LVADs and when you decide about LVADs versus transplant. Thank you very much.
Thank you. Thank you, sir. Thank you for the luminary session, sir.
Thank you, sir, for this brilliant insights. Now, next we move on to a compelling clinical dilemma. So, I'd like to invite Dr. Suresh Rao, sir, who is a co-director of the Institute of Heart and Lung Transplant and Mechanical Circulatory Support at MGM Healthcare, a highly distinguished cardiac anesthesiologist and intensive care expert with over 30 years of experience specializing in ECMO, management, and transplant critical care. So, sir is going to be presenting the great debate heart transplant versus LAAD, how to choose the right path. We welcome you, sir.
Yeah, I finished. Oh, they already introduced you. Just started. Okay. Share is like. That's great. Great. Oh, can you? Yeah, I can see. Oh. Okay. You have to log out there because there is. Mm. It's okay, no? No. Okay, no? You can. Mm. Okay. Presentation. What is that? Can you see? Can see. You can see the screen. I can start the. Okay. You're. I think you're. You have to put this one off. Hello. Okay. Yeah. Good afternoon, all. At the outset, I would like to thank the organizers for giving me the opportunity. Sorry that we couldn't join physically as we had two donor alerts. In fact, we are doing the transplant now. Now, both heart transplant and LVAD are the established procedures for the advanced heart failure. The question is how to choose the right patient for the right procedure. The objectives of this talk are to look at the various indications and case selection criteria for the heart transplantation, to look at the role of mechanical circulatory support in heart failure patients, and destination LVAD, the case selection criteria, to compare the risks and benefits of each one,
and also to look at the factors influencing the treatment selection, and finally to review the patient outcomes and the quality of life considerations. And I will give some of the case scenarios from our own experience. Yeah. So basically the heart failure can present in various stages. In stage A, they are high risk factor patient. This one for the heart failure, they may not have symptoms. In stage B, they will have some kind of structural disease but no symptoms. In stage C, they will have actually symptoms. And in all these three stages, it is the lifestyle changes, medications, or some patients may get benefit from device therapy. However, when it comes to stage D, that is refractory heart failure, they may not respond to any kind of medical therapy. So they will be on inotropes. They require repeated hospital admissions. And these kind of patients who require some kind of definitive therapy like heart transplant or LVAD. Now, incidence of heart failure is around 1.5% of the adult population, of which around 5 to 6% of the patients may develop advanced heart failure. Now, with each admission for heart failure, the mortality increases by 20 to 30%. Despite the newer medications, the advanced heart failure mortality is high. It's almost 50% 2-year mortality. Now, heart transplant is the definitive therapy in stage D heart failure, and various mechanical circulatory support devices are used as a bridge to transplant. All these devices, to begin with, they were used as a bridge. It's only later some of the devices are used as destination therapy in advanced heart failure. Now, the need of the hour, we need to have a dedicated heart failure clinic to take care of all these patients. So, what are the selection criteria to decide whether the patient requires transplant or a LVAD? The first thing is they should receive maximal medical therapy before considering for transplantation. And also any other alternative surgical therapy like a CABG, valve repair, valve replacement, all these things should be considered before looking at device therapy or transplant therapy. The most useful this one criteria which helps in deciding whether the patient requires transplant is CPET, that is cardiopulmonary exercise testing. And if the peak VO2 max, if it is more than 14 ml per kg per minute, they are considered too well to be considered for heart transplantation because it has not shown improvement in the overall survival rate as compared to conventional therapy. On the other hand, if it is 10 to 14 ml per kg, they have some survival benefit. But if the peak oxygen consumption is less than 10 ml per kg per minute, they have greatest survival benefit. Now, these are the class 1 indications for cardiac transplantation. Any patient in cardiogenic shock requiring mechanical circulatory support and the heart is not recovering, or patient has got refractory heart failure and on continuous inotropic support, and we cannot wean off the inotropic support, they are candidates. And any patient having NYHA class 3 or class 4 symptoms, and the 12-month prognosis is low. By looking at the Seattle heart failure model, we put various criteria to give the risk of mortality in 1 year or 2 years. And some patients may have progressive symptoms despite maximal therapy. And some patients may have hypertrophic or restrictive cardiomyopathy, but severely symptomatic. And some patients may have refractory angina. They're not suitable for revascularization. Again, we can consider heart transplantation. And of course, life-threatening arrhythmias, despite medical therapy, and EP, ablation, all those things, then we can consider for the transplant. And some of the cardiac tumors and some complex congenital heart disease, for example, hypoplastic left heart syndrome, failing Fontan, etc. To make it simple, this is a practical approach. If the patient has got one or more hospital admissions for recurrent heart failure and echo shows severe ventricular dysfunction with DF less than 30%, and if you look at their NT-proBNP, it is raising each time. And if their 6-minute walk test is less than 300 meters, and of course, peak VO2 max is less than 14, I think we need to consider for the transplant or LVAD. So heart transplant, it is a gold standard therapy with long-term survival. However, we have limited donors and also they need to be on immunosuppression. Whereas LVAD, it provides the mechanical circulatory support. It can be used as a bridge to transplant, or it can be used as a destination therapy also when the patient is not a suitable candidate for heart transplantation. So what are the factors to be considered before deciding whether the patient requires transplant or LVAD? Now, right heart study is the most important parameter we look at. And usually we measure the pulmonary artery pressure. With heart failure, there will be pulmonary hypertension. And in the beginning, this pulmonary hypertension is reversible. However, as the days goes by, they will develop fixed pulmonary vascular resistance. And if the PVR is more than 3 Wood units, probably they are not good candidate for transplant. And also we look at the TPG, that is transpulmonary gradient. If it is less than 15, we can go ahead with the transplant. This is very important because you are getting a heart from a donor whose pulmonary artery pressure is normal, and you transplant and right ventricle is exposed to high PA pressure, RV can fail. And the other criteria, the age of the recipient should be less than 69 years. Of course, this is not a strict parameter because we have done transplant in an 80-year-old guy also. And patient should not have any infection. They should not have any active malignancy. In fact, immunosuppressants can exacerbate the malignancy. And they should not have any hepatic or renal or pulmonary dysfunction. Coming to the LVAD, basically it supports only the left ventricular function. So the right ventricular function has to be normal when you consider these patients for a LVAD implantation. The second most important thing is the aortic valve. There should not be any aortic regurgitation. If there is severe AR, either it has to be repaired or you need to do AVR. Otherwise, the LVAD will fail because whatever the blood pump from the LV to the aorta will goes back to the LV. So effective cardiac output will be low. And of course, they should not have any pulmonary hepatic other dysfunction, organ dysfunctions. Coming to our own unit experience, we would have done more than 800 heart transplant, heart and lung together, and more than 100 LVADs, more than 60 of LVAD as destination. Some of them are as a bridge to transplant, and at most more than 800, including the CPR. So one case from our own experience, this 8-month-old baby, a Bulgarian born, had dilated cardiomyopathy in end-stage heart failure. Child was advised the Berlin heart implantation as a bridge to transplant. So it was airlifted to Chennai. Now it suffered a cardiac arrest as soon as the flight took off, revived. Then the child had one more episode of cardiac arrest at Karachi and revived after 40 minutes of CPR. Then once the child came to Chennai, again one more arrest, we did the ECPR and stabilized the patient, child on central ECMO. You can see the echo. The left ventricle is hardly contracting. The circulation is mainly maintained with the ECMO. And 3 days later, child woke up, and luckily we got a donor, brain dead donor from Mumbai. Echo showed borderline ventricular function. However, there were no Indian patients for the of this organ, so we accepted for this Bulgarian child, and the blood groups were different. So it was a ABO incompatible transplant. The child's blood group was A and donor's group was B. So we did the anti-B titer. We used the ABO absorption filter, and the finally transplant went on well. You can see the child recovering in the post-transplant period. The If you look at the echo, excellent ventricular function. And this is the photo mother sent to me, child celebrating the first birthday. So excellent outcome is possible with the heart transplant from 1 year to probably 8 years. This is another gentleman who had MI, but it was a delayed presentation. By the time patient came to us, the ventricle was thinned out. He was getting repeated VTAC. In fact, he had a cardiac arrest in our ICU, and we did ECPR. Then we put him on BiVAD. So he was on BiVAD for 2 weeks. It was used as a bridge to transplant. And finally, he underwent a transplant. You can see the video on the right side where the patient is walking in his flat after the discharge. This is another interesting case, Nigerian who had a severe ventricular dysfunction, and he was waiting for a transplant. He crashed, then put on ECMO, then converted into LVAD. You can see the two cannula coming out. One is draining the blood from the LV and returning it to the aorta. And finally, he got a heart. This is a echo of the post-transplanted heart. And we could discharge him after a month's stay in the hospital. Now, heart transplant has got definitely advantages. It has got best long-term survival for eligible patients, and they will have near normal heart function. And the exercise capacity also is very good. They have better quality of life. And of course, they need not have any external mechanical device. Whereas there are limitations, there is limited donor availability, and waiting time may be sometimes too long. And during waiting period, they may deteriorate. And once the transplant is done, they need to be on lifelong immunosuppressive therapy. There is always risk of rejection. They are also prone for infection, and they can develop potential organ dysfunction. For example, they'll be on immunosuppressants, which may cause renal dysfunction. Now, coming to the LVAD, what is LVAD? It is left ventricular assist device. It's a mechanical pump that assists the left ventricle in pumping the blood through the body. There are various indications. It can be used as a bridge to transplant, especially while waiting for the heart. Patient becomes sick, you can put them on LVAD. Or it can be used as a bridge to recovery. Sometimes acute MI, you put them on LVAD. Then once the heart recovers, you can take off the LVAD. Or in acute myocarditis also, it can be used as a bridge to recovery. Or it can be used as a destination therapy where transplantation is not possible. So this is the first LVAD. We did it in 1995. That is the Meadows pump. He was waiting for a transplant and went into severe low output. So he was on LVAD for 3 months before the successful heart transplantation. Now, LVAD, to begin with, it is used as a bridge to transplant. I will show some examples. This infant had severe heart failure, went into severe low output, intubated, put on ventilator, but child had deteriorating hemodynamics. So we put him on LVAD as a bridge to transplant. You can see two cannulae, one cannula draining the LV, other cannula returning the blood to the aorta, and this is the centrimac pump. We put the child on LVAD for 1 month before the transplantation. The other option is to use Berlin heart. This child had severe biventricular dysfunction, so we put the child on BIVAD using the Berlin heart. And the advantage with Berlin heart is that you can keep the Berlin heart for a longer time, 1 to 2 years. This child was on Berlin heart for 1 year, 7 months before the transplantation. When coming to adults, we have various options like HeartMate 3, then you have CarHeart, CarWave. Of course, all these are in the pipeline, but HeartMate 3 is the one FDA approved, which is used at present. Now, this is HeartMate 2. You can see the inflow cannula, the pump, and the graft to the aorta. And this is the device control and the batteries. And the first successful heart transplant, HeartMate 2 implantation was done by us in 2005. And this is a lucky gentleman who did extremely well and had good quality of life. And this is axial, it is basically an axial flow rotary pump, which pumps the blood. Now, LVAD has some advantages. One is immediate support for the severe heart failure is possible. In heart failure patients, definitely it reduces the symptoms, improves the quality of life, improves the survival, and it can be used when transplant is not possible or the service is not available. It also can be used as a bridge to transplant, and this patient doesn't require any kind of immunosuppression. Of course, it has limitations. There are bleeding complications. Patients may develop stroke. Device infection, that is the exit wound where the this device lead comes out, it's a potential problem. And they require daily device monitoring and the device management. This table compares the heart transplant versus LVAD. In heart transplant, yes, they need a donor, whereas the LVAD, just a mechanical device is needed. Waiting period is less in LVAD. It is often long in heart transplant, and lifelong immunosuppression required in transplant, but LVAD requires anticoagulation. There is no risk of rejection with LVAD, and device maintenance, nothing is required for the heart transplant. Coming to the quality of life, it is excellent with heart transplant. It is good to excellent in LVAD patient, depending upon the patient. And long-term survival, generally it is higher with the heart transplant. However, it is improving with LVAD because of the newer technologies. Whatever survival outcome with heart transplant, excellent long-term survival, 10 to 30 years, with the median survival rate of 15 years. Whereas LVAD has got the survival is improving, especially with the newer technology. But the key point is transplant remains the gold standard for eligible candidates. What about the quality of life? With heart transplant, they have greater physical freedom, better exercise tolerance, and no external hardware. Whereas with LVAD, again, they have a significant symptom improvement. They will become more interdependent. They will have increased independence as compared to severe heart failure patients. However, they have to carry the controller and the batteries. Who is a good candidate for heart transplant? Usually younger patients, when there is a suitable donor and recipient size match and no major contraindications like infection, high PVR, or other system diseases. And who is a good candidate for LVAD? Usually patients who are not eligible for heart transplant, or waiting list is too long, or they need some kind of urgent circulatory support. So they are good candidate for LVAD. Let me end with the case. It's a 8-year-old man had ischemic cardiomyopathy, non-diabetic, hypertensive. He had CABG done, had a CRTD device, and but despite of all these, developed severe heart failure. His kidney function was worsening. He had low pressure, lung congestion. He was getting repeatedly admit to the hospital. Sometimes he will get admitted one day, the very next day he get discharged. Again he'll come to the hospital again same day. So he was not responding to any kind of medical therapy. So we implanted the HeartMate 3. This is basically a magnetically levitated pump, and it can pump blood up to 10 liters per minute. And he was not a candidate for transplant, so we went ahead with the LVAD. So you can see him. This gentleman is carrying the device and the batteries, and he is having a good quality of life. Uh, in fact, one time he was bedridden and he was in a severely uh, disease conditions and severely breathless also. So to summarize, with advanced heart failure, if the all the criteria they meet, they are waitlisted for the heart transplantation. And if they are not eligible for heart transplantation, you can go ahead with the destination LVAD. Some patients with advanced heart failure may present with acute cardiogenic shock. So these patients may require short-term mechanical circulatory support. And if the heart recovers and if they are candidate for transplant, again, you can go ahead with the heart transplant. But if the organ is heart, they are not recovering, then we have to go for long-term mechanical circulatory support. Again, with this, if they become candidate for transplant, you can go ahead with the transplant. But if they are not candidate for transplant, so it can be used as a destination therapy. Thank you. You can see this boy actually he was in severe heart failure, bedridden, and we implanted the HVAD, and you can see him dancing to the Indian music. Thank you.
Thank you, sir. Thank you, sir, for showing us the right path.
Now I would like to invite Dr. Bhaskar Rao sir to deliver his vote of thanks.
Respected Dr. Balakrishnan, thank you very much, sir. I know you have been traveling up such a long journey from USA. You still, the medical fraternity knows your contribution to the transplant in India. I was just discussing about you with Dr. Talwar recently. So, a lot of people came to see you, but I'm very thankful that you didn't disappoint them. And
I'm very sorry we couldn't join you physically. As Suresh said, we also have a transplant going.
I'm sure you would have definitely made your personal presence here. But many thanks for delivering the status and scope of cardiac transplant and lung transplant in India and leading the way from there. Thank you very much, sir.
You're welcome. Thank you.
Dr. Suresh Rao, thank you very much. I'm also sure that you would have been here. But what an apt occasion to deliver a lecture on transplant just before going for a transplant. Wonderful occasion indeed. I'm sure both you would have enlightened this August gathering and definitely infused some enthusiasm to think cardiac transplant and lung transplant, heart lung transplant as a definite possibility in our settings also. It really gives, excellent message that Tamil Nadu peripheral hospitals are significant part of contributions to the cardiac donations. Thank you very much, sir. Many thanks once again.
Thank you. Thank you.
Let us pivot our focus to pulmonary care. To moderate this session, I welcome our panel of experts, Dr. Sunil Kumar sir, Dr. P. Virita ma'am, and Dr. Sushmita J ma'am. I invite Dr. Saumitra Sinha Roy sir, a senior consultant and director of the Interventional Pulmonology and Lung Transplant Program, an authority on advanced respiratory failure and candidate mapping for lung transplant. To address a critical question, breath of life, candidate selection for lung transplant, when it is it too late?
But I think you was talking us to sleep. I- mm, ja- ah, yeah, while going, yeah, correct. Hmm. What I do is I'll take some melatonin in the that to change this one. Otherwise, not so bad. Correct, correct.
At the outset,
Hmm.
let me
It's
thank
7
the
o'clock.
organizers for such a gorgeous kind of program they have made, and that this auditorium looks excellent, really. Okay, so first, I will be talking on the candidate selections in the transplant and how to go about it, and specifically focusing on when it is really too late for a lung transplant. We do not have the benefit of like an LVAD for lung. Hopefully someday it will come. So a clinical case presentation at the beginning. 32-year-old nurse, young patient with a cystic fibrosis, had an acute infections with bilateral pseudomonas and MRSA infection, and presented with a severe septic shock with an aggressive antimicrobial regimen therapy with colistin both as IV and nebulization therapy with meropenem, vancomycin, moxifloxacin, caspofungin, and nebulized tobramycin. Now, patient is on mechanical ventilation, followed rapidly to ECMO, and the current state is moribund with zero functional and clinical improvement after 5 days of multi-organ support. Now, the dilemma in ICU is a salvage lung transplant is indicated? She is such a young woman and from our fraternity. And is this the point where the bridge transplant becomes bridge to nowhere and perhaps it is futile now to transplant? The considerations will be the infection controls with an active severe MRSA and the Pseudomonas infection with an septic shock. It is usually a contraindication in all kind of good programs for transplant. Physical conditioning, is the patient now become too frail to undergo the high risk surgery? Organ recovery, is there a chance as the patient was previously almost okay? Can the patient recover completely or it is completely destroyed with this active infection? And the transplant window, the golden period, are we still in that or it is now become too late? So this is the dilemma and we will be building on this and we will talk about this. Before that, lung transplant Indian historical timeline, um, we have started transplant in lung much later than all the other organs were when it has already started much better and much way beyond. Whereas late 90s, we have our teething status. And then slowly by 2005, 2010, we have established the registries and all the legislation specifically from the Transtan and Jivandan from the southern states and also by the NATO. And by 2011 to 2018, we have started a standard kind of high volume bilateral lung transplant, but we have still a lot much way to go. The key success drivers are the standardized brain death protocol, which has been made specifically by input from Transpan and Jivandan, and then the surgical and the pulmonologist inputs are there, and advanced mechanical support has become much better than after the ECMO, which we learned much better perhaps after the COVID kind of time, and then the better preservations, the transition to the advanced lung preservation solutions, the Perfadex has reduced the PGD, the primary graft dysfunctions status from about 30% to less than 15% with better preservatives. So, how is the current landscape in the lung transplantation in India? Somewhere about 170, 160 annual transplant is happening in India. Chennai and Hyderabad are the primary surgical hub in India, and the current 1 year post-transplant survival is at about 85%. And in Chennai, we do a pioneering work under Dr. Balasar. The regional network, the concentration of expertise has really helped to nurture this activity and the infrastructure. In India, our case are not like COPD and cystic fibrosis as we see in the Western countries. We see more of ILDs, almost about 80% or around that are the cases of ILD. Then we see post-TB bronchiectasis, HP, and post-COVID pulmonary fibrosis are definitely a lot there previously. So before going into the problem areas of when it is so late, let's talk about PF-ILD because, as I said, the progressive fibrosing ILD is the commonest cause of transplant which is happening in India. So what it is, there is a worsening radiological and honeycombing of the CT scan with a progression of the disease, with a declining lung function of FVC and the DLCO, with associated respiratory symptoms, severe progressive dyspnea, and chronic cough. One point is that many of our patients and your patients perhaps will be having persistent dry cough, and we try to give many drugs, and finally we are not getting as successful to come for that cough. Patient will come and say, "Do something for my cough. Transplant will happen, but do something for the cough now." Though the point here is to note that cough will reduce if you start giving them oxygen early. And as soon as the oxygen will be starting, you might say that the patient resting oxygen level is good. Why to start oxygen? But the point is when the patient is walking, going to toilet, taking food even, their oxygen level goes down with that minimal exertion, and oxygen will definitely good to their cough suppression. Deterioration in the quality of life and early mortality are the important thing to consider because the survival as per all kind of literature is about 2.5 to 3.5 is the average survival for PF-ILD after diagnosing, and hardly about 25-30% people are surviving for about 5 years. The clinical spectrum of PF-ILD is all IPF is under the gamut of PF-ILD. Then the connective tissue disease related ILDs are about 70% of the CTD ILDs goes into PF-ILD, and chronic HP and unclassified and familial ILDs also comes under the gamut of progressive fibrosing ILD. So how do you see the criteria for progression? The FVC should progressively decline more than 10%, and FVC can decline between 5 to 10%, but with either associated increased symptoms or the CT has showing progressive changes. Then we will say that this is progression in last 24 months if there is happening like that. And what is the impact? Despite all this optimal antifibrotic therapy like nintedanib or immunomodulation, patient will be displaying the progressive fibrosing phenotype, are at a higher risk of acute respiratory crisis, and can suddenly decline with an acute exacerbation to acute respiratory failure status. So to us, the pulmonologist, the development of a progressive fibrosing phenotype should be treated as a major red flag, triggering an immediate discussion with the patient and between us regarding transplant feasibility, and an early referral to a transplant specialized center is the need of the hour, as per Dr. Raghu some time ago. Just to show you that how important it is that an IPF, as per the chances of death, the 5-year survival, as I was telling, IPF's 5-year survival is somewhere around 25 to 30%, and all these are different cancers, and only the lung cancer and the pancreatic cancer has a lower survival than them. Most of all the other cancers has a better survival than an IPF after diagnosis. So let's now talk about the candidate selection. As per the ISHLT guideline, so the lung transplant should be considered in a patient with chronic end-stage lung disease when you have a 50% or more risk of death from the lung disease within the next 2 years if transplant does not happen. More than 80% likelihood that the surviving can happen for about 3 months after the lung transplant. That means the patient condition, general condition, is not so bad. And more than 80% likelihood of a 5-year survival from a general medical perspective, provided the patient is having a good lung function. That means the other organs are expected to function in a good way for the next 5 years. So the window is very important. Too early, your short-term survival without transplant exceed their post-transplant survival expectancy, which is in general about 7 to 9 years. Too late, if the patient has developed irreversible multi-organ failure with profound muscle wasting, that is sarcopenia, or active systemic sepsis leading to the surgical futility. I'll be talking about the few of the diseases where we should have this selection criteria. So there will be two things. One is, when do you evaluate or when do you refer for transplant, and when do you have to actively list the patient in the transplant registry so that the patient is now having much worse lung function as on acute respiratory failure and needs transplant within next 3 to 6 months. So let's talk about only the active listing registry criteria. So significant last 6-month decline in ILD with an FVC of decline of more than 10% or a DLCO of more than 15% is important. Oxygen saturation declining less than 88% on a 6-minute walk, or needing for resting supplemental oxygen. Secondary pulmonary hypertension has developed with a mean PAP of more than 25, or a severe acute exacerbation of ILD has happened, and these are an important consideration for transplant, as post exacerbation in an ILD, in an IPF, or any other CTD related ILD, the post exacerbation mortality exceeds 50% in the next 3 months. What about COPD? When to place on the active listing registry, when the board index, that is the PMI, FEV1, MMRC, and the 6-minute walk distance combined, the board index happens, so is more than 7. When that in that time, the 2-year survival probability is less than 70%, matching a post-transplant survival. FEV1 is less than 15%, hypercapnic respiratory failure is happening, and moderate to severe pulmonary hypertension is there. For COPD, when to list is an important decision, because it is not as clear cut as an IPF or other connective tissue disease related ILDs, because a COPD patient can prolong their life even longer with oxygen. However, with a board index of more than 7, or with moderate to severe pulmonary hypertension and in recurrent hypercapnic respiratory failure, is an important consideration when to list a COPD patient. For CF and bronchiectasis, there will be FEV1 less than 25%, frequent pulmonary hospitalization, massive hemoptysis are important criteria. For pulmonary arterial hypertension, a refractory functional class 4, or a cardiac index less than 2 liter per minute per meter square, with an elevated right atrial pressure, and again with pulmonary hypertension features like syncope and refractory hemoptysis are important criteria. Absolute contraindications: recent or active malignancy is an important thing. Generally, a 2 to 5 years disease-free survival interval is needed. And the other thing is irreversible multi-organ dysfunction like renal, hepatic, or cardiac problem, uncontrolled systemic infections with severe disease, active TB, untreated deep tissue fungal infections are also an important problem for absolute contraindication. The other thing comes into mind are the psychiatric disorders and non-compliance, active substance addiction, at least 6 months of documented abstinence. For lung, it is smoking, and all the other problem areas need to be addressed. Complete lack of social support are the other absolute contraindications. Relative contraindication, mostly it is on the age and frailty. Advanced age limit of about 65 to 70 is relative contraindication, along with the physiological reserve. We basically take care of the physiological age than the actual age, and how is the physiological reserve, whether there is frailty involved or whether the other organs are involved, is an important considerations. The common medical comorbidities: diabetes, coronary artery disease, which is not amenable by bypass surgery or a PCI, is important, along with a severe GERD. This must be kept into mind, because GERD needs the lung, perhaps the ILDs have happened because of the GERD, and post-transplant, the GERD can make the transplanted lung bad again. So that need to be evaluated thoroughly, and if needed, surgery need to be done for the GERD. The frailty and the obesity part comes into picture very often. BMI more than 35 is an absolute no-no for a surgery, and we usually target below 30 for the BMI, and also severe cachexia with a BMI less than 16 is a relative contraindication. Sarcopenia and frailty is a very important consideration for us, and the sarcopenia scales are available. For with that we check the patient sarcopenia level and also the muscle quality and the frailty assessment. I will pass through those. So how is the outcome? The survival benchmark and survival factor wise all over the world. Currently, the median overall survival is about 6.7. 1 year survival is around 82 to 85 percentage. 5 year survival is around 58 to 62 percentage, and 10 year survival is about 35 percentage. The better survival is seen with the CF and primary pulmonary artery hypertension with about 9 years, and ILD and COPD is about 5.5 to 6 years kind of thing. The recipient age, donor recipient HLA matching, baseline serum creatinine, pulmonary hypertension, and pre-transplant functional status. The very important 4 criteria on which the survival depends. ECMO to transplant. I think it will be taken up by the next speaker. I would like to point up the only few things that ECMO bridge to transplant happen. Obviously, the quality of life and the survival comes down from the 1 year post survival with an ECMO bridge to transplant 5 to 82 percentage, whereas a stable on home oxygen will have a better survival of around 88 to 92 percentage. The PGD rate is much higher. Why it is? Because the PGD rate is much higher. Surgical hospital stay, ICU stay, and the infection rates are higher, and the renal replacement therapy need is actually much higher. And why it happens? Because of the surgical hemostasis, bleeding, inflammatory activation by SIRS, and multi-organ strain are the commonest problem areas. So our idea is avoid ECMO bridge as far as possible, avoid ventilation bridge as far as possible. And if we have to do on ECMO, then try to have it an early versus late ECMO. You don't want, try to have an early ECMO initiation if you feel like the patient has deteriorated enough with a refractory hypoxemia. Within 12 to 24 hours of refractory hypoxemia, initiate VV or VA ECMO as needed. And the late salvage cannulation when the patient is crashing, again, patient will be having problem from that with secondary coagulopathy, may have a brain injury, may have multi-organ hypoxia and ischemia. So target is early ECMO initiation rather than late ECMO initiation. We target awake ECMO versus an intubated, ventilated kind of consideration. And a few of our statistics, MGM, we have got about 120 double lung transplants, 27 heart lung transplant, and post-COVID of 19. Our 5 year survival is 68%, which is better than the ISHLT numbers. It could have been better had we get the patient, as I said, when we choose to get the patients, but unfortunately we get referral from all over the country, and patients are mostly referred late on ECMO, on ventilator, and that's how perhaps the 5 year survival is could have been much better if we get a referral early. So when it is too late for transplant, the surgical futility, irreversible multi-organ failure, acute kidney injury, needing dialysis, severe sarcopenia, and complete loss of physical reserve is when the patient is bedridden, quadriplegic, or demonstrates profound vertebral cachexia. Active uncontrolled sepsis or a septic shock has got almost near zero utility. You need to do pre-transplant, rehabilitation and rehabilitation towards management of the sarcopenia and the frailty issues. Ambulatory ECMO is our target, and almost all patients on ECMO will be on ambulation. So, what are the too late red flags? These are severe sarcopenia, bedbound more than 4 to 6 weeks, recurrent sepsis, ICU delirium, no rehab potential, multi-organ failure, and needing CRRT. So the optimal window is early, and when the patient does not have all these problems, and when the patient is mobile, not having much sarcopenia, not having the weakness, severe weakness. So the lesson learned, lost optimization window is a area where our lung transplant survival is coming down, multi-organ atrophy, and the crash listing and salvage bridging is perhaps reducing the patient's outcome. The clinical red flags we have discussed: acute exacerbation, growing oxygen requirement, declining in lung function. Try to send the patient to the transplant center towards immediate listing. And the bridge, if you have to do with either a ventilator or an ECMO, try to do it as early as possible. With patient must be mobile. And in conclusion, lung transplant is a highly complex, life-saving therapy, but its success depends on the meticulous and timely selection of a right patient. Refer early, list appropriately when the window is there, understand the too late thresholds we discussed, harness the modern mechanical support, and try to have a person on early versus late ECMO support. And finally, these are the patient's outcome. This man is walking up in his home after 5 years of transplant, up to fourth floor of his home without stopping. And this lady is doing horse riding. So the success of a lung transplant program is not measured in the number of salvage surgeries we have attended, but by the number of patients we can safely guide into their golden window of recovery. So let us collaborate to ensure that no candidate is left behind and no life-saving organs are lost to futility. Thank you.
Thank you, Doctor. Pavitra Sinha Rai. That was excellent presentation of the lung transplantation. Nowadays, it's very important after the cardiac transplantation. So the more and more number of cases are coming up in India, and especially after the interstitial lung disease. But how do you select between the double lung transplant and single lung transplant, basically the organ? How do you select the cases?
Can you please come with your question one more?
So how do you select the single lung transplantation versus double lung transplantation in our cases?
So the question is on single or double. We always target double lung transplant.
Yes.
Because the outcome is much better with a double lung transplant. Single lung transplant is only we accept when a patient is in the very high elderly age group, like 79, 78 kind of thing, where by that way we can reduce the transplant surgery time and all these morbidity post surgery. That's one. And the other one is when we have in India specific one is the post TB destroyed lung. Like say left side is an extremely small thoracic cavity now because of the say 20 years of destroyed lung. The thoracic cavity has become very small. You cannot fit in a lung there. And the right side is much bigger. In these kind of scenarios only, we prefer to have a single lung. But I can say in 99% or 95% is or double lung.
Thank you. Thank you. Most of these patients are also having pulmonary hypertension also.
Yeah.
And stage lung cancer.
Yes, that
Yes.
is the biggest challenge because the outcome with a patient with a severe pulmonary hypertension is lower, as I have shown in it there. So the target is always to take the patient early and to avoid the pulmonary hypertension to happen, start the patient on oxygen. as early as possible. The patient who is waiting for transplant should have good oxygen support because hypoxia is the biggest reason for the pulmonary hypertension to happen. So if you want to postpone or reduce the pulmonary hypertension along with all the drugs, which perhaps does not work other than a CTD related CTD related
Thank you very much.
thank you. Unsure.
Pulmonary hypertension.
Primary pulmonary hypertension. Yeah. There are, we have transplanted in last 5 years, perhaps, I think 6 or 7 patients on primary pulmonary hypertension. And as they're young, they do really good. And most of the time it is the heart lung transplant is not needed. That depends on the right heart cath and how is the LV-EDP and the left atrial pressure kind of thing. But most of the time we have seen that bilateral lung is good enough for a primary pulmonary hypertension.
Sir, most of these patients are in respiratory failure, and some of them are on the ECMO also. In your experience, what is the optimal time? How much time we can make them comfortable on ECMO before the availability of the donor lungs?
I had some data for our hospital.
Yes, sir.
I did not have time to show that.
Yes.
On an average, 50 to 55% of our patients who had to go on to ECMO will be waiting for about 2 weeks and more for getting the lung. Unfortunately, the maximum patients I remember is 4 months kind of thing, waiting on ECMO, 4 months plus, and another was about 2 months plus something. So we would prefer a patient, maybe the best outcome will be below 7 days of ECMO and 7 to 14 days. Anything above 14 days, we are in a tight territory where the outcome is dubious or doubtful. But the excellent handling by ECMO by my next speaker and Dr. Bala sir and the whole team, the outcomes are really as good as where I trained in Toronto.
Okay. Thank you. Thank you, sir.
Thank you.
Thank you very much.
Thank you for answering a critical question and providing invaluable criteria, Dr. Roy, sir.
Okay, next moving on to the next session. I know everyone are hungry, but let's wait for 15 more minutes to witness a great engaging lecture delivered by Dr. Murli Krishna sir, who is a senior consultant at the Institute of Heart and Lung Transplant and Mechanical Circulatory Support, which is recognized by advanced medical circulatory bridges and specialized ICU critical care. He is going to present an absolute lifesaver of the modern ICU question, that is the ultimate bridge role of ECMO in the modern ICU. Over to you, sir. Thank you.
Good afternoon, everyone. I'm Dr. Murli. My sincere thanks to the organizing team for this opportunity. For the next 20 minutes, I'll briefly introduce to ECMO and what role it plays when you handle any patient in the ICU. Okay. So we'll start with 3 different case scenarios. The first one is a young female. She has a very bad bronchopneumonia, intubated, 100% oxygen prone. In spite of that, you see that the saturations are low, 100% FiO2 from venti. Sats is only, let us say, 80% in this case. The second one, again, is a young male. He has an acute MI, cardiogenic shock. You put the patient on balloon, you start on inotropes. Still, the patient doesn't settle, and the lactates are worsening there. And the third one, again, is a young patient who has a DCM. who is waiting for a heart transplant, but before he gets a donor, he deteriorates and then he goes into a cardiogenic shock. Here also, you have put a balloon, you've started on inotropes, still this patient not settled. What is common in all these three cases is the fact that if we have time, these all three patients can be saved. The first one, if the lung recovers, the patient will do well. The second one, AMI, if you revascularize, it can settle down. The third one, if they get a donor, they can just do well. So in all these cases where we just need that time, but the vital organ, say the heart or a lung, is so bad that it cannot support the life there, and we need that specific time, ECMO is the one that buys us the time. So let's look at it in brief in the next 15 to 20 minutes. So this is an ECMO showing the different components of it. What you are seeing here is a schematic diagram. What you are seeing here is a video of a patient who is on the ECMO. You have the cannula which are inside the patient. Then you have the tubings. This is connected to a pump, which essentially works the work of a heart there. Then the blue one is the oxygenator, what you are seeing there and here. Then you have the post-oxygenator blood, which you are seeing in the bright color. That's the pre-oxygenator is dark, the post-oxygenator is bright. So oxygenator is where the gas exchange happens. And as you see, the bright light is returned back to the patient through another side cannula at a different site there. So to start with the different types of ECMO, we have the veno-arterial ECMO. As the name VA says, you're taking the blood from the venous side and you're returning it to the arterial side of the limb. So this particular patient was a DCM who was waiting for a heart transplant, deteriorated, and we have put on the ECMO. So this particular VA ECMO, when in VA configuration, supports both heart and lung. So patients with both heart failure and lung failure, this can support there. On the other side, the other configuration is a veno-venous ECMO, where you drain from the venous side and you return it back to the venous side. Since you're not involving the arterial side of the circulation here, this supports only lung. This particular patient is a patient who had a viral ARDS, and we have supported it with a VV ECMO in this case. So apart from these two, the VA and VV, we have one more, a little complex one, that is a veno-arterial venous ECMO, where you drain from the venous side and you turn it both to the arterial and venous side. This is used only in special situations where you have some issues either with VV or VA. But per se, VA alone will support both your heart and lung. This is used only if you have some certain complications with the VA. That is when you go with the VAV ECMO there. So we dealt with the types of ECMO. Let us look at what are the indications and contraindications. When do we go or choose an ECMO in a patient who needs that kind of thing? To start with the veno-venous ECMO. So this is the main thing what we need to know. Like we have seen before, this supports only lung. This does not give any support to the heart. So if the patient cardiac function is poor, we should not consider this. We should go for a VA ECMO. So if the isolated lung problem, we should consider this. And a general thing for any patient for ECMO, this ECMO, whether VA or VV, should be considered only if the patient is not responding to maximal medical therapy. Just because a patient has an ARDS or has an MI doesn't mean we put the patient on ECMO. We should try the conventional medical measures, like in a case of a lung failure, your maximum ventilator, prone ventilation of the patient, sedate, paralyze, and ventilate. All these we should try, and only when you are not able to stabilize the patient with that, that's when the ECMO comes into the picture there. So grossly, whenever we talk of ECMO, we talk of the context of bridge because it's only a temporary support. This bridge can work in two forms where you expect the lung will recover, a short-term pneumonias or a bronchopleural fistulas or any other problems. That's where you call it as a bridge to recovery. On the other side, if it is a totally damaged lung and just need to wait for a suitable organ, then you look at a bridge to transplant. But one thing has to be clear, before we consider ECMO, we need to know what for we are doing the ECMO in this particular patient there. If you look at clinical indications or reasons for requiring ECMO, any respiratory failure due to any cause, like what you see here, you can consider ECMO. It can be pneumonias, it can be aspirations, it can be post-transplant failure, pulmonary contusion, pulmonary embolism, air leaks, any possible respiratory failure, you can support the patient on ECMO. Along with that, an emerging thing is the peri-procedure support. Like as now more and more patients who are at high risk are undergoing complex intervention pulmonology procedures, you use this as a peri-procedure support for both interventional pulmonology and some surgical procedures there. So when do we consider? Very simple. We have two types. One is hypoxic and a hypercapnic failure. If it is a hypoxic respiratory failure, when your PF ratio is less than 80, we should consider an ECMO. If it is a hypercapnic respiratory failure, what you see is not your PCO2. You look at the pH. If there is a respiratory acidosis, it should be a pure respiratory acidosis, and the pH has come down to less than 7.25. That is when you start considering the ECMO. In hypercapnic respiratory failure, when you're managing this patient, it's extremely important that you don't cross this, whatever the set ventilator settings. You never try to cross a plateau pressure of more than 30, and you don't cross a respiratory rate of more than 35. Because if we do that, the lung can possibly go for a permanent damage, thereby hampering the recovery there. So this is when we consider doing the ECMO, PF ratio of less than 80 or a pH of less than 7.25 in a hypercapnic respiratory failure. But what this guidelines doesn't tell us is the level of preparation of a center that we should always take into account. If this patient is in a quaternary center where it is available 24/7, we can try and do it whenever we want it. On the other side, if it is a peripheral center where we need time for the help to arrive to do the ECMO, we should consider it little before. Typically, a PF ratio of 100 or less than 100, we should start thinking about the ECMO. What also the guidelines doesn't say is the time the family needs for preparation, both psychologically to sign the consent, and second, to arrange finances for a costly thing like ECMO. So taking all this into consideration, when we see a patient who is progressively going down, when you're looking at that you possibly may reach this kind of marks in your blood gas exchange, we should start considering it little early and start speaking with the family members there. So what are the contraindications? There are only absolute contraindications which are relevant there. If the patient is having a cardiac failure, it has to be a VA ECMO. And if there is no exit option, to give an example, a patient with ILD and the lung is not going to recover, the patient is not for a transplant, either not willing or not a candidate, we should not consider an ECMO. There are a lot of relative contraindications, but these all should be taken and considered on a case-by-case basis. A lot of these relative contraindications also, we can still go ahead and do the ECMO there. So let's look at a VA ECMO when it should be considered. As we discussed before, this has to be some sort of bridge. That can be a bridge to recovery, like what we saw the other case, like an acute myocardial infarction, or a bridge to transplant or a LVAD, where your patient is having an end-stage failure, and you know that you put a patient on VA ECMO. Once you get a suitable donor, you can go ahead and transplant. Two other things also come in the VA ECMO. That is a bridge to bridge. You have several types of mechanical circulatory support. You can start with ECMO and subsequently convert it to another mechanical circulatory support. That's when you call it as a bridge to bridge. Or if things are not clear, we're talking of VA ECMO when a patient is in cardiogenic shock. If it is a young patient, you don't have time to decide or think. If he's crashing, you just put the patient on ECMO and then further plan what is the problem and what needs to be done there. So these are the gross indications when you look at the VA ECMO there. If you look at the clinical scenarios, any reason that causes a hemodynamic compromise, any reason that causes a hemodynamic compromise due to cardiac reason, any of that can be considered as an indication for the VA ECMO, like whether it's a post-MI cardiogenic shock, post-cardiac surgery, cardiomyopathies, chronic heart failures, myocarditis, any of this can be considered. What is now in expanding pool is a lot of drug toxicities and poisonings, where the patient has a cardiac depression, you can consider. Also, ECPR, when a patient is arrested, you're not able to revive, you can consider. Acute anaphylaxis, the patient suddenly crashes, you can consider. Or peri-procedure support. Again, interventional cardiology has increased tremendously the scope of it, where there is a high risk of arrest during the procedure. You use electively ECMO, support the patient, do the procedure, and win it off after the procedure. And a patient with sepsis with myocardial depression. Sepsis without myocardial depression, not an indication. Sepsis with myocardial depression is an indication for doing a VA ECMO in patient who is in the shock there. So any cardiogenic cause leading to a shock, we can consider the VA ECMO. At what point we do consider? These are the contraindications. Again, the absolute contraindications are based upon like when the aorta doesn't permit a regurgitation or a dissection there, or the patient is very moribund, that is when you see an absolute contraindication. Relative or always case basis, like the patient age, all these are there, but again, you take it on case by case basis. We have done in neonates, we do even in 80-year-olds, and you do it like if the patients who cannot anticoagulate also. But these relative, you take it on case by case basis there. So at what point we do consider the standard sky staging we have in that the shock when it is progressing from stage C and beyond. Once you start some inotropes that put the first level of support, that is a balloon. If the patient is not not improving and going to stage C or stage D, that's when we have to start thinking or doing the ECMO at this point. We can do even in stage E also, but if you do in stage E, the outcomes are clearly shown to be worse when compared to doing in stage C or stage D there. A lot of things you need to monitor when a patient in cardiogenic shock. When we looked at respiratory failure, it was very clear. You're looking only at the PF ratio or the pH there. But when it comes to a VA ECMO cardiogenic shock, you have to monitor a lot of things. But grossly, this is what it boils down to. If your patient is not maintaining adequate cardiac output, with a simple examination, your peripheral pulses are not there, urine has come down, lactates is going up, acidosis is worsening, and a second organ, most common is the kidney. If the urine is unsettled, patient is deteriorating there, and whatever the measures you have taken, your inotropes or a balloon, is not improving the patient, that's when we should go ahead and do it. VV gives us a time of, say, 10, 12 hours in a lot of the cases, but VA doesn't give us so much time. A lot of times we have to rush into the VA ECMO there. Apart from this, whenever a patient is having a high risk of cardiac arrest, that is having malignant arrhythmias and all, we can consider that. Or like we spoke before, when the return of spontaneous circulation is not possible in a cardiac arrest patient, we go ahead and do the VA ECMO there. Okay. So how do we do this? Giving. This is what it is. You have two types. One is the central ECMO, where it is open and done. Usually it is done in the pediatric patient where surgeon cannulates and does. What is commonly practiced is a peripheral ECMO. Again, that can be surgical or percutaneous. The commonly used one is the percutaneous because it has all these advantages. You can do it bedside. You can do it anywhere. This can be done by any person there, and you can do it off very quickly. You just need 10 minutes to establish the patient on the ECMO. You typically start with screening of your vessels. Once you choose the vessel, you take an ultrasound guided puncture there. And once you do the puncture, you put your guide wires both in the artery and venous based upon what you want to do. You confirm your guide wire position, IVC and aorta there. Then once your guide wire is confirmed, you serially dilate. There is a set of dilators that come in the ECMO circuit. And then you dilate them. And finally, you cannulate the patient based upon what size cannula you want there. If it is a veno-arterial ECMO, like once you put the cannula, you confirm the cannula position. If it is a veno-arterial ECMO, you would like to keep it in the right atrium. If it is a veno-venous, depending upon the patient's ECMO configuration, the drainage is usually in the RA-IVC junction, and return is placed in the high RA or in the RA-SVC junction. And like I said, if it is a veno-arterial, you place it in the right atrium, the cannula tip there. If the patient, we have choose a peripheral VA ECMO, it's always important to put the distal limb perfusion because once you put the arterial cannula, the blood flow to that limb will be compromised and this patient will have a risk of having a limb ischemia. So in a VA ECMO, done peripherally doing a distal limb perfusion is always a must there. So once we put on ECMO, you go for maintenance, like caring of the patient once you do on ECMO. That's an elaborative thing, but to put things in a very simple perspective, this is what it is. You target your anticoagulation. Your main challenge is handling your anticoagulation. Typically is heparin titrated to APDT or anti-10A levels. A very strict infection control measures. One of the major cause for loss of life in ECMO patients is sepsis, so you take care of it. Then as soon as you put and stabilize, you start addressing the primary issue, what the patient, the reason for which you have done ECMO. Is it an acute MI or is the patient having a ARDS or is waiting for a transplant? You start working on that. Along with that, you focus on not to lose the physical status of the patient, the nutrition, the rehabilitation. These all you focus and make sure that the patient is well preserved when you're handling the patient on ECMO. To just give an examples, you can prone a patient on ECMO, you can mobilize them. They keep doing the physiotherapy continuously when they are in the ICU there. So next come the question, can we shift a patient on ECMO? We can very safely shift a patient on ECMO. We regularly go across the country or even abroad. We have gone many number of times. When we get a call, we go there, we see the patient, we put the patient on ECMO there, and then we shift, whether it is a road ambulance or air ambulance. More than 200 patients we would have easily shifted. Till now, we never had a mortality. So ECMO shifting is safe, and provided you go in a systematic approach, meeting all the checklists, and then do it, you usually can be very safely shifted a patient who is on ECMO there. So what are the major complications when a patient is on ECMO? These are the ones. If you are doing a peripheral VA ECMO, your main worry is the LV distension. LV will get distended and you can have pulmedema. Different measures for that. They can do a surgical LV venting, or you can do a septostomy, or you can do an LV venting apically. So many options are there, but that needs to be handled there. The second complication that can happen again in peripheral ECMO with a reasonably recovering heart and a bad lungs is something called Knox-Horse syndrome, where the upper half of the body will have a desaturated blood. So the saturation in the brain and right upper limb will be typically less. Patient, like you see, the right upper limb saturation is only 79% in this patient in spite being on ECMO. when you see the left upper limb and the pulse oximeter is showing 98% at the same point there. So if you identify this, then you will be able to rectify this. You work on the lungs. If that doesn't settle, then you put a patient on the hybrid ECMO, what we spoke a little while before. Then other complication, which you see very specifically in the veno-venous ECMO, is a recirculation where the blood you give back from ECMO just comes back to the ECMO there. This commonly happens because of cannular position. Once you adjust that, that usually settles down. The common issues more than this, what you see in any patient on ECMO or this, you have a bleeding related complications, can bleed anywhere. So you focus on that and titrate your anticoagulation and coagulopathy accordingly. Second, as I said, infections are a major concern. So strict infection control measures, surveillance and appropriate care for the infections is extremely important. Then limb ischemia, we look at it. Apart from that, there can be ECMO circuit related problems like oxygenated failure, or general critical care related problems because these patients are generally sick or in the ICU there. So once the primary reason, whatever you have done the ECMO for is settled, say viral ARDS has recovered or MI has been revascularized, or it's like you have transplanted the patient, you start weaning. Typically for VA ECMO, you wean like this, you decrease the flows and see the vitals there. Whereas it is a VV ECMO, you use a blender and start coming down on the support of both oxygen and the gas flow. Once the patient wean to lower level and the cardiorespiratory function is good, then you go ahead and you clamp and see if the patient is tolerating well, then you can remove the ECMO and then plan further care in this patient. So this can be done in pediatric patients also. We have a large number of patients, pediatric patients who we have done ECMO. Then to sum up, this is the life-saving measure. They should be considered for all patients who have a failing heart or a failing lung. We need to be clear about what we are doing. Is this patient going to recover? That's when we are going to consider this. If it is not recovering, we have to put them on a transplant pathway at the earliest there. The preferred way of initiation is percutaneous, and a good critical care is what matters. Addressing the primary issue, taking care of the critical aspects, and a comprehensive care. That's what gives us a good result in this patient. Thank you. These are some of the patients.
Thank you, sir.
Thank you.
Thank you very much for the insightful session. Any questions? Audience, any questions, please? Thank you, sir. So this is the morning session, first session, and there will be like a let's break for the lunch. So we'll be convening back by within another 15-20 minutes by 2:15 2:20, so that we will be on schedule for the afternoon session also. And please carry your lunch coupons, which are included in your welcome kit, delegate kit. Please take it.
May I invite our moderators, Dr. Murli Krishna T. Sir, along with Dr. Damodar Rao K. Sir and Dr. Bhaskar Rao M. Sir. Now, I would like to invite Dr. Ankita Kulkarni ma'am to begin with the discussion, role of end-stage heart failure refractory to medical management. What next? Over to you, ma'am.
Good afternoon, everyone. At first, I would like to take this opportunity to thank the organizers for this wonderful opportunity. We here have an esteemed panel that will help us understand the nitty-gritties of managing advancing heart failure, transplant, LVAD, and answer some very practical questions that we come across in our daily lives. As we all know, heart failure has undergone a paradigm shift in the last decade from the kind of patients that we are seeing to the way we diagnose them, manage them. And yet, we still have certain patients who we cannot help with the standard therapy that is available. So, we are here to answer the question, what next, with our esteemed panelists who are experts in advanced heart failure management, anesthetists, cardiac anesthetists, and mechanical circulatory support. We'll go ahead with a case. Now, this is a stable heart failure patient that we come across in the OPD multiple times. He was a 68-year-old male, heart failure with reduced ejection fraction, had ischemic cardiomyopathy, has undergone a CABG some 7-8 years back, is diabetic, and for the past 2 years has had 2 heart failure admissions, but currently is in NYHA class 1 to 2 with no symptoms. He's on guideline directed medical therapy and appears to be stable. He's on GDMT in the form of these tablets. So the question is this the right time to refer this patient for advanced therapy or do we wait? We can ask the cardiologist to please weigh in.
So once we have a patient with diagnosed ischemic cardiomyopathy, we probably would also like to have information on his coronary status and his left ventricular function, whether any viability assessment has been made.
So, sir, his coronaries are well perfused. The grafts are patent. His native coronary vessels have not shown any progression of disease. His EF, though, remains to be 25%. There is not much of scarring on cardiac MRI, and there is mild to moderate mitral regurgitation.
So now I think now that the patient has this kind of significant LV dysfunction for quite some time, and he go on medical therapy appears stable, the chances of his, getting into improved LV function are quite less now. Obviously, the first important thing is symptomatic status, whether he, is symptomatic with routine activity or not, and then his exercise capacity one has to look into whether he's on optimized guideline medical directed therapy or not, including obviously the important 4 pillars of heart failure. He's tolerating them or not able to improve upon his heart rate optimal levels. Those things one has to look into. Once they are all there, the patient is asymptomatic. Obviously, it could be managed with the cardiologist.
And then one has to keep in mind that at any point of time he might require, advanced therapies. So, what do you say? Do you think that the asymptomatic patient heart failure, should he be assessed with a heart team, cardiac failure team, and then be incorporated into the transplant list or not? If EDMT, if they're well stabilized, and as you're saying, they're asymptomatic, they ideally need not go right away for it. They just need to be on a like a waiting stage, or they can just be like educated or informed and left there. So that can be like that like depends upon the way it is practiced. So not the cardiologist practicing, that can be under the cardiology care. Or if it is a team-based approach anywhere, that can just come in that team meeting discussions or like orientation session for the patient. But in one word, asymptomatic heart failure, well optimized on medical therapy, can wait until there are some red flags in different. This patient basically requires to be complex medication and then statin therapy and then heart failure therapy and importantly exercise. Whatever cardiac directed exercise should be maintained. And importance of the statins, lipid levels, weight, and all those things. And of course, the cardiologist should decide when the patient requests to go to a transplant clinic or enrollment. Any of the other device therapies or any considerations for recruitment into heart failure therapies. Otherwise, sir, I think the patient can be maintained on medical.
So, what do you think are the challenges to optimization of GDMT that you face in daily practice?
Each depend on whether he is tolerating beta blockers, is tolerating, what about his renal functions, whether he's able to be maintained on, renin angiotensin inhibitors, potassium levels. So those things have to be addressed. And then, if he has been able to take those things, that's fine. Um,
Already MRI done.
Yes, sir.
Yeah, viable date. One.
Viability has been done.
Viability has been, that's what.
Okay, I missed the slide.
Yeah,
It is not viable. Huh? What is the
So the
scar
graph,
burden? What is the
he's,
scar burden?
he's well revascularized. There is no scar burden that is obvious on the echo, on the MRI, sorry.
Okay. So you think it is not
But
ischemic cardiomyopathy?
sorry, sir.
You think it is not ischemic cardiomyopathy? It's
There
dilated
must be
cardiomyopathy.
some underlying dilated cardiomyopathy as well, and he had some additional insult in the
The
form
word
of.
ischemic cardiomyopathy per se indicates you should address ischemia also.
Yes, sir, but the ischemia was addressed. Despite that,
No.
his EF remained.
What you're saying is patient is a cardiomyopathy patient. He has past CABG. Myocardial viability is good. Scar burden is minimal. In such patient, it should not be no more termed as I think ischemic cardiomyopathy. It should be termed as DCM.
There is a mixed component of both, sir.
Now, I think, see, the thing is that we are not clear when the patient has coronary heart disease and obstructive atherosclerotic cardiovascular disease with coronary component, still persisting to have LV dysfunction. We don't have a uniform definition for that. Patients with dilated cardiomyopathy, normal coronaries, still fine. Even without addressing whether microvascular angina was there or not, all those things were different.
The microvascular obstruction can also occur in DCM, can also occur in HCM, can occur in other conditions also.
But
per se, without a component of ischemia, I think how far we are justified. Leave alone. General term.
I don't think we have any answer for that because those both can coexist. Such conditions, I think, coronary heart disease is there. OCABP. No confusion.
More
about it.
probably would be in DCM with a past history of CABG with myocardial good viability.
Unless the
How can
patient had DCM established and then develops coronary heart disease, there is no way we can say whether this is present or not, or that is present. So, In any case, once so much of time has elapsed, post CAPG, patent grant, and of course the LV function has not improved with optimal medical management, the management would be almost the same, including the indications for ICD. That's what the next question is, that the LV function it remains at 25%.
Yes, sir.
Should we consider the patient for ICD?
Yes, sir. That is additional question, whether any other therapy can be offered, and would you consider him for an ICD, primary prevention?
And we really should be registered for the program on next year's program also.
Yes.
All patients who have significant severe LV dysfunction should be considered for ASCD without any symptoms or without any heart or monitoring abnormal findings, especially when the symptoms are not even class 3 or class 2.
Post coronary heart disease, even if it is an MI after 40 days or 50 days or whatever, even 2 months, the persistent significant left ventricular dysfunction, ICD is a class 1 indication, and this patient definitely falls into that category. Primary prevention, even without Holter showing significant ventricular tachyarrhythmia or management, still qualifies.
With all due respect to all of you, I think all this was done when this guideline directed medical therapy were not optimized. Now I'm an outsider. I'm not sitting in any corporate hospital. I have seen n number of idiopathic dilated cardiomyopathies. With the advent of guideline directed medical therapy, many people are doing wonderfully well. Very few people who are sending nowadays for CRT or ACD. Not sudden deaths are complete, not I would just say not completely, markedly come down. Beta blockers are doing very well. Sacubitril/valsartan is doing very well. Dapagliflozin or empagliflozin is doing very well. Spironolactone, epranolone, so many drugs have come. They're doing very well. Cardiorenal, some of the more entire metabolics or hemodynamics are completely been revolutionized by these wonderful drugs. The armamentarium has completely revolutionized. I don't think all patients require ACD compared to a decade or 2 decades back.
Uh, See, what you say has significant relevance in the sense that last decade, this quadruple treatment that has come up, symptomatic status has significantly improved. And also,
Mortality also markedly improved.
some of the studies have shown that with these 4 drugs, people who are able to tolerate optimal dose of all these 4 drugs, the left ventricular ejection fraction also has significantly improved. Such kind of patients, they would be out of the list of ICD. But what about the patients who have persistent significant LV dysfunction despite GDMT? Uh, Do we, I'm going to let them out of the waiting list of ICD? I'm not sure. Because we are still in the beginning of these major effects of GDMT, latest generation of, all these 4 classes of drug. We have seen some of the studies showing that there is a significant increase in the left ventricular ejection fraction with passing time, which definitely rules out some of the patients who are initially planned for ICD. But this case is different. This case continues to have significant LV dysfunction despite optimal doses of tolerated maximal therapies. In that case, probably this patient would be a candidate for class 1A indication of ICD.
EPS studies will help in such patients. EP studies help in such patients.
In this case, see, not when you have a significant LV dysfunction persisting, but they definitely EP studies are indicated when there is ambiguous Holter monitoring, sudden cardiac death suspected but not confirmed, revived. Those kind of patients, definitely yes. Like like all of you, what you put everything is perfectly dispensed.
Like those category of patients who are improving after putting on GDMT, they just need to be on that. Who are stable at the steady level, even with that, can probably continue under close watch. If the discussion just comes down to the category of the patients who, despite maximal medical therapy, are worsening. So, like the red flags which we probably look, or what should be the next step there in that category of patients who, despite the maximal medical therapy, are worsening. So that worsening can be in many forms. In a very simple way to look at is that hospital admissions, like which this case had, a 2 hospital admissions in 1 year is always considered as a red flag, which needs the patient needs something more than this, unless at that point of time he has skipped on the medicines, which clearly shows a reason kind of things. In this category of patients who, despite maximal medical therapy, are worsening, our concerns are only two, three, whether this is going for a very high pulmonary hypertension, or is he developing a cardiorenal syndrome, or is functional capacity going down, or is he at risk of a sudden cardiac death. So these are the concerns. The further things what they need is like one, looking at the ICD, whether they do need it, and then go for the ICD. That is one. Second, for the further care and management, they need if the patient is fit enough to undergo a CPET testing. So CPET testing, I think, will tell us where do we stand in terms of your VO2 max. If your VO2 max still more than 12, 14, then we are in safe range. If it is less than 12, then certainly we need something there. Along with that, what really helps us is a right heart cath, which tells us where do we stand. Is the right heart cath, it's not just only for to list a patient for transplant, but the precise numbers what we get about the SVR, PVR, RA pressure, LA pressure, that tells us which specific part of the medical therapy can be furthermore optimized. If the SVR at the end of it is still high, then we can further work on the dilators. On the other side, if the right heart clearly shows that the patient cardiac output per se is low, the venous saturation is low, that means very soon we are looking at a patient who is going to have a significant trouble there, sir. So that category of patients in whom the right heart study shows they need a CPET and right heart, and that category of the patients in whom the CPET or the right heart shows red flags. That is where we need to take them forward, whether it is, the further therapies, whatever we can offer surgically for a heart transplant. In the meantime, to keep them, in a simple words, to keep them alive, we need that ICD as a bridge or whatever the support there, sir.
Especially in heart failure, we all know that, um, stage 4 patients, class 4 patients, the mode of death is mostly pump failure. And class 2, class 3 are the people who are at highest risk for sudden cardiac death mortality. So those are the people probably who will be requiring more of an ICD than at the end of the uh, spectrum of the heart failure evaluation.
What would be the ideal time to consider this as advanced cardiomyopathy and when to refer for transplant?
If we look at purely from the transplant perspective, we have to consider from both the ways. Like, did the patient reach that indications? Has he reached indications or still he doesn't meet? On the other side, has he missed the window? That is, does he have any contraindication or where we can say transplant also not possible? To look at both, like what we discussed a little while back, requiring transplant is when you have a maximal medical therapy, still having a red flag. In this case, very simply, 2 hospital admissions itself with failure and progressively worsening. Your exercise testing or a 6-minute walk, they all can point towards that. That's one. Then the right heart cath and CPET will tell you. Then if you are looking at did we miss the window? Did we miss the window? The patient not fit for a transplant. At some point we consider, okay, let us consider later, let us consider later. But in the meantime, suddenly it happens, he's not fit for a heart transplant. That can happen in 2 ways. In a slow form, if the pulmonary hypertension develops and the PVR becomes fixed, that goes more than 4, that's where the concern is. So that needs to be monitored. Second, if the renal dysfunction develops, whatever the reason, a patient with a renal failure, whatever we do in them, the outcomes are not as good as a patient with a normal renal function. So someone who is having worsening symptoms, worsening of pulmonary hypertension, or developing a right heart failure again, then who is having like worsening of the renal failure. Before all this happens, we should catch them in that window and put them on the spot.
So, guideline directed medical therapy is indicated in all heart failure patients and it improves survival. Although progressive symptoms, worsening biomarkers, intolerance to GDMT can be warning signs of disease progression. And a simple mnemonic, I need help, can help us refer patients and consider them early for referral. So, I need help is basically need for inotropes, progressive worsening of NYHA class or class 4 symptoms, any presence of end organ dysfunction in the form of renal failure development or hepatic dysfunction, ejection fraction being persistently less than 20%, defibrillator shocks, appropriate defibrillator shocks, recurrent heart failure admissions, escalating diuretic requirement, low blood pressure especially not allowing optimization of GDMT and progressive intolerance to GDMT, which can signify progression of the disease as well. Okay, so now this patient has presented 3 months later with worsening dyspnea and has renal impairment of creatinine going up to 1.8 milligrams per DL. After stabilization, we perform an angiogram and a right heart cath. Here, the right heart cath shows an RA pressure of 18, a wedge pressure of 28, and a cardiac index of 1.8. He has elevated PVR. The aortic pressures are 90/50 and the heart rate around 110 beats per minute. First, I would like to ask the cardiologist, how would you like to optimize this patient? And how do you differentiate between end organ dysfunction that is reversible versus irreversible? His creatinine has risen with acute decompensation of the heart failure as well as indicated by higher pressures.
We can see that left side pressures are quite high.
Yes, sir.
Pulmonary capillary pressures are increasing. So there is a mild elevation of the creatinine also. So we'll have to clinically the patient has worsening dyspnea. I think he's going into decompensated heart failure. So definitely yes. He whatever parameters of renal impairment are not consistent with the kind of clinical deterioration. Probably we have to go in that direction.
This like how do you differentiate reversible from irreversible? Like both the perspective, we're looking at both here lung and the kidney. If you look at specifically for the right heart cath, if you're looking for the lung, we need to obviously look at the TPG. How much is the TPG or how much is the PVR? If the PVR is anything more than 3, you try to do a vasodilatory. Vasodilatory again depends upon the only difference in this chronic heart failures is the vasodilatory that is typically done in the cath lab because cath lab timings are always short at the end of 1 hour or 1.5 hour. We have to shift the case, will be a case next to it. So probably a prolonged vasodilatory challenge, keeping the patient in the ICU, bringing back again and then getting the numbers again will help us whether we stand as a reversible or an irreversible disease. That is from the lung perspective. 90, yes, sir. You have to slowly optimize that for putting on this one. Whether you can try a nitric oxide, inhale, all those things you can try and see whether it will work or not. But again, like sir said, it has to be done under a close supervision of all the hemodynamic parameters. Second, the other main organ what you're looking at is the renal depth. Whether the patient has a irreversible or a reversible renal disease. That again, like it's not a perfect white and black. There's a gray zone there. But what really helps you is looking at the simple thing is how long the creat, looking at the old patient's file, is it a chronic disease or is it an acute? Get an ultrasound abdomen done, get a nephrologist, get a urine routine. All these things will help you in identifying whether it's an acute or a long-term renal disease there.
Is there a specific choice of inotrope that you prefer in patients with cardiogenic shock? Sorry.
Unless the patient has renal disease pre-existent or parameters by, as said, by either urine analysis or by ultrasound, first thing you should adequately treat the right heart failure because the most often commonest cause is elevated renal venous pressure. In spite of that, the renal creatinine continues to worsen. Then you should always think of probably the organ has been irreversibly damaged. That should be kept in mind regarding the kidney in heart failure, advanced heart failure.
I think receiving maximum level of vasodilation and creatinine mounting up on we are developing right heart failure. Do any further medical therapy, we should consider program.
So is there a specific inotrope that you would prefer in this patient or either is okay? Dobutamine, milrinone, noradrenaline, something that you would prefer or
Only Previously, this because the dopamine, because of its dopaminergic receptors, better handling of the creatinine and renal hemodynamics. Now this noradrenaline has an edge over the other inotropes. Means inotropic support in heart failure. Norad has more
I know
more
they
beta
have
now.
proved any survival benefit.
No survival benefit. Only all these are only bridging therapies. They're not survival. Advanced heart failure, inotrope preferred nowadays. The concept is Norad. Actually, there's an article in MGM a decade back where it has been proved that it is superior to other inotropes. Norad. I forgot the trial's name also. I read the article in MGM a decade back. Norad is the preferred inotrope in advanced heart failure support for. It's always temporal, and then none of the inotropes have proved to improve the mortality also. None of the inotropes in either acute or chronic.
Again, all depends upon the hemodynamics. Set like one side of it is like they certainly don't tolerate high pressures. The 12V, whatever will be very sensitive to afterload. I mean, a normal pressure 110, 120, we may be happy to see the number, but that LV, on the contrary, will be like struggling more or will go for a low cardiac output. Inodilators are preferred if the patient, there is a scope for them, like inodilators, a milrinone or a dopamine. Preferably, we typically use milrinone. That's what we use. And as a second line dopamine, like in this patient, maybe the heart rate is 110 already on higher side. That one. If the patient is decompensated in milrinone, and if that causes a too much fall in SVR, to balance that out and maintain that mean arterial pressure, this is post CABG, you need that perfusion pressures. And again, if the creat is high, then again you need the perfusion pressures. To balance that out, in milrinone plus some norad titrated to maintain at least an adequate mean arterial pressure. That probably will be the best to do that. If you can give these kind of pressures, that would be really important to be cautious.
100% inotrope. 90 systolic, I don't think there's a role for a Mineral or Amber and all this. BP is must. It's a vasodilator plus inotrope.
With norad.
Yes. Sort of thing. Norad is a must with it.
Norad, yes, sir. I mean, that has to begin like on the context of the situation, sir. If the pressures are low just because the cardiac output is low, sometimes paradoxically, like milrinone also, you see an improvement in pressures because it improves a bit of cardiac output that itself will improve the pressure there. But this case, particularly being an ischemic cardiomyopathy, status post ABG, perfusion pressures we need to give a little higher. If this was like a history as a typical DCM normal coronary all along kind of thing, maybe they will tolerate even a much lower pressure, 80, 85 systolic also, we see that they tolerate well. So there you start with a very slow dose, keep titrating it, and just identify what is appropriate there based upon the hemodynamics.
So, what would be the role of mechanical circulatory support in such a patient? Mechanical circulatory support.
When they decompensate, it certainly has a good role. What is crucial is time, and what is crucial is you don't end up in having an organ failure. If this patient urine is like hourly 30 ml, 20 ml, you don't want to wait till it goes for a shutdown, and within the next few hours, you want to do it. And simplest thing which helps in most of the patients is a balloon. Though often underrated and under-recognized, IBP has a lot of advantages. IBP helps in these patients. And if the shock is quite bad, there's no native contractility. And again, you have to phenotype it, biventricular LV, how bad is the shock. Based on that, ECMO, or if it's something that helps in every possible way. But again, ECMO has your time bound. If it is an isolated LV and a patient can afford no other contraindication, it can be gone. That is only if it is a profound shock.
So most of the studies suggest that IOP is no good in improving mortality, but in Asian countries, it is still a very viable option. And I still remember 2026 Japanese guidelines, they still recommend IOPP as one of the primary things because most of the centers do not afford all the other insul or, VA and all. So IOPP still is there, though it is repeatedly mentioned that it doesn't improve mortality, but it can be as a bridge to some of the other definitive treatment modalities.
I mean, right, absolutely right, sir. One.
You cannot give him an IABP for long time. So as a bridge, I think you should go for fun and learn of something. Temporarily we can do IABP or before ECMO plus IABP. You should have a word, unless you get say sometimes hard immediate.
Yes, sir, all this way. IBP actually is wonderful, like sir said, helps a lot. What really makes the difference is patient, if someone is in sinus rhythm, that works one. On the other side, if this patient is someone who is in AF with fast ventricular rate, IBP will not make any difference. The essential requirement or essential thing that helps you in identifying that this particular patient IBP makes a difference is a sinus rhythm or a lower rate, even if it is like not a sinus rhythm, a lower rate. That category of patients, you see that it helps. And compared to all other MCLs, the main advantage with IBP is the complication rate is much less in literature, much less complication cost and all. Unfortunately, not heavily supported, but yes, it makes enormous difference. In these kind of acute on chronic heart failure patients, there is enough evidence that it helps in this patient. And just to comment, sir, very commonly used, like a lot of patients, we support 1 month on balloon and transplant. That is very common. Once in 2, 3 months, we have a patient like that. And we had 2 patients in COVID time, like who at the beginning of the first wave, when everything went to lockdown, they were waiting for the transplant and they went into shock. All of the hospital was empty other than the COVID patients. And these were the only 2 non-COVID patients in the hospital. They both decompensated. The entire, everything was shut down, so were the organ donations. So then we, ECMO couldn't think of because there was no end in oversight when the COVID will end, all these things. So we put balloons in that. We maintained them for 8 months and 9 months. Second wave ended, then we transplanted them. Both of them were good. So it can be used for a long time. We converted that to a subclavian balloon and kept it for a very long time. That's the longest what we have used, but generally 4 weeks to 6 weeks is very common supporting criteria.
Just the last this thing. So, what are the average waiting time for cardiac transplant, and how can we expand the availability of donor hearts?
You are the best person for it. Around like average, we say around 2 to 6 weeks. Depends. Someone gets lesser than that. Someone may take 7, 8 weeks. But 2 to 6 weeks, most of them end up in care. Yes, sir. 2 to 6 weeks. Yes, sir. It is, yes, sir. Donor heart is very crucial in those kind of.
I think we will wind up here, but we have answered quite a lot of questions. In the end, I would just say that we have to make sure that the heart is sick enough while the rest of the body is well enough and consider advanced therapies at the right time. Thank you.
Thank you, ma'am. Thank you, Damodaran sir, Bhaskara sir, and Murali sir. So now we'll be going to the next session. Yeah, please. Go to the answer.
Welcome back to our third and final session for the day, the Multidisciplinary Masterclass, showcasing the incredible breadth of specialty care offered at MGM Seven Hills Hospital. To guide us through this expansive session, please welcome our session moderators, Dr. B. Srinivas, Dr. Ravikumar Raju, and Dr. Chandrasekhar. I would now like to invite Dr. M.S. Ravishankar Sir, Head of Department of Nephrology and a transplant physician, a leading nephrologist in the region who spearheaded more than 1,300 renal transplants, orchestrating renal care, dialysis modalities, and complex live and cadaveric kidney transplants. Welcome, sir.
Hi, and good afternoon, everyone. So, me and Dr. Srinivas go back by almost around 22 years. I think we've been together since then, and it's been a great journey along with him. I still remember when I had come to Vizag looking for a job, he actually invited me, he asked me to join with him, and then he actually nurtured and then he took care of me there. And he does this not just with me, he's done it with all the nephrologists in the city. So, and this is actually not normal behavior. So, we actually all think that there's basically some gain of function mutation in his goodness gene or whatever it is. And it's phenomenal. Nice to be associated with such people. And me and Ravi, of course, go back to almost around 8 years. And I mean, a nephrologist only can be only as good as the transplant surgeon. So in these 8 years, I don't remember having even one major vascular complication. And with that kind of surgical skills, it makes my job so much easier actually as a nephrologist in the post-op period. So when you have a patient of CKD stage 5, so you have options. You have options of renal replacement therapy. Now this is not exactly universal. Suppose you have an 80-year-old person who is frail and asymptomatic and has no metabolic acidosis, potassium is normal. I would not subject him to dialysis. On the other hand, if you have somebody with a creatinine of 4, 5, and say he's got a cardiomyopathy which is probably attributable to uremia, I would actually start him on dialysis much earlier. So once again, these are all rather vague, not exactly vague. I mean, you need to react based on the situation. But yes, by and large, CKD stage 5, you would need to have a renal replacement therapy. You have options of hemodialysis, peritoneal dialysis, and of course, kidney transplantation. Hemodialysis again is of three types. You have the hospital hemodialysis, that is in-center hemodialysis, and you can actually do hemodialysis at home. This is actually, what is done in the US, and which is actually now creeping into the major cities in our country. And you also have, of course, and in this home hemodialysis, you can actually go for nocturnal hemodialysis or a short daily hemodialysis. Both of these have actually got advantages of their own. You take very good care of the volume status. So the need for antihypertensives is quite low. Need for phosphate binders is low. And potassium is never really high in these people. So the dietary requirement again is much more relaxed. But yes, you need to have some kind of training. In fact, these people can let their own fistulas, either they or their very close relative. So a little bit of training is needed. But yes, if you can actually do this, nothing like that. Peritoneal dialysis is something which, the country is also, the government is also trying to promote. This is actually a very green form of dialysis. Did you know, even in a hemodialysis, we use around 120 liters of water just for one session of hemodialysis. And that's a lot of water which is being used up. But with the CIPD, we just need around maybe 6 to 8 liters of fluid, little bit of plastic bags, yes, but then you're saving a lot of water in this. And then finally, the reason why I'm here is basically to talk about kidney transplant. So so when you compare dialysis with transplant, definitely transplant is a huge advantage. The average survival on dialysis is roughly around 5 years, whereas on transplant, it's around 10 years or so. There's a lot of time commitments with dialysis, which you do not see with transplant. So in hospital dialysis, the patient is virtually married to the hospital. He needs to visit 3 times a day. Either he alone or he comes along with one more relative. So it's certainly very taxing on the family. Little bit easier with peritoneal dialysis. You probably need to spend around 2 hours at most in a day. Whereas with transplant, there's hardly any time commitment except for the time of surgery and the post-op period. And there's a huge lifestyle impact, a huge benefit with transplant. I mean, your movement is not curtailed. See, for example, if you want to go to Tirupati for a darshan, you need to fix up a dialysis slot and swims. If you want to travel to one more place while you're doing CAPD, then the company has to provide those bags there. So all those inconveniences are not seen with transplant. The only thing is you need to remember to take your medicines on time, and of course you need to take hygienic food. This is the only thing which you need to do with transplants. Initial costs are obviously high with transplants, but when you look at the long term, see, I mean, for drugs, probably around 5 to 6 thousand a month. That's all you would need with transplant. So on a long term basis, probably this will work out to be cheaper. Yeah, and the biggest advantage is obviously with the joy of motherhood. So this is one patient out from Nellore whom we transplanted I think around 18 years back. So uh, she got married subsequently, and then her creatinine was around 1.8. We actually dissuaded her from becoming pregnant, but of course she would not listen to anyone. And then finally, yes, she tried a lot of IVF procedures, but then naturally, when she lost weight, she did conceive. Yeah, and certainly it's a huge thing for the family, isn't it? But yeah, I mean, we are very particular about whom we ask, which patient we advise to become pregnant. Obviously, pregnancy is not allowed in the first 1 to 2 years following transplant. And if they want to become pregnant, we make sure that the renal functions are normal. So the creatinine should be as close to the normal as possible. There should be no proteinuria. The blood pressure again should be very well controlled, either with no drugs or with just one drug. And there should be a minimum of proteinuria. Now, most of our patients are actually on triple immunosuppression, that is tacrolimus, mycophenolate, and steroid. Mycophenolate, of course, is teratogenic, and we actually shift the patient from mycophenolate morphine to azathioprine maybe a couple of months before planning for pregnancy. CNIs are fairly safe. Tacrolimus and cyclosporin are acceptable. And the steroid dose should obviously be less than 15. We normally use around 5 to 10 mg after 1 year of transplantation. The mTOR inhibitor sirolimus is also teratogenic, and this is something we change when somebody is planning pregnancy. Yes, there will be some amount of decline in the GFR following pregnancy and delivery, but it is not a big issue. There is no increased incidence of rejections nor other complications in a transplant patient who becomes pregnant. The kidney, of course, is placed in the right iliac fossa, in spite of which vaginal delivery is safe and it is encouraged. Cesarean section is used only for its obstetric indications. So who would? So now that we've seen, the why a transplant is better and superior over dialysis, we will come to the question about who. So as we all know, I mean, donations can actually be cadaveric or it can be live. The cadaveric donations will have a slightly lower 10-year graft survival rate compared to live. This is mainly because of two reasons. Whenever you take a kidney from somebody who's brain dead, the kidney is subject to a lot of cytokine storm. And also there'll be an increased cold ischemia time. Because of this, the cadaveric donors do slightly worse compared to a live donor. Yeah, and quite surprised to hear that the wait time for the heart is around 2 to 6 weeks, but not so for the kidney. The average wait time is roughly around 1 to 2 years. So that's certainly something which needs to improve. And yeah, I mean, with live donor, obviously we subject them to a lot of, we have time to do a lot of tests, and we make sure that the donor is, I mean, well selected. You don't have that much of time for a cadaver, of course. Now, how about whom would you take actually as a live donor? Well, obviously, if somebody has to be live donor, he has to be able to give a consent. So obviously, anyone less than 18 years of age are not suitable for donation. Or also somebody who's got mental retardation, again, is not suitable for donation. And yes, it also is understood that they should have a normal renal function. That is, the GFR should at least be more than 80, and there should be no proteinuria, no active sediment, and the BP should be well controlled or should be non-hypertensive or well controlled with one drug. Now, if there's a difference in the function of both the kidneys, then by law, the better kidney should be left with the donor. The kidney which has a slightly lower GFR goes to the recipient. Now, there is a lot of debate about using a diabetic as a donor. Some countries like Australia do not take diabetic donors. US is somewhere in between. And India, yes, we do accept diabetic donors. But then there are certain eligible criteria. The diabetic donor should at least be more than 55 years of age. Duration of diabetes more than 3 years. And yeah, the BMI should be less than 30. And he should have no end organ damage. Basically means the fundus is not showing retinopathy. The urine albumin creatinine is less than 30. And the HbA1c should be less than 7 on at least 2 occasions. If all these criteria are satisfied, then you can actually accept this diabetic as a donor. So once you finally selected the donor, then we actually have to look for any pre-existing anti-HLA antibodies. Because if these are present, then the kidney will reject on table. The way we look for these antibodies is to do a cross match. So cross match, there are various kinds of cross matches. The simplest one is what is called a CDT cross match for a complement dependent cytotoxicity test. There we actually take the donor lymphocytes and then we add the recipient serum. And we also add in a lot of complements. So if the antibodies are present, then they will bind to the donor lymphocytes and the complements will produce lysis. So if more than 10% of these lymphocytes are actually showing lysis, it means we have significant antibodies and we should not be going ahead with the transplant. Now, there are so many other kinds of tests which are done. A simple thing is called a flow cytometry. The principle is the same, but you can actually do it against both B lymphocytes as well as the T cells. So we actually see what is called a frame shift. That's how the lab gives the result. If the frame shift is generally less than 1,000, then the antibodies are not significant. If the frame shift is more than 1,000, then we all know that between children and parents, the match is around 50%. And between siblings, it can be usually around 0. The reason we do a HLA typing is, of course, it helps us in immunosuppression. And it also gives you the long-term prognosis. Transplants with 100% matches do very well, and you can actually reduce immunosuppression down the lane. Now this is the ABN compatible transplants, which we were not doing at one time, but we are doing quite routinely now. So this was actually started in Japan, where there was actually a paucity of suitable donors. considering that they have a very geriatric population. Now, the principle is the same. See, the AB groups are actually present on the endothelial cells. So if you say transplant A positive donor to a B positive recipient, the antibodies will obviously bind to the endothelium and will produce a hyperacute rejection. So the whole idea is, in case we do this transplant, we need to reduce these antibody levels. We do it through a series of steps. In the first step, we actually reduce the production of antibodies by using a rituximab, which is an anti-CD20 marker, anti-CD20 monoclonal antibody. And around 1 to 2 weeks prior to transplant, we start them on the triple immunosuppression. But still, the antibody levels are quite high. So we need to reduce them definitely at the time of surgery. So obviously, we need to remove these antibodies from the serum. Two ways of doing it. One, you can do a plasmapheresis. The other is this unique thing which is called glycosol. Yeah. So this is very small device. It costs around 2.5 to 3 lakhs. But then the technology is very interesting. It has basically a matrix to which is attached the A or the B groups. So when you pass the serum through this very small device, all the antibodies which are present, that is specifically the anti-A or anti-B, are actually taken up, are actually bound to this, and then they are removed. Yeah, it's quite expensive, but it can be reused. This is what we're using routinely now. ABO incompatible transplants, they compare very well to an ABO incompatible transplant. The only difference is actually in the cost. Now, some of these people have mothers who are having multiple children, those who received transfusions in the past will have anti-HLA antibodies. Even these we can transplant, but of course we need to reduce the anti-HLA antibodies using either rituximab as well as IVIG. But still, all these are quite expensive. So to overcome all this, we do what is now called swaps. So this is actually, there's actually a Muslim couple from Odisha whom we swapped with with a Christian couple from Kakinada. And this is actually done through, of course, with permission. And then incidentally, the operating team was all Hindu. So this is possible, just because of the swap program. Yes, this has now been made official, and of course, how exactly we do it, the steps, they will come out subsequently. But yes, this has now been made official. Yeah, transplantation. Yes, that is the way to go ahead for patients of CKD stage 5. There are only very few contraindications for kidney transplant. Someone has got an active malignancy, associated cirrhosis, end-stage heart disease, and some kidney diseases, like for example, TMA. Thrombotic microangiopathy recurs very fast after transplant. We have a drug called eculizumab. With eculizumab, we can actually do a transplant in these people, but the drug is very expensive. Each dose costs around 1.5 lakhs. It has just now been introduced in our country now. Active HIV, multiple illness, poor compliance. So these are some of these are absolute, some of these are relative contraindications to transplant. Primary hyperoxaluria, I would advise a combination of both liver as well as kidney transplant. I think I'm short of time, so I'll stop here. Thank you. Thank you, Dr. Ravi, for the heart-touching kind words. Your talk was very lucid and clear regarding the modalities of RRT and specifically about renal transplantation. Now the session is open for any questions.
Mike. Mike. Hello. Thank you, Ravi. I'm very proud of you because we come from the same college. And I think also your surgeon is from the same college. And we are celebrating in this great college the day today. Okay, you have covered everything, but just for the sake of asking, I'll ask you some questions. Okay. You said about sensitization. So in the population, they have received transfusions and there are certain reasons. So do you face that panel reactive antibody load is increasing? So you have said that you want to do immunosuppression and all that. How do you balance that with the side effects of that, such as introducing infection or CNI toxicity?
If I got the question right, it's about sensitization. Yes, and that's the reason we actually advocate using a leukocyte depleted packed cells in patients on dialysis who actually need blood. And of course, now with the advent of erythropoietin, the need for transfusion has certainly come down.
In continuation, because of the cadaver pool is still small, so do you have any extended criteria? Suppose there had been a circulatory failure, would you take that kidney and what would be the test? Will you do a pre-implant biopsy to make sure that the graft will take up?
Yes, whenever in doubt, especially when we feel that there is some doubt about the quality of the kidney, we do take a specimen and send it for frozen section. And based on that, we will decide. Especially in diabetic donors whom we are not very sure about presence of any diabetic nephropathy in them. I mean, I'm talking about cadaveric donors. Live, no, it's not a standard practice.
I hope I have time. I can ask one or two questions. See, in the early phase, sometimes the graft doesn't take up. So it's a very tensing time, and we do put them on dialysis. So, how do you differentiate between early graft rejection, or is it a tissue reperfusion injury, or is it CNI toxicity? How you manage that? How you take a decision on
Uh, I mean, the answer, of course, would lie in the kidney biopsy, and we do graft biopsies left and right. They're easy because the kidney is very superficial. Yes, a bit of clinical judgment, and if the clinical judgment is not diagnostic, we do a biopsy, and that will tell us. The biopsy will tell us if it's CNI toxicity or whether it's acute rejection or so.
Just one question to the surgeon. Sir, how do you manage if there are multiple vessels and if there are atherosclerosis in the vessels?
This was the recipient vessel or the donor vessel? The multiple vessels, now we are taking like the two vessels, one vessel will anastomose to the external iliac artery and the other vessel to the internal iliac artery. The three vessels, we will try to do pantaloon technique for the two major vessels, and for the minor vessel, like the lower pole, we will anastomose either to the external or to the inferior epigastric in a very less number of cases. Whereas coming to the atherosclerosis part, the atherosclerosis is like we see a calcium plaques in the external iliac artery, we say retention stitches on all the sides to prevent the plaque rupture and migration and to prevent graft thrombosis.
Thank you. Thank you, sir. Any more questions? Any more questions? Okay, we'll be moving to the next one. So thank you very much, sir. Thank you, sir.
Thank you, Dr. Ravishankar, sir, and our esteemed moderators. Now, to take us through nearly 2 decades of clinical experience, I would like to invite Dr. Tyagarajan Srinivasan, sir, on the stage. Sir is a senior consultant and director of the Institute of Liver Diseases, Transplant, and Hepatobiliary Surgery at MGM Healthcare, a world renowned liver transplant surgeon with a team experience of over 3,500 transplants. He performed India's first successful intestinal transplant and set world records for transplants in pediatric recipients. Sir will be delivering a talk on 18 years in liver transplantation, lessons, milestones, and the road ahead. Welcome, sir.
Good afternoon, everybody. Hope you're not sleeping after the sumptuous lunch. Thank you, Dr. Batmanaban and MGM 7 Health, which has come up in a new avatar in Vizag to deliver tertiary and veterinary care services to this part of the world. And there's a long distance between Chennai and Hyderabad. A quality, highest degree of healthcare facility should be available to the people of Andhra, Southern Orissa, and Chhattisgarh. Is a natural catchment area. So this effort by MGM to transform itself into a transplant hub in this part of the country is a very welcome one. Already they've been doing successfully kidney transplants. We have already done 3 liver transplants here. So to further progress, to increase the awareness, we thought that this multidisciplinary conclave will bring in more multivisceral transplants, heart and lung transplants, and BMTs as a routine procedure in this part of the country. So this is just a small attempt. I'm not such a great person or something. To give you a perspective of how transplant surgeon's life is made of, what are his problems, what is he doing, and what are the interesting things ahead. So this is not a purely science topic, it's more of a normal topic. The calling. Why I chose to do the transplant. When I was in undergraduate college, this was not very far away, just 20 years, 24 years back. A ward will be full of cirrhotic patients, like 20, 25 patients, everyone dying. It was a pathetic scene and a heartbreaking scene. I used to think, don't they have anything? That was the first instance which I thought that liver transplant should happen in India. It first happened nearly in 2002. And then from 2002 to 2009, it was growing on a slow phase where I joined the liver transplant in 2009. From 2009 to 26, in these 18 years, it has grown leaps and bounds. And you cannot imagine, we are the third largest country in the world to do the highest number of transplants. And we are the largest country in the world to do the maximum number of living donor liver transplant. I think you should all give congrats to all the surgeons. It's a tremendous achievement these 18 years. It shows the true potential of India, and I think it can grow 10 times more. The annual requirement of liver transplants is around 50,000 per year, but we are hardly doing 4,500 per year, and that too only 20% is cadaveric transplants. So there are a lot of interesting things. The transplants, you always oscillate between near death and decades of survival, and they're very highly challenging and a very specialized field, especially the living donor transplant. Because on one hand, you have a normal person who has a highly complex anatomy to dissect. Both the donor has to be completely safe. So this sums up. This is the Gangaram Hospital where it all started, the liver transplants journey in the country. Parallelly, it started in Hyderabad and Chennai in 2010-11, where it took up. Professor Rela was the pioneer in this part of the country. Dr. Soin and Subhash Gupta were the pioneers in the North India. These were the three mentors who shaped my life. Professor Jaidev Vig, he was exceptional surgeon in PJ Chandigarh, where an exceptional taskmaster and punctual person is a great HPV and JI surgeon. Then I trained under Professor Samira Nandi. In India, I would say one thing, if Nandi was not there, there is no transplant in India. He literally fought with the government to form the Human Organ Transplant Act in 94 and revised in 2011. In India, we are doing liver transplants only because of this gentleman. And Professor Soin took the baton from him in Gangaram. Now he has done almost 5,000 liver transplants, which is one of the largest in the world. I trained under him, but with all this expectation, I think you go into a transplant center and suddenly you feel 4 days a week you have to do the duty, and you go home, rest for one day, and again 4 days a week. You feel like, why did I come to this profession? I should leave it. And it's extremely high intensive and pressurized working environment. But somehow, every transplant surgeon in the world literally has gone through this phase where not many of the people outside the transplant community realizes that how much hard work each has put in. It's not because of the financial rewards or thing, it's just pure passion to succeed in this. So then we trained in Medanta for quite a long time. Then we set up the MGM team around 5 years before. We started with 4 surgeons and a transplant anesthesiologist. In liver transplant, it is a completely different set of game. If your hospital has a liver transplant, means it has everything because you need a good nephrologist, you need a good neurologist, you need excellent imaging system, you need high level ICU care, you have to be top notch in the infection control. And every arm of the hospital has to work if your liver transplant has to work. And it's not an easy game. So you have to build a core team, and building is easy, but training, sustaining the team is the most difficult person. You have to choose the correct persons, and never ever as a transplant surgeon, you can say that I finished this surgery in 2 hours, I finished this surgery in 1 hour. You will have a disastrous complication here. Safety takes precedence over flamboyance. And more importantly, you have to trust each member of your game because it's a huge teamwork. 6 surgeons have to work together to form a LDLT team. You have to trust each other. And investing in state of the art resources is paramount. You have to have all the gadgets. It nearly takes you 5 crores to set up a good, efficient liver transplant setup in an existing hospital. And if you compromise on resources, your results will be bad. When the first initial 50 independent transplants, I had done almost around 1,300 transplants before coming to MGM, but it was under somebody's shadow. But when I did on my own, I felt that it was a completely different ball game. Again, you have to walk as a toddler, you have to get up, walk and run, and you will see a completely new set of problems. You have to deal with the management, you have to deal with the patients, You have to deal with your colleagues. You are young in age. Not many people will respect you. But Ding is just a new guy. But you have to navigate through these systems very carefully. Often I thought, why should I take this much amount of stress? I should leave. But only two things kept me going: passion for liver transplants and a few happy smiles of saved patients who say that you have given my life again, doctor. In spite of these failures, this what keeps each one of the transplant surgeons going. I'll tell you brief stories of four patients which has taken a great impact in my life. He's a sitting judge in Rohtak. He was 11th post-arm plague. He was doing all well. Suddenly, status epilepticus for 4 days. He went into M1, M2, again recovered, but again he went into embolic stroke. Pre-op, we did thorough coronary angiogram, everything, nothing was found. But we know we found by the FFR and the 3D radial, the angiogram that we use a new lesion, which was not seen in the normal angiogram. Then we stented him. He grossly recovered. After 5 months, he's completely normal now and is attending the course. So this is one of a very unforgettable survivor for me. This is another gentleman. On third day, he was doing extremely well. Sudden collapse and desaturation. And I don't know anybody has revived after 50 minutes. He didn't revive. He revived. The rhythm came after 50 minutes. The whole team was on it. He was on a vegetative state for 2 months and he slowly improved. Now, nearly 4 months after it, he can walk, he can eat on his own. Maybe in another 2 to 3 months' time, and he'll be completely normal, I think. But this is a patient where everybody thought we have lost hope. They spent nearly 70 lakhs for this thing and thought everybody lost hope. But again, these kind of survivor stories inspire you to work more. And even if you have a 0.1% chance, you should fight for it. So this is a small story of an extraordinary donor. She is a 16-year-old girl. Legally, 18 is only allowed in India. She studied in Dubai. She was going for a 12th class. Her father had acute and chronic liver failure. He has to undergo a liver transplant within few days, but unfortunately, she couldn't get leave. We somehow managed him with the multiple sessions of plasmapheresis conservatively for 3 weeks. And when they went to the committee rejected. Then we went to the High Court and fought this case that she's medically fit. So we got a special permission from the High Court, probably the first or the second in the country, where a 16-year-old girl was allowed to donate for her father, and still they are a happy family. So this is another interesting story. It was in the peak of COVID. I was new to MGM. Everywhere there were COVID. There was a 26-year-old national level basketball player, but unfortunately he didn't have any finances, had a fulminant liver failure, and was COVID positive. Everybody refused, but we took him up. We raised crowdfunding. The entire transplant was done by the crowdfunding. We did under the bio bubble. The liver donor transplant. 3 donors got rejected, but still one of his cousins was found to be a suitable donor. And we did the world's first, in the COVID period, emergency living donor transplant. So my brief training, as I told PJ Chandigarh and Gangaram and Medanta, went for training in Fudan University and Seoul for laparoscopic and robotic surgeries. And most of my life has been in Medanta, which does annually around 300 liver transplants a year. So when during Medanta, we were part of world's lot of innovations. We were the world's first youngest world's youngest domino liver transplant, and India's first successful liver transplant. We did three swaps together, and India's first ABO transplant. And we did the world's smallest child. It was just measuring 2.1 kg. I was doing laparoscopic donor hepatectomies. I've done 40 of them. And in India, I did the first hypothermic perfusion. Normothermic, others have done. And the world's first emergency, this thing. These are all small work. In MGM, we have done 290 transplants in the last 4 years, and the survival rate is around 94%. Majority of them were chronic liver disease. Still, we managed to save 75 of the acute on chronic liver failures and acute liver failures, and we have excellent donor 100% survival. In this short journey, I learned humility is the first thing I learned. It reminds me the outcomes are never under our control. There are a lot more factors playing in transplant. Even if you have done 3,000 transplants, 4,000 transplants, each transplant you learn a new thing and it makes you completely humane. And teamwork beats individual brilliance. Transplant is never a solo achievement. More than the technique, the correct timing, when to do, more than when to do, when not to offer a transplant, how to get out of the big problems is the most important lesson I learned. Donor is the true hero because every donation is an extraordinary act of generosity. And most important for any transplant, if you want to avoid litigations, is counseling. Never give extraordinary expectations. It creates a huge trust deficit between the patient and the doctors. And if you counsel them right, hardly you would ever get into litigation because transplant is a profession where litigation is one of the highest. So, to sum up this, what are the interesting things I see coming up in the next 10 years, the road ahead? Machine perfusion is probably the second most biggest advancement in liver transplant or organ transplant after immunosuppression. Because of this, in India, the average rejection rate is around 23 to 25%, but still we can make use of these 15% organs, either by normothermic or hypothermic. Normothermic has its advantages that you can check the viability of the organ when you perfuse in this machine. Basically, it's a membrane oxygenator. It delivers blood uh, like normally within the body, and it makes the liver work, and you can see the bile, and you can see the pH, lactate, bilirubin, all those things, and you can actually see whether this liver will work or not. In UK and US, allowed nobody operates cadaveric transplants in the night. They'll put it in the machine, come back the next day and do. In India, still we have a long way to go. The government decides we have to have this. Like AI, we are missing the bus of machine perfusion, which is a huge thing all over the world. In still, India has not gotten into this. So the second thing is xenotransplant. You would have heard in the recent things, gene-edited pigs, both in China and US, both liver and kidney, and combined liver and kidney. Even though we have only short survivals, 1 month, 2 months, but I think it's there is a huge hope in this xenotransplant. It's coming again in a big way, and in maybe in 50 years down the line, there would be nobody waiting without an organ if this comes to force. And everywhere we hear A has a lot of role in especially organ transplants. You can match the donors, you can accurately select the recipients, you can predict the complications earlier, and in all results in better graft survival, personalized patient care, and optimized resource utilization. And this thing is more important. Everybody thinks that even after transplant, lifelong, you have to get medicine. It has its own side effects. Now we have biomarker guided immunosuppression where you see the signatures, you titrate, You tailor the immunosuppression according to each patient, and you can achieve a operational tolerance. Liver is a little more immunotolerant organ, unlike kidney or bowel, where you can achieve a operational tolerance in fewer patients. When you have the exact immune signatures, you can do this immunosuppression more than science. It becomes an art. So regenerative medicine, everybody would have heard. So we are doing stem cells, organoids, and bioengineered tissues. Still, a lot of research is happening. At one point of time, we will have a viable artificial piece of liver. Nowadays, it's basically used as a bridge to transplant or metabolic liver disease. But one day, when they can create the scaffold which can support the system, we will have this bioengineered liver. I think it's maybe real in the next 20 years of time. So these are some of my photographs where we trained in Seoul and China. Nowadays, nobody goes to the West. Everybody goes to the East for the training. The West is lagging behind the East because the China, Japan, and Korea are doing amazing work in living donor transplant. One important thing this side I wanted to show that Tamil Nadu has an excellent system of Chief Minister's health insurance scheme, where the entire transplant is funded by the government. In Andhra, you have a scheme, they give 10 lakhs, and if they go for crowdfunding and all, we can save a lot more patients. And in future, I think money will not be a big hindrance to successful transplants. These are some of these things in the media when we did for a Polish pediatrician, we did hilar cholangiocarcinoma and a Mayo protocol. And we did double surgeries a lot of the times. We have done 4 times coronary artery bypass grafting with liver transplants. We have done combined liver kidney transplants. And we have liver transplants with heart surgeries. And we keep doing this type of small things often. So this is a patient from Africa which has got a very difficult tumor. We replaced the entire IVC with the liver. And this lady had a stage 4 colorectal carcinoma. This is not about transplant. This is about cutting edge liver surgery. She had 9 lesions, stage 4 colorectal carcinoma and a rectal cancer. We removed everything in a single sitting and she lived for 4.5 years after stage 4 colorectal carcinoma. We do a lot of patient educations in the YouTubes and these things. These are some of the happy families impacted through our transplant programs. And this is our team when we completed the 250th transplant. And 18 years of this profession, we have touched the scores of lives, countless lessons learned. Every transplant is a triumph of science, teamwork, courage, and human generosity. The greatest achievement in transplant is not the operation itself, it is in witnessing a patient return to life, family, and purpose. To sum up, gentlemen, lessons from the past, commitment to the present, and hope for the future. Thank you for listening. So, if anybody, I think there's nothing to ask in this, it's just a boring lecture. I would like to invite You all know Dr. Vishnath is a very famous gastroenterologist in Vizag. So I'll introduce rest of my team to you. Dr. Srikanth is from Medanta, so he is also a experienced liver transplant surgeon. Dr. Sagar is a full-time liver transplant surgeon in MGM 7 Hills. Dr. Usha Ramakrishna is a surgical gastroenterologist and a liver transplant surgeon in MGM 7 Hills. So we all work as a team. Now we have a full-fledged team, liver transplant team in MGM 7 Hills. So I just want to know the burden of the cirrhosis. It's the common liver-related mortality. All these things are increasing. Alcoholic liver disease. Now the terminology is changed. It is no longer a non-alcoholic fatty liver disease. It's called metabolic associated steatotic liver disease. And there is a rising incidence of acute and chronic liver failure and HCC. Primarily, cirrhosis affects patients during their economic productive. So the current scenario in liver transplantation in India and in the world, it started around 50 years ago. Now, even the 10-year survival is more than 70%. There are a lot of newer immunosuppression agents, newer preservative solutions, improved critical care and surgical techniques. So the success in Indian programs are all equivalent to the international programs. The challenges is the expansion of the donor pool and to minimize deaths on the waiting list. So now coming to the point, I feel why patients are referred late. I would say it's first physician awareness, that the lack of physician awareness. We think that the mild should increase unless he becomes very sick and bedridden. We should not refer for transplant. Frailty is a thing which is often underestimated by clinicians. Unless you have the eye for it, you cannot assess frailty in cirrhotic patients. And also, there is a lack of familiarity with the transplant criteria. And moreover, when you see the patient factors, they will spend for everything. But when you ask to spend for transplants, they will say the huge financial task. So many people will be confusing. They'll go to native place. Even doctors go to Ayurvedic medicines, take Siddha medicines, and they try all sorts of things, homeopathy, and they will go for all palliative procedures than curative transplant. And also we have, even though it's coming up, still liver transplant, even such a big state like Andhra, we don't have a continuous functioning liver transplant center, unlike Chennai or Hyderabad. And also there are referral pathway delays. I'd like to ask Dr. Srikanth, uh, how old do you think that a patient can undergo transplant? Because it's a common myth that anybody more than 65 will not live with the transplant.
So coming to the recipient age, we have to see more of his physiological reserve than the chronological age. Some patients might be 60, but they might be too frail for the transplant. But there are some patients who are more than 70 and they're doing well. They're doing on the performance status is good. They're doing on their work. They're not dependent on anyone. So only chronological age should not be considered as a risk factor for transplant. Yeah, some might recovery delays might be there in the post-op, but the graft survival and the patient survival are more or less same in more than 70-year-old and less than 70-year-old patients. So the oldest patient we have done is 79-year-old. That's around 4 years back. He's 83 now. The chief editor, he's still doing it.
That breaks one myth. Dr. Sagar, do you think that patient has diabetes or even the donor has diabetes? That's a strict no-no for transplant.
So when it comes to recipient, so it's really a myth to say that patient has diabetes, so will he tolerate transplant? Because when you come to etiology, NASH, every patient has this diabetes underlying. So saying that patient has diabetes, will he go for transplant? It's better to think that is he really fit to undergo a transplant. And, when it comes to donor, yes, Initially, it was a criteria that all any comorbidities donor should be excluded. But now, with advancement of medications, I think we can take our
Very selected, highly
highly
selected
selected.
donors. Not every donor is a no.
Yes.
Highly selected donors you can still take it.
Yes, sir.
Dr. Usha, you think that alcoholics should not be offered transplant?
No, sir. In fact, alcohol is one of the leading causes of cirrhosis in our country and also in the world. So definitely it should be, in fact, they should be considered for transplant. But the only thing it is about abstinence. Many of them, they are put aside because it's a social factor. It's an added factor, and patient is taking, if he's taking actively consuming alcohol, we tend to put those patients aside. But it is not the thing. In fact, it is now said that like alcohol addiction, like diabetes or hypertension, it should be actively treated, involving the neurologist and the psychiatrist. And eventually, these patients should be in between uh, made ready for transplant itself.
So I agree. It's more of a chronic disease rather than a self-inflicted disease. It was an outdated view. After some this thing, they have a genetic predisposition, and some people cannot get out of it. It needs more compassionate counseling and familial psychosocial support, and exactly understanding the science behind it will not exclude as a alcoholic as a liver transplant. We'll see to come. Nay. So, so these are the reasons for commonest delayed referral, like clinical consequences, transplant consequences, and human consequences. So we'll go to the first case. Dr. Vishnath, a patient with a first episode of ascites with a MELD of 12. Would you refer now or you will wait, sir?
Yeah, just give very brief information to the audience regarding MELD, a model for any stage liver disease. It's a scoring system which uh, is supposed to be predicting the 3 months mortality in chronic liver diseases. Ranges from 6 to 40 and classified as mild, moderate, and severe. So less than 9 is supposed to be mild disease, whereas 12 comes in moderate severity. Standalone Med 12, there is a controversy that you can wait or you can go ahead with the transplant option. But the moment you have the first decompensation in the form of ascites, the whole focus shifts from managing the complications that you expect in this patient in the near future to start workup for an early transplant enrollment for this patient. So MELD 12 on its own may not be an emergency, but when you have or you face the first decompensation in otherwise stable chronic liver disease, I think it's time for us to help the thought of transplant.
Dr. Srikanth?
So as R told, MELD only estimates the synthetic and excretory functions of the liver. Actually, it does not consider many things. See, first of all, if the first decomposition is ascites, you should research the small infection that's subsiding on its own and SSD is coming down within 1 month without any diuretics. We might get away without transplant for some time, but most of the ascites decompensation patients will be on diuretics, and the diuretics will long-term cause HRS and all these issues will be there. So any decompensation, especially ascites, should be referred for transplant.
Dr. Sagar and Dr. Srikanth both can take this question. As you said, is meldonone LF for referral?
MELD will not be a only triggering factor for it just predicts the mortality. And just looking into MELD, we generate divert from other things like refractory ascites, as we discussed, and sometimes tumors are being missed, and priority, which is the most important thing. So low melder with severe priority, again, he may lose a battle of transplant. So I feel that MELD alone doesn't not be the patient clinical story.
So the main thing, the MELD estimates the 3-month mortality, but it doesn't tell you about the need for the transplant. So this is an important thing. This slide is a old one, MELD 15. The AASLD 25 guidelines says that greater than equal to 12, you can refer for transplant. And this slide will tell us that a patient with a compensated cirrhosis and a decompensated cirrhosis, the median survival is 9 years versus just 1.5 years. And this is an interesting slide. So this is called the transplant window. So every cirrhosis has a natural history. It goes through child A, child B, and from child B to child C terminally, it goes through a period of 1.5 to 2 years where they have this transplant window. When you do too early, you have this side effects of immunosuppression, familial support, economical impact. When you go too late, it's a futile transplant. They won't withstand the surgery and they'll be too sick. But the problem is identifying the transplant window, whereas the benefit is significantly more than the risks involved. And this identifying the transplant window in each patient is the most important thing. So early referral for transplant is generally indicated in first episode of decompensation, any acute on chronic liver failure, severe quality of life issues, recurrent liver related hospitalizations, any decompensated cirrhosis. So the MELD exceptions, as Dr. Shrikant has told, refractory ascites, hepatopulmonary syndrome, recurrent hepatic encephalopathy, recurrent GI bleed, frailty, and sarcopenia. So I would ask Dr. Vishwanath, MELD 15 plus frailty or MELD 30, which you would go for transplant urgently. So which you say no for transplant.
Again here, if you consider MEL 30, it comes in the severity group, and obviously we are dealing with a liver which is not going to improve on its own. So probably the only option left for a person with MELD 30 is enrolling for transplant and do an urgent, if possible, transplantation. Probably, I may not be aware, but I think he will be falling in the high priority list for transplant.
Unfortunately, we don't have a high priority list in India. We have only for acute liver failure. ACLF don't get priority or MEL doesn't get priority. It's a very skewed system of organ allocation.
And like Dr. Srikanth mentioned, MEL does not consider sarcopenia or cognitive function disturbances and malnutrition. MELD 15 with frailty also comes in the severity group and should be a candidate for urgent transplantation. The reason being, there might be surgical difficulties, and the post-operative period of this patient will be definitely not as smooth as a with only MELD 15. With MELD 30, the problem is there will be a surgical complications will be high, but the post-operative period will not be all that difficult as compared to MELD 15 with frailty. There is a chance that you can wait with MELD 15 frailty, trying to improve his nutritional status, but that sort of an option will not be available with MELD 30. So I feel MELD 30 and MELD 15 with frailty come under the similar priority when it comes to giving them an option for urgent transplantation.
Yes, sir. Due to paucity of time, we will move on to the next case. In an alcoholic associated liver disease, Dr. Srikanth When should these patients be referred? And Dr. Usha also can opine on that.
So, in alcoholic liver disease, we should, is there underlying cirrhosis or is it's only acute alcoholic hepatitis? It's acute alcoholic hepatitis. You can give a steroid therapy for maybe a couple of weeks and see if he's responding and MATRI score comes below 32 or Lilly score less. Then you might think of conservative management, but they're not responding. He should be taken into consideration like a patient who needs early liver transplantation. And I don't think he should wait for the window period of 6 months for abstinence, which is not possible because most of these patients are very young, like 30, 32 years, who might lose their life if wait for the 6 months abstinence. And with the underground cirrhosis, the acute decompensation with alcohol, it should be considered like an ACLF, which has very high mortality. I mean, if it progresses, maybe 2 months survival will be less than 10%. It is going to ACLF grade 3.
Dr. Usha?
Srikant, the issue here is recrudescence. That is the patient going back to uh, the addiction after the transplantation. If we can get a reasonable good time to counsel the relatives and give a good psychiatric help to the patient, it will be of great help if we can move ahead with the transplantation rather than waiting for him to complete the 3 or 6 months which has been stipulated.
Dr. Usha, your take on that?
Sir, as with any cirrhosis, any event of decompensation, the first event of decompensation would be valid even in alcoholic cirrhosis. So any decompensation, and the second is initially it was 6 months, but again the rule is changed to 3 months, and now as early as even 1 to 3 months, if the patient is abstinent and he's on active psychiatric follow-up, we can refer the patient for early transplantation.
I think SALT score will be a good assessment tool for predicting these alcoholics. So if you have a very high intake per day or multiple prior failed rehabilitation attempts, you have to think twice before offering them. But other when the SALT score is less than 5, can definitely offer them transplant. And one important thing is alcoholic liver disease, the outcome for transplant is the highest success compared to acute liver failures, liver cancers, HCV viruses. So you cannot deny it absolutely because it has a lot of benefit. Lot of the recidivism is actually 10 to 20%. The problematic recidivism. So I think you cannot shun away the alcoholics for the liver transplant. So Dr. Vishnath, early HCC with child A cirrhosis, do you think conservative or TACE, RFA or transplant?
If you act, if you act, if you actually see the combination of early HCC with child age cirrhosis. Early HCC, sir, what they mean is by applying the Millen's criteria, the tumor should be less than 5 centimeters solitary, or maybe less than 3, but each of them is less than 3 mm. And there should be no vascular invasion or extra vascular spread of tumor. Now, actually, if you see, there is nothing hidden about the fact that for HCC and cirrhosis, the final curative option is transplant. Of course, for child age cirrhosis standalone, we can wait for the person to maybe decompensate, which can take as much as sometimes 12 to 15 years also. But then if you are offering a cure for early HCC with a transplant, I think one should go ahead with early transplant in such cases with HCC and child cirrhosis.
Sagar?
So, referral for HCC child A, it doesn't mean transplant alone. It's like background of cirrhosis, he should be under a good surveillance and because there are a lot of things downstaging that you see is giving a family time, prior counseling, and giving them time to go for financial management. So whenever this scenario comes, I feel that patient should be under a surveillance of a transplant surgeon, not only for transplant but even for coming up transplant.
See, delayed referrals in HCC, the salvage transplants are not as good as the primary transplants. Even within Milan excludes lot of potential beneficiaries. Actually, morphology only we are normally concentrating, but it's the tumor biology is the main thing apart from morphology, which predicts these patients' recurrences. Because there are a lot of studies coming up with optimal downstaging and bridging, and as Dr. Sagar said, surveillance protocols, good long-term survival is possible. Dr. Usha and Dr. Srikanth, are we missing any other transplantable cancers commonly?
If it's a cholangiocarcinoma and other things within some criteria, we can do transplants, and IHCs also we can do transplants, but they should be adequately prepared. Mayo protocol and all should be taken into consideration. Free of chemoradiotherapies and all, then they will have extremely good long-term survival. Even CRLMs we can do transplant who are inoperable. Only thing is there should not be any extrahepatic disease.
Dr. Usha?
Sir, as is valid for HCC, even for the other tumors, the biology of the tumor is most important. And once the tumor is also responding to the preoperative therapy, we give them a response time as to how the tumor is responding, whether it's downstaging. And definitely, most of these cancers would be transplantable in the long term, whether it is cholangiocarcinoma, colorectal, neuroendocrine tumor. These are all neuroendocrine metastasis. Most of these tumors could be transplantable, with adequate downstaging.
So, due to paucity of time, we would skip this. This is the acute on chronic liver failure, where normally you decide about liver transplants, whether it is grade 2 or grade 3. When you have controlled the sepsis, you don't wait too long. You refer for transplants on the third day, fourth day, which we commonly see in clinical practice. Because the organ failures becomes more than 3 or a Cliff SOFA score increases very much more than 70, they don't do well. Or if there is a severe inotropic requirement, they don't do well. So I would say top referral pearls for liver transplant. First, decompensation refer. Mild is not everything. Refractory ascites is a red flag. Every HCC patient needs a transplant discussion. ACLF can deteriorate overnight. Age alone is not a contraindication. Most importantly, creatinine, when it rises in a CLD patient, when the kidney is involved, it means they are going not doing well. You should think about transplant HRS. Early evaluation saves lives. Most important is psychosocial support. Unless you have a good family support for these transplant recipients, these patients don't follow up their disease. They just miss the transplant, don't take medicines regularly, don't follow up. A lot of these patients drop out. And this is the slide I wanted to show you everything. ASSLD 25, mild more than 12 is an indication for liver transplant. So after hearing these things, I want to ask from the audience, what percentage of candidates are still being missed? And after hearing this panel, will it change your practice? If there is any gastroenterologist here or general physician, they can tell us.
Good afternoon, ladies and gentlemen. My respects to you. I'm from the Caribbean, Trinidad and Tobago, from the medical board. I'm the psychiatrist too. So basically, psychiatry itself is stigmatized among the other professions. So I'm talking about the alcoholics in Trinidad and Tobago and Jamaica, and Caribbean, and in Barbados, where we call them the CARICOM. women, ఆడవాళ్ళు మగవాళ్ళకి అది తేడా లేదమ్మా. Both of them have equal because you're not a trini if you don't have a drink. So what we are saying is that they should be given the priority. But as you have said, seeing the biopsychosocial model, we have to put that together, just not the biology itself. So when we look at it with beneficence, we're talking about the ethics of it. I salute you, sir, for what you have done, what you are doing. If we should be given the priority, rehabilitation has to be done. So no questions asked, period.
Thank you, sir. There are no more questions. Thank you for all the panelists. To conclude, gentlemen, patients rarely die because they were referred to early, but many die because they were referred to late. Thank you.
A truly eye-opening panel discussion for every practicing physician indeed. Moving on, let us now dive into some hematological frontiers. I would now like to welcome Dr. M. Deen Dayalan Sir, Head of Department and Clinical Lead of the Department of Pediatric Hematology and Oncology, Blood and Marrow Transplant at MGM Cancer Institute. Sir is a pioneer in curing complex benign and malignant hematological disorders through bone marrow transplants. Sir has spearheaded over 800 bone marrow transplants, which is the highest number in South India, and he was felicitated by the Andhra Pradesh government in 2023. Welcome, sir. I would also like to welcome session moderators, Dr. K. Radhakrishna sir, Dr. R.V. Bangaru Krishna sir, and Dr. Ramadevi madam. Welcome.
Start. Good evening, everyone. Before Dr. Deen Dayalan sir speaks something, 1980s, when I was a postgraduate, bone marrow transplantation was a good essay question for 30 minutes. I used to wonder how many folks a donor will have and how many folks a recipient will have. I thought it was infiltrated into the bone of the recipient. In the early 80s, there were hardly any centers. By late 80s, we used to hear a word, Dr. Maman Shandy of Vellore. Then the discussion in the postgraduates was they do bone marrow transplant at CMC Vellore. They do 10 bone marrow transplants a year. Now we are doing hundreds in Vishakhapatnam itself per year. So the journey of bone marrow transplantation has been fantastic in our country, saving a lot of children. And as somebody said, bone marrow transplantation is not a procedure. It is a transplantation of hope from one life to another. And before he speaks a few sentences, Madam. Please.
So definitely bone marrow transplantation, the awareness in the public is very less. Previously, everyone will thought like bone marrow transplantation means like they will take bone piece from the donor to then they will infuse into the bone of the patient itself. But now the awareness in the general public is also increased, and the complication management and even in haplotransplantations also we can able to achieve because of the better critical care and because of the better conditioning regimens and all. Even with half match also we can able to achieve a good outcomes. Definitely bone marrow transplantation is a game changer in the medical field.
Sir, if the chairperson speak less, you have more time to speak.
Thank you for kind introduction. See, all are surgeons. I'm only one physician, BMT physicians here. So I'll talk about cutting. I'm talk about talking. So, first I'm going to talk about what is the history of BMT, then about stem cell biology, then who needs transplantation, and what is the transplant process, and a few case studies. Who did the first bone marrow transplantation? In 1956, the Donald Thomas did the first bone marrow transplantation. The patient is an leukemic patient. He was treated with an radiotherapy, and child was in good clinical condition, and he got the stem cell from the identical twins. So there's a first successful bone marrow transplantation in 1956. Then 1973, we did the first unrelated bone marrow transplantation. In 1983, we did the first unrelated cord blood transplantation. So, and then stem cell biology. So, what is a good thing about stem cell is stem cell is able to differentiate and has also got self renewal. So, the first stem cell with pluripotent stem cell, then give rises to the pluripotent stem cells, and then give rise to the adult stem cells. What is adult stem cells? It's just like in a somatic stem cell. It is an undifferentiated cells in the differentiated body. So example like hematopoietic stem cells, neuronal cells, hepatocytes, or are multipotent stem cells. So what is the multipotent stem cell, hematopoietic stem cell give rises to the common lymphoid and then common myeloid progenitors. The lymphoid cells give rises to B cells and T cells. So any defect in the T cells can go for a severe immunodeficiency, and then they can cause malignancy also. They play very important role in the immune system. And then common myeloid, this is differentiated into the neutropenia, or could be in a pure red cell aplasia, and then sickle cell anemia, thalassemias, and then A megakaryotic thrombocytopenia, any related disorders can cause. So bone marrow transplantation is called a blood and marrow transplantation. So it's a reconstitution of entire hematopoietic system by transfer multipotent stem cell present in the bone marrow. The goal is to replace the defective or diseased stem cell with a healthy stem cell is called it is a goal of the bone marrow transplantation. What are types of bone marrow transplantation? It is an autologous, allogenic. Autologous from the patient who owns collected stem cells. Allogenic is divided into the identical twins or matched sibling or matched family donor. This matched unrelated donor, or could be an haplo donor, this off-matched donor, an umbilical cord donor, and mismatched unrelated donor. What is autologous bone marrow transplantation? So some of the patient like multiple myeloma or neuroblastoma, you have to give high-dose chemotherapy. When you give high-dose chemotherapy, the stem cell get destroyed. So what you should do is keep the stem cell aside, then you give high-dose chemotherapy, then give back the stem cell to the patient. That is a autologous bone marrow transplantation. So it's especially mainly useful in the multiple myelomas and then Hodgkin's lymphomas and neuroblastomas. What allogenic bone marrow transplantation, the main purpose is to GVL effect. In what happens in leukemic patients, the patient cell won't fight against the malignant cells. So with the help of the donor cells, it fight against the cancer cells. It's called a GVL, graft versus leukemic effect. And then any hemoglobin disorders, we can use the allogenic bone marrow transplantation. So how will you choose a donor? Selecting the donor is a very important step in the transplantation. So select the donor is most important step. What is HLA typing? So HLA typing is very important. What is the function of HLA proteins? The main function of the immune system is to differentiate the self antigen from the non-self antigen, and also destroy the abnormal cells in the host tissue. So So somebody to help the immune system to fight against. The job is done by the HLA proteins. So HLA proteins are encoded in the chromosome 6. So that is the first thing should do is a HLA typing. Second thing, you look at the disease status. Suppose patients in the patient having malignant, so disease should be in the remission status. So if a patient having immunodeficiency, the patient should be in the free of infection. So disease state is very important. And blood grouping. Unlike in the solid organ transplantation, even patient having mismatched blood transfusion, mismatched blood group, you can do the transplant. And then sex and age. Less than 40 years, we can donate the stem cells. And then better to avoid multiparous female donor to the male patient, because the more chance of a GVHD and CME status. Out of 5 criteria, the HLA typings and disease status are very important. What is the finding the diary? How will you find the donor? So only 25% of the patients have a family donor. So remaining 75%, they don't have a family donor. So what you do is, once donor is not available in the family, the full 10 by 10 match, then we send the HLA typing to the registry like a DA3 and then DKMS. They look for any donors available there or not. So like 10 mg, 10 by 10 match donor is not available. If it's available, then you'll proceed with a mud transplant. Suppose that is not available, you go for the half match transplant, this apple identical transplant that will tell you later. And then I'll also go for an unrelated cord blade. So this is actually matching. So this is when you say both allele, both are fully matched, you say 12 by 12. So ideally, the full match donor is a good option for the successful transplant. So what is the apple identical donor? See, every individual has 2 sets of HLA. One come from the parents and one come from the mother. So aplo means 50% match. That means every patient will have a match donor will be available. That's why 50% match donor available. So that is even if you say father or mother or children or brothers, all will be they can donate. So that is so every patient have a donor in the stem cell transplantation. So first you know the donor. Then where is the stem cell source? Either can get it from the PBSC, peripheral blood. How we get the peripheral blood? So we give 5 days of GCS injection to the donor, and then after apheresis mission, you are able to collect the stem cell from the donor, then give to the patient. Other will be the bone marrow harvesting. So we can take the bone marrow from the posterior superior iliac spine, and you can give, and the other will be in a cord blade. What are steps involved in the stem cell transplantation? So this is very important. First, you find out who is a good donor. So then patient, you have to give the chemotherapy, what is called conditioning chemotherapy. The main purpose of conditioning chemotherapy is to destroy the malignant cell and then destroy the immune system to prevent graft rejection. So after giving the conditioning chemotherapy to the patient, then collect the stem cell from the donor, give it to the patient. So at day of infusion, the patient does without any immune system. After 1 year, the patient have good hematopoietic stem cell system. That is a fully complete donor immune system will replace the patient immune system. That's why in immune reconstitution, in stem cell transplantation, give only for immunosuppression for 1 month or for 1 year. Unlike for the liver transplant and kidney transplant, you have to give for the lifelong immunosuppression. So then what is engraftment? Engraftment, whether it's transplant success or not, you can go by the neutrophil engraftment or platelet engraftment. Neutrophil engraftment is called ANC is more than 500 for 3 consecutive days, and platelet engraftment is more than 20,000 for 7 consecutive days without any transfusion support. Usually for the PBSC, within 10 to 14 days, they'll get the engraftment. In bone marrow transplantation, that is an engraftment takes almost like in a 2 weeks, that's 14 to 18 days. For the cord blood, that's 18 to 21 days. That's why in India, you're not able to do one cord blood transplantation. It almost takes around 3 weeks. With 3 weeks of immunosuppression, our patient is very prone for gram-negative sepsis. This immune reconstitution, and within first cell to engraft is a monocyte, then followed by the neutrophils, then followed by NK cells, then followed by T cell, then B cells. By within 1 year, there will be complete reconstitution of the immune system of the donor. So what are the complications? The first is a graft rejection. So suppose host immune system will destroy the donor cells. So then the patient needs a second transplant or GVHD. The donor T cells kills host tissues and skin and gut and liver, and it is managed with an immunosuppression. If nothing happens, they lead a very good, amazing new life. Imagine a patient with thalassemia leading a lifelong blood transfusion with successful transplantation, no need for a blood transfusion. That is imagine the child will have an amazing new life. What is supporting care? The patient should be admitted in the HEPA filter room. There is a positive pressure room so that the chance of infection will be less. And then should be good central line monitoring should be done. The nutritional support. And other most important thing is 24/7 need a blood bank support. We need irradiated blood products. And then good ID support, this is infectious disease support and IC backup. And most important is share care approach and crowdfunding. And then they stay for 3 months near the center. And financial support is very important. For thalassemia patients and sickle cell anemia, our Andhra government gives 10 lakhs. And also we make arrangement through the DKMS and crowdfunding. So most of the transplant in MGM, we were able to do it with the government support and the NGO support. Next question is when to whom to transplant. So for any acute leukemias, we can do the transplant. The chronic leukemias and MDS, we can do a transplant. And lymphomas or myelomas, either you can do the autologous transplants or allogeneic transplant. And bone marrow failure, we can do a transplant. And then inherited disorders like thalassemia, sickle cell, pyruvate kinase deficiency, and solid tumors like an neuroblastoma, we can do an autologous transplant. The bone marrow failure either could be an inherited bone marrow failure or it could be an acquired aplastic anemia. For both the condition, we can do the bone marrow transplant. Almost like 81 condition, pediatric condition, we can do the bone marrow transplantation. Some few case scenarios. The thalassemia major child, 8-year-old male, diagnosed at 3 months of age group, is a regular transfusion and iron chelation since infancy, low matched family donor. We did we found a matched unrelated donor in the Dati registry. So suppose the patient have regular blood transfusion. In India, most of the patient receives it's a non-liquid depleted and a non-irrigated blood product. There more chance for a rejection. So we have give pre-transfusion immunosuppression 1 or 2 cycles. Then you give intensive iron chelation for almost like 2 to 3 months. And then we did a transplantation and engraftment in the day plus 11 and 100% donor times are achieved. Is a transfusion free and is a stable blood counts. Most important question is when to do a transplant. When should I refer for a transplant for the thalassemia patient? The ideal age for do the bone marrow transplantation for thalassemia is between 3 to 7 years before the iron overload occurs. So beyond 10 years, if you do a transplant, we have a huge splenomegaly, there'll be more chance of rejection. So what we have found out is when you do a transplant less than 7 years, the transplant success is almost like 90%. That means if you do a transplant for 100 children, 90% of the patient will recover from the thalassemias. More than 10 years, when I have like a classic thalassemia, the survival rate is only 80%. So early the referral, the better the prognosis. The third 3 months old child, he came to loose stools and vomiting and fell. The previous sibling death at 4 months with the similar features. So since the child is a previous sibling death was there, we thought it could be in a severe coming immunodeficiency, but bone marrow consistent with an HLH. So clinical exome sequence were done. It's a preference gene mutation. So we did the HLH protocol, and then child went to the remission status, no match donor, and then we did a alpha beta depletion. See, in what happened in apple identical transplant, along with the stem cell, they also have the T cell. The T cells are responsible for the GVHD and graft rejection. So we have to kill the T cells. There are two ways you can kill the T cells. One is by using the post-transplant cyclophosphamide. Other is like an T cell depletion. Either it could be an alpha beta depletion. You did a transplant at 5 months of age. So age is not a barrier. Some other patient did a transplant at 3 months to 4 months also. So day plus 11, engraftment is confirmed, 100% donor chimerism, child is in disease in remission, patient having normal development. This is a child. Now this is almost like a 3 years old child. Is doing a normal and going to the school also. Other things like the primary immunodeficiency, with it is an LRB deficiency. That's some of the immunodeficiency can present like an autoimmune immunity, autoimmune features. This 5-year-old boy, the concerned parents, recurrent diarrhea since the 8 months of age group, and one sibling died at 3 years of age group with a similar complaints, and gut biopsy showed autoimmune enteropathy, and child had a partial response to the steroids. Then we did the exome sequencing that confirms the common variable immunodeficiency. So because of progression to failure to thrive, severe hyperkalemia and frequent hospitalization, the HSCC was only the curative option. So we did the match, we went for a HLA matching. Elder sister was 10 by 10 and transplants were performed, and now is doing well. So these are most of immunodeficiency when picked up early. If you do the transplant without any infection, they do very well. So in immunodeficiency, the first thing is suppose the patient has failure to thrive, and any family history of family history of death is that times don't give any vaccination. So first rule out immunodeficiency, then go for a vaccination. This is aplastic anemia. The 5-year-old child is a parallel to skin and gum bleed, no dysmorphism on organomegaly, and had a bit purpura and ecchymotic patches over the limbs. Investigation hemoglobin is 6.54 and MCV is 98, and ANC is only 200 only, and platelet less than 20,000. Because of less platelet and hemoglobin is less than 8 grams, the patient having a diagnosis as a severe aplastic anemia, and direct Coombs test was negative, and vitamin B12 level was normal. So we did a bone marrow aspiration biopsy. It's hypercellular marrow. So we did a transplant. The ideal donor. It's a full 10 by 10 match sibling donor, and patient had a full donor chimerism, and now his patient going for the school, going to the school. The relapsed B-cell ALL patient, the 5-year-old male child. It's a B-cell diagnosed at 3 years of age group. Started in UK ALL protocol. It is relapsed during the maintenance. It is isolated bone marrow relapse. So we started on a relapse protocol, and MRS negative, remission achieved. There's no matched family donor, and patient with poor financial setup. So we did the apple-identical bone marrow transplantation using the post-transplant cyclophosphamide method, and patient is engrafted on day plus 12, and MR is negative, and chimerism was 100%. Now this the patient is almost like 5 years post-transplant. So now the Bloom syndrome, the MDS, is a 11-year-old girl, the pallor with the fatigue, and have a pancytopenia, and hemoglobin was 4, and WBC was gains was 300, platelets 55,000, and facial dysmorphism, and capillary spots are there, and macrocytosis. We initially thought like an Fanconi anemia, but we did a workup that shows a Bloom syndrome, and parental testing also confirmed the same variant, And then we did the is evolving MDS, the multi-digit dysplasia within 5% blast. So what is challenging this patient is, actually the first time in the world we did a bone marrow transplant for the Bloom syndrome. So we don't know what protocol should follow. Like a Fanconi anemia, if we give high-dose chemotherapy, they can go for reactions and adverse effects. So we modify the protocol. So and most important challenge is a younger brother. So the weight difference was almost like a 20 kgs. So donor weight is only 25 kgs and patient weight is almost like a 45 kgs. So we did the T cell depletion on neutrophils and platelet engraftment by day plus 11, and this is day 17. Is a donor. Image is only the 5-year-old child is giving the stem cell to his elder sister is 11-year-old child. So another most important thing is now you know what is a transplant, whom should a transplant, and when to transplant. That's most important thing is in condition like osteopetrosis, before vision or hearing loss occurs, because irreversible neurological damage, we should do a transplant for osteopetrosis and speed and accelerate with earliest possible opportunities. Like a severe immunodeficiency, if you do a transplant less than three months of age group, then almost a success rate more like a 90%. If do after 3 months, its success rate will come down. And mucopolysaccharidosis is like before the first birthday, and X-linked adrenoleukin dystrophy, the lowest score less than 10, that is the time you should do the transplantation. Take-home message is, as I already told you, there's no lifelong immunosuppression like unlike liver transplant, renal transplantation. A successful BMT sclerosis is not a lifelong treatment. See, I'm doing transplant for last 15 years. Some of the patients they got married, they're doing engineering degrees. So the bone marrow transplant is a lifelong procedure. The most important thing is you should choose the right patient and right donor, and preparation and timings are very crucial. And most important thing is a multidisciplinary approach with the primary physician gives the best results. So we in last 4 years, we did around 217 total transplant in last 4 years. Out of which 86 is a matched family donor, and 35 is a matched unrelated donor, and 87 is an apple identical donor. So our center is doing most of apple identical donors, and nine patients are autologous transplantation. Thank you.
Thank you, Dr. Deen Dayal. You told us the basics of hematopoietic stem cell transplantation and gave us huge number of examples. Now it is up to us to identify cases, because as basic pediatricians, we have to identify cases and send them to you so that you can transplant life from one person to other person. Thank you.
Sir, very nice presentation. You covered all the basics for the common people also, which they can understand and all. And broad specialty doctors also should completely aware of the transplantation is not only for the malignant things, it's for the benign causes also. Especially the pediatrics group, like even the storage disorders, if you refer early so that the neurocognitive symptoms we can reverse. So that's a very important thing in them. And early referral is good for the patient along with the life and the quality of the life itself. Thanks.
Thank you very much, sir, for enlightening us. The brighter point I observed is that no immunosuppression for the lifelong, whereas all other kidney donors, liver transplants, they need immunosuppression and the drugs, and it incurs lot of cost for the lifelong. Where it is not there. And another thing is very difficult for the child to give lifelong medication, oral medication. So it is not there. Thank you very much, sir.
Any question?
Thank you very much, sir. Any questions, audience? So thank you very much, sir. Thank you, Dean, sir. Thank you, Ramadevi, madam. Thank you, Radhakrishnan, sir, and Mangakrishnan, sir.
Thank you very much for coming all the way. I would like to thank Dr. Radhakrishna sir and Bangar Krishna sir, especially because they have come with a busy schedule. And Dr. Bangar Krishna sir is a busy pediatrician in Shodavaram. Thank you, sir.
What an incredibly insightful session, sir. Now, we welcome a highly specialized lecture on an emerging frontier. Please welcome Dr. Anil Vaidya, sir, Chair and Director of the Institute of Multivisceral and Sir will speak on the evolution of intestinal and multivisceral transplants. Welcome, sir.
Thank you for the opportunity to speak here. This is perhaps one of the rarest of transplants done worldwide, but a growing field in India. So when you say multi-visceral transplantation, it's not that you're transplanting every organ individually. Multi-visceral transplantation is for a cluster of organs. It could include the liver or exclude the liver, but it's transplanting all the abdominal organs at one time. The learning objective for this lecture is it's important to understand that this multivisceral transplantation is not possible without understanding what intestinal failure is. We'll also take you through intestinal transplantation with its indications, surgical options, stomas, and evolution of this technique. Immunosuppression will be touched on. Transplant for tumors is going to be spoken in the next session by my colleague, Dr. Shiv Kumar. We'll talk about immune surveillance. And most important thing is the ability to close. Is the volume better? So a very important part of multivisceral transplantation is the ability to close the abdomen. You can imagine that patients who come for intestinal transplants have lost their abdominal domain. And when you try to put in a new organ, the problem comes with trying to cover the organ or rather getting abdominal closure. So straight on to intestinal failure, we all know is defined as an inability of the intestine to maintain nutrition or electrolyte balance. And it comes very simply in three forms. Type 1, type 2, and 3. The type 1 happens, we as general surgeons, as specialist surgeons, you'll have a patient coming for either any abdominal surgery, can have some ileus. The following abdominal surgery might require a bit of fluid and nutritional support, and it's usually self-limiting. There are a few that have had major intestinal surgery with septic and metabolic complications. These people they require fluid and nutritional support for an extended period of time. And this requires a multidisciplinary intervention and usually in specialized units. If you look at the disease spectrum for type 2 intestinal failure, surgical complications, Crohn's disease, that's IBD, and gut ischemia are the three highest numbers of contributors to type 2 intestinal failure. And usually type 2 intestinal failure requires this parenteral support for almost 1 year. So before a surgeon can go back and reconstitute the intestinal tract, the patient needs nutritional support for about a year. And so management of these type 2 intestinal failures is very, very crucial. And there is a standard method or methodology to manage these patients. The first thing is to look at sepsis. Second is measure their nitrogen balance and look at what is appropriate nutrition for them. Then find out what the anatomy is, the remnant anatomy, and then make a plan. Sepsis and wound care, very, very important. We all know that sepsis can decrease nutrient transport, decrease intestinal motility, enterocyte proliferation, and mucosal barrier function. It also has increased insulin resistance, protein metabolism, and decreased glucose utilization. And all this, with GI dysfunction and malnutrition, has persistent intestinal failure. And in these type 2 intestinal failure, sepsis is perhaps the most important cause of death. You've got to have a high index of suspicion in this patient who's got type 2 intestinal failure, because more than 50% will have normal white cell counts, will have a normal CRP, 50% may be apyrexia. Their central lines, the people who've got central line infected in central lines, about 66% with normal white cell count and 33% as apyrexia. They need a very high index of suspicion because they have failure to thrive, they've got hypokalemia, unexplained high output from their stomas, and hepatic dysfunction. Next thing comes nutrition. And nutrition, if you've got enough intestinal layer, you can try enteral nutrition, but you got to be very careful because if there is sepsis and a borderline intestinal layer, they might still have this motility. You will not have the ability to give them nutrition in the scenario. So for these people, it's important to think that parenteral nutrition might be the right thing to do. When you start feeding these patients, we all know about refeeding syndrome. Be very careful not to give them, we are over enthusiastic to see a patient that's with type 2 intestinal failure. You want to give them a lot of nutrition. There comes the problem. And a majority of these patients die because of this refeeding syndrome, which is based essentially on insulin secretion. But when you start giving them calories, insulin levels rise in the body to create additional glucose load. Potassium goes into the cell, and sodium comes out of the cell because they redeem. So improving nutritional status does restore immune function, improve wound healing, and prepare the patient for definitive surgery, which may take at least 1 year. This is for type 2 intestinal failure. Then you obviously need to know what are you left with? How can you reconstitute this person's anatomy? And the best one we use is, of course, CT scans, what have you. But we try to use water-soluble contrast rather than pale things to be in real place. Once you have a plan, that plan could be medical. That means keeping the patient on long-term, treating the underlying bowel inflammation, or it could be surgical. What is interesting to note that almost 50% of patients with type 2 intestinal failure will progress to type 3. And type 3 is a different beast. Type 3 is irreversible intestinal failure. And there comes the indication of the AGA hasn't changed their indications for the last 25 years. Impending over liver failure because of shortcuts and TPL, thrombosis of 2 or more major venous accesses, frequent access-related sepsis, and frequent severe dehydration. As we've gotten better at what we do with transplants, Now, quality of life is being asked as a potential indication and patient choice. Essentially, adults with shortcuts, ischemia, acute ischemia, SM thrombosis holds number one position. In kids, it is gastroschisis, vaginal metropolitis, and bottles. Look at a lot of these transplants being done worldwide. And as you can see, that the number one spot has been taken by ischemia. And not far behind ischemia is tumors. Look at the bottom of the slide. What are the constraints of intestinal multivisceral transplant? Of course, it's the surgical, technical. Imagine an average patient has already had about 10, 12, 15 abdominal operations according to you. Immunological monitoring, infection versus cancer all the time. Surgical, multiple prior operations for abdomen, down wall, open abdomen, like this one. You can see that's the north end of the patient, south end of the patient, 15 abdomen. That's the gastrostomy, top right. So this is an average patient that you get to see. We've got a bit of a menu on what grafts we can use. There's the isolated intestine on the top left, liver intestine, pancreas. Then there's the multi-visceral. That's the one that has liver as a part of the graft. And the modified multi-visceral transplant has everything except the liver. This is how the isolated intestine is plugged in. The inflow and the outflow is on the aorta and the IVC. The liver, pancreas, and intestine. This is the modified multi-visceral transplant. That's got everything except the liver. And this is the multi-visceral transplant. And if I look at evolution of multi-visceral, that is the whole thing, the whole graft, with technical modifications. I do keep the donor spleen. I have stopped doing an esophageal anastomosis. I do a gastric anastomosis. And I do use the donor colon in the graft. Now, as I said, we become our own victims of our own success. We've gotten better at doing things. We get the technical aspects, keeping the graft longer. So we think about, is there another indication apart from ischemia? And that's where tumors comes in. I won't dwell too much on this because Dr. Sukumar will be talking about it next. And I'll move on to immunosuppression. We rely highly on a very hard induction immunosuppressive strategy. We prefer alemtuzumab, that's Conclave, and other groups use ATG plus similar. So very tough, very hard hitting immunosuppression to begin with. But our maintenance is very simple. We use only single drugs. I use only Prograf. Some centers use Prograf with the low dose steroid. It's important to have a surveillance of these grafts. Traditionally, any other clinical signs is non-specific. We developed something like Zoom endoscopy. Plus, we use serum citrulline, ostomy calprotectin, and a bit of a new evolution is vascular screening. So Zoom endoscopy magnifies it 100-fold in image analysis of the mucosa. And endoscopic biopsies, we don't follow this in India because it's too tough or too expensive for the patient. But traditionally in the Western world, this is what we can get. Zoom endoscopy looks like this, and actually look at individual villi and then quantify what is the health into a score. This is as normal mucosa. That's the biopsy that look like that. There's mild rejection, flattening of the mucosa, distortion of the architecture. There's moderate rejection, and this is severe rejection. So there's a complete loss of the architecture. This is how severe rejection would look like on endoscopy. But you got to persevere. In the old days, if there was severe rejection, we would take the graft out. Now with the advanced immunosuppressive therapies, we can have longitudinal monitoring. This is moderate ACR. We treat it, and it takes about 30 days to return back to normal. The problem with this is that for 30 days, the patient goes back onto TPN, and it's a lot of expensive, chance of sepsis and what have you. So at Oxford, I devised this. It's called the vascularized sentinel skin flap for monitoring of intestines. What this does is if you transplant a vascularized skin flap in the same donor, it gives you a 10 to 15 days advance notice on impending rejection. If that develops a rash and you biopsy the rash and sees rejection, you treat the rejection, then thus prevent a targeted attack on the intestine. We devise the technique. We take the forearm flap and the same donors, and the right donor looks like this. It's got a inflow and an outflow. Here's the forearm incision. And this is how it looks after the implantation. So it looks post-operatively. This is how rejection looks. It's like a maculopapular rash on the limited only to the skin flap. You biopsy that and you see the grades of rejection you treated. So one of my patients having this, he's now almost 15 years out. Closure of the abdomen is important, as I alluded to begin with. You do primary closure, you could do delayed, you could do prosthetic closure to the abdominal wall, or you could do abdominal wall transplant. Since you're transplanting everything anyway inside the abdomen, you transplant the abdominal wall. So these intestinal failure patients have had multiple intestinal resections, near total nephrectomy, weight loss, sclerosing capsular peritonitis, poor quality of native skin. So it's very difficult to keep the new intestine that you transplant with any kind of skin cover. So we devised this. We take the whole abdominal wall from the same donor again, put this blood supply on the inferior gastrics. We isolate the inferior gastrics and the recipient, and that's how we vascularize it. At the same time, of transplant. That's how it looks post-op. Transplant numbers in 2024, the registry showed 82 competing centers. So about 5,400 transplants done on 5,000 patients. Current survival about 4,000 and off-target nutrition majority. The longest surviving recipient is transplanted in 8 years. We measure graft function not only by actual graft function, but by prognostic score to see how much of their day-to-day activities they can do themselves. And if you transplant the colon with a small bowel, you show a slightly better prognosis. The causes of death, unfortunately, have not changed over the last 50 years. Sepsis contributes to one of the largest causes of death, and the sepsis happens when patients undergo rejection. Then there's translocation of bacteria and increasing immunosuppression in the face of bacteria in the blood. So having the sentinel skin flap really helps. You can predict that rejection and treat it before rejection happens. What about India? How many patients with intestinal failure in India? I took a rough analysis from what happens in the world. So we're looking at taking about 5% approximate average for about two criteria. There's affordability and equity of access. So the point prevalence of patients requiring TPN between 3 months to 1 year is about 46 per million. And you put patients. And if required, there's irreversible intestinal transplant. About 1.4 per million, about 95 per million. And that's about we should be doing a year. Can we make it possible? I think a national registry of intestinal failure run by dedicated intestinal failure units. Personalized TPN, decrease the amount of line infection. But we know that global constraints, lack of these intestinal failure. So is it better to transplant earlier? Or are we ready for a new era of dedicated intestinal failure? And I think this is something that's very important. Take home messaging. They do not exist in different silos. They have to be in one place. And intestinal failure, a specialized intestinal failure unit and intestinal transplant has been one place. And with that, I'll stop.
No. Thank you, Dr. Vaidya sir. To wrap up our masterclass presentations, we will now direct our focus on the intersection of oncology and transplantation. Please welcome Dr. Sivakumar M., Senior Consultant Surgical Oncologist, Transplant and Robotic Oncosurgeon, an expert in HIPEC and PIPAC, leading the multivisceral abdominal oncology frontline. Welcome, sir.
Good evening to one and all. I think I'm the last batsman, I think so. So probably openers and middle order has done their job. Probably I'm just has to score a last run to win the match. I think Dr. Anil has given a full perspective of multivisceral transplant and intestinal failure that makes my job easier. Disclosure, I'm basically a surgical oncologist, and by serendipity, I just met Dr. Anil 3 years back, and now I'm into transplant oncology. Thanks to Dr. Anil. And without further ado, I will go for the topic. And thanks to MGM Seven Hills for the opportunity. So the agenda is going to be like, what is transplant oncology? Like previous speaker has alluded all the indications. If you have gone through this, there is only 10% of this is transplant oncology. It is a very niche field. And already Anil has told about MVT, modified multivisceral and isolated bowel. And I am going to discuss about what we have done in India. So the transplant oncology, it is an emerging field, new concept in cancer treatment with promising outcome. It's like conceptually, it's like a radical cure for cancer by completely removing the cancer bearing organs and replacing like for like. Aim is to improve the quality of life and survival for cancer patient. Everyone might not get into the view like for any cancer patients, you can remove the organ and put the organ back. No, it is not that way. So majority of the time, it is going to be improve the quality of life ultimately. So it is the marriage between the transplant medicine and surgical oncology principles. Without violation of surgical oncology principles, we have to get into the transplant program. So before the bowel transplant, a few slides about, because we know about liver transplant. Everyone knows about kidney transplant, liver transplant. So last 2-3 decades, in transplant oncology, liver transplantation for hepatocellular carcinoma, colorectal liver metastasis, cholangiocarcinoma, it has been proven, and lot of trials have gone through, and 5-year survival rate across the trials, you can see that 5-year survival is reaching up to 70%. Imagine for hepatocellular carcinoma, 70% 5-year survival. And for colorectal liver metastasis under control, and you can have a 60 to 70% 5-year survival actually. And modified multivisceral transplant. What is this multivisceral transplant? Is already we have discussed this. More than one organ, if you are going to transplant, it is a multivisceral transplant. And the whole package, if you are going to transplant, it is multivisceral and modified multivisceral, the similar slide. So one thing I like to emphasize is all are cadaveric transplants actually. The donor is always from the cadaver. There are some centers doing a live bowel transplants or being in the trial phase actually. So indications in oncology is very few. To put it in nutshell, wherever chemotherapy is not indicated, if it is going to be a low-grade tumor like desmoid tumors in a familial adenomatous polyposis, pseudomyxoma peritoneal, jelly belly abdomen, peritoneal surface malignancy, which is a low-grade tumor where chemotherapy doesn't work, and low-grade, grade 1 and grade 2 neuroendocrine tumor, and rarely sarcomas and mesenteric sarcomas where it encases the SME and SMV, where no other choice, and no distant metastasis, and an intermediate tumor like epithelioid hemangioendothelioma. And last but not least, majority now the radical surgeries are being happening in oncology, and ultimately the patient end up in resection of bowel and short gut syndrome. So like this program is first of its kind, like put it in India or Asia Pacific region. In MGM Chennai, we have this. I think last slide Anil has put up like we have a unit and a transplant center where this is the first of its kind. Let me go through 2 cases of isolated small bowel transplant. This is the first transplant patient 2023 we have done for isolated bowel. As an oncologist, I don't believe in this transplant 3 years back. After this patient, I got belief, and I got because as an oncologist, always we ask evidence, and immunosuppression will allow the tumor to grow. That is what the concept generally the oncologist will assert as a surgeon. So common indication already we have discussed. This is the patient. She is a unmarried girl, like with intestinal failure. She had a history of FAP, and 2017 she was operated for total proctocolectomy. Invariably, all these operated patients will have developed within the 5 years desmoid tumor of the mesentery, which is very badly treated outside, and majority of the patient have no other options. They die of the disease within a year or two. So this is the status when she landed to our clinic. With the weight loss, she weighed only 33 kg. You could count her bones and tendons actually. So we have taken up the patient for a home-based parenteral nutrition. That is one of the important pillar of this transplant program. She was 6 months. She was on nutritional rehabilitation to gain the weight, and we planned for a single stage surgery, tumor resection, and transplantation. So this is the intra picture. I'm just going to go through. This is the intra where the surgeon, Dr. Anil, is hooking his finger in the SMA complex. You could see the specimen. This is the cocooning of the abdomen. This is a small bowel. You imagine this is the small bowel, and it is completely infiltrated by the fistula and infiltration by the desmoid tumor. Desmoid is an intermediate type of tumor which it will not respond to chemotherapy, only for surgery, and it has prone for recurrence. Those small bits you can see, those are from abdominal wall. Wherever you put an incision, it will develop desmoid over there. And this is a donor small bowel, and this is an intraoperative picture where we have prepared the bed and vascular anastomosis is happening. This was the vascular anastomosis, and once the reperfusion is happened, you can see the bowel has come to life actually. We transplant with the right colon for better water absorption and patient's outcome. And this is the enteric anastomosis, and this is the final picture. You could imagine this patient, as usual, all post-op periods and immunosuppressions, Anil has discussed the same protocol, and final report is desmoid. And this is a FAP protocol. We do strict criteria. You could imagine this patient. You can see she is back to her job. She is independent of TPN. She is not married. She's not married. You could see she is with in the sari with the stoma actually. Now it is 30 months now. We have operated in 2023 actually. So outcomes after a bowel transplant, it has transformed the life of a patient taking normal diet, independent of TPN, no TPN, excellent quality, disease-free, and immunosuppression. Few examples across the world, Cambridge group and Illinois group, they have done few cases. And second is a modified multivisceral transplant. This is in Asia. That is the first case we have done in Asia, modified multivisceral. It is difficult to do a modified multivisceral rather than the proper multivisceral with liver. With liver, it is very difficult to get an organ in India because the waiting list for liver failure is huge, huge actually. So this is a one Miami. This is 2005 data. So 100 cases. Now they have come to 500 cases of multivisceral transplant. All indications you see the highlighted are intestinal gastroparesis, intestinal dysmorphity, no oncology indications. So what happened is Steve Prescott. This is a gentleman. This is Dr. Anil Vaidya's first patient in the world actually. 2013. This gentleman was diagnosed with a peritoneal surface malignancy, pseudomyxoma peritoneae, where, jelly belly abdomen. We used to operate, open the abdomen, debulk the disease. The patient, multiple times you can debulk. And finally, the patient end up dying because of the disease. So the CRS hypec has improved the quality of life. And even after CRS hypec, this patient had multiple surgeries and end up with unresectable recurrent pseudomyxoma peritoneae. I think Dr. Anil was there in Oxford in 2013. This guy has searched for anyone doing transplant for him. So initially it was very much reluctant, and ethical committee, it was very difficult. And finally he was very much persistent to do this transplant. And finally, successfully, the first transplant was done in the world by Dr. Anil Vaidya for this patient, successfully able to do the procedure. But unfortunately, this patient died after 3 months because of sepsis related things. But this opened up the floodgate for a lot of patients. Next 10 years, the Basingstoke and the Oxford group could able to do 15 patients because it's a highly selective patient, where all unresectable pseudomyxoma peritoneae has been done. You could see that even if it recurs 90%, the patient will have a good quality of life. They could able to spend time with their family for 4 to 5 years. You could see the first year survival is 80% and 5 years survival is 55%. Out of 100 patients, 50 will be alive for 5 years, able to spend a quality time without any TPN. That is what the idea. This is the patient landed up to us with the same similar history, 2-3 surgeries outside done. In 2024, the patient came to us, and this is what the abdominal wall failure we could say that it is a filled with a jelly belly abdomen, and the tumor has proliferated and fungated. And surgery for a regular surgical oncologist or gastrosurgeon, surgery is not possible, conventional surgery. So with the transplant procedure, we could almost completely. The R0 resection might not be possible. R1 resection is possible, and patient can be back to oral diet, and which has got a very good quality of life. So this is post 3 months. You could see the abdominal wall has improved and the tumor has grown because the TPN is going to feed the tumor also. So you could see this is an intra-abdominal, intra-operative picture. You should see the right side is the head end and this is the lower end. And you could see the complete cocooning of the abdomen. You could see the ulcerated growth, and you could see the stomach, gallbladder, everything is like a cocoon. See, after removing the tumor, you could see this is the small video. This is after surgical removal. You can see the aorta and IVC. Completely the retroperitoneum is like a virgin, actually.
So you could see this picture post resection of the tumor. Liver is intact. We have removed the entire tumor, and you could see this stomach, pancreas, spleen, entire small bowel, and the ulcerated tumor has been completely removed and blocked. So this is the donor graft as usual. Like for any kidney, liver, heart transplant from the deceased donor, we harvest the patient from the donor. Once the cross clamping is done, we shift the patient here in the recipient hospital and we start resecting the tumor. Based on the burden of the disease, this takes around 10 or so. It has to be highly coordinated. It is a team approach. So this is the graft, actually, entire graft. Cover from the stomach, duodenal-pancreatic complex, and with the large bowel up to the right hemicolon we used to transplant. So you could see the vascular anastomosis, bowel anastomosis, and biliary anastomosis. The graft has come to life actually. Always our protocol is after 2 days or 24 to 48 hours, we reopen the abdomen to look for collections and give a wash. And this patient, unfortunately, she had a good recovery. At this juncture, I should say, after this procedure, I thought this is like a only simple procedure, patient discharged in 2 days. I think the hard work all have been put by Dr. Anil Vaidya last 2-3 decades. They have been working on this. So the same protocol, we just follow it in Chennai. So this program for transplant oncology is happening in UK, Cleveland Clinic, and now in Chennai. Last 3 years it has been happening. Throughout the world, these are the 3 centers, major centers, where the transplant oncology is happening. And this is the tumor marker as usual. This is the team actually. And so far what we have done, we need to put up our data. So you could see the yellow highlighted thing is for oncological indication. As we said, only 10% are oncological indication. The first year we started 2023, we could able to do 2 cases. Next year 7, and last year 21 cases of bowel transplant. Whole put together for benign and cancer indications, we have done 21 cases. So last year, like 21 cases we have done. So it was the world highest number actually. And so far we have done for 1 case of PMP, modified multivisceral, and 2 desmoids, and one another desmoplastic small round cell tumor. I think only few slides are there. So last 3 years, this is into the 4th year. So 34 cases we have done, and less than a 10% is the oncological indication. It's a very niche field. So we should not take home like for all cancer patients, we can do a transplant. No, it is not that way. You have got all strict criteria. What is the evidence? Always we need evidence and ethical clearance. So this is called a Transcape study happening in Cleveland Clinic. Dr. Anil Vaidya is the principal investigator. The same Transcape India study, we have got ethical committee approvals, and Dr. Anil is principal investigator. I am one of the co-investigator, and it is on recruit. We are recruiting patients actually. So take home message is like modified multivisceral and isolated bowel transplant option previously available only in Western countries, now available in India. And few have attempted. If you put a Google or AI search, 2012, 13 or something happened in North India, but only few cases, but they could not succeed actually. Because the most important is a team approach where the rehabilitation, home-based TPN is the most important pillar of this successful program. And we have developed this program actually. And from UK, US experience, we have extrapolated and we have customized in India. An indication, as I told you, it's a slow growing tumor where the standard surgeries is not indicated. That is, the options are not left with. Those are the indications. And immunosuppression, like said, last 2 decades, it has got evolved, and it is only an oncologist myth. And monitoring, as usual, rejection, infection, GVHD, and post-transplant second malignancies. Quality of life significantly improved. And as always, liver surgeon and everyone we are discussing, early referral is most important. And MGM Cancer Institute and MGM Healthcare is, we have put up in the global map, and India also, for the multivisceral transplant program actually. So push your boundaries beyond the ordinary, be the extra in the extraordinary. So that is what happening. So transplant oncology itself is a very, very niche field where we need more patient and perseverance. Thanks to Dr. Anil, one of the world most pioneer is with us. Happy to have any questions. Thank you.
Hello. Ladies and gentlemen, as the curtains fall on this monumental day of academic brilliance, we officially welcome you to the valedictory session of Precision and Pulse 2026. Today, we didn't just share knowledge, we bridged the gap between intervention and implantation, turning clinical challenges into infinite hope for patients across Andhra Pradesh, Odisha, and Chhattisgarh. To deliver our formal concluding remarks and acknowledgement, I invite our organizing secretary and deputy medical superintendent, Dr. G. Raghvendra Kumar, sir, to the podium. Welcome, sir.
Good evening, one and all. So, distinguished faculty from MGM HC, Cancer Institute, and MGM 7S Hospital. What an absolute powerhouse of multidimensional science and collaboration today has been. On behalf of core organizing committee, MGM 7 Hills Hospital, I stand before you with a heart full of gratitude. First and foremost, a massive thank you to our pillar of support, our cluster chief operating officer, Sri SP Padmanabhan sir, for his unwavering administrative backing and strategic leadership in bringing this massive multidisciplinary vision to life. Here we extend our deep gratitude to Indian Medical Association Visakhapatnam to collaborate in collaborating for this CME, especially the IMA President of Visakhapatnam, Dr. I. Vani, KGH Superintendent, and also the IMA Secretary, Dr. MVV Murli Mohan sir, and APMC Observer, Dr. Malladi Sharma. So, and the entire leadership team for partnering with us and making this an elite accredited scientific reality. To our extraordinary faculty, speakers, panelists, and moderators, you are the beating heart of this conclave. Thank you for flying in to our esteemed guests from Chennai, sharing your life's work and pushing the boundaries of quaternary care. A special shout out to the internal organizing committee, our staff, from the scientific team to our logistics, the AV crews, the operations team, who work tirelessly behind the scenes to keep our tight timelines flawlessly on the track. Our deepest appreciation goes to our pharma and industry partners. Your robust support ensures that the wheels of medical education and clinical innovation keep spinning. Thank you to Sun Pharma Cardiac Dimension, Sun Pharma Gastro Division, USV, Medtronic, Alembic, MSN Laboratories, Linux Laboratories, Lupin Cardiology Division, Lupin Semanics Division, Glenmark, Renovate, Merck, Celera, Eris, Genova, Newgenics, Hexagon. And finally, to you, our incredible delegates who have been there since morning, thank you for your electric and intensifying energy, your thought provoking questions, and for standing with us from the early morning registrations right up to this final session. You are the true reason this conclave is a resounding success. Before you head out to celebrate this evening, please ensure you sign at the registration gates to claim your 2 credit hours. Thank you all. Keep defining the frontier of care. Uh, Drive safe and have a wonderful evening ahead. Thank you.